paper in International Journal of Stroke, and this is far more severe, and this is related to age and hypertension as well as diabetes. So that is one robust paper coming out of India as far as one comorbidity is concerned. But I would like to certainly see more papers.
Yeah, Dr. Manisha, over to you.
Yeah. See, I would like to thank Dr. Mishra for such a in-depth analysis of this very burning and really important topic. And as a physician and diabetologist, we have to deal with this problem in coming year, maybe months or maybe a year when the COVID is going to be there. I would like to share here one experience of mine that I have seen young boys and two or three boys having pancreatitis of age of 15 to 17 years. So they presented with fever and all those things, and along with their severe pain in abdomen, and found to have acute pancreatitis with COVID. So COVID is definitely affecting pancreas, though they did not have diabetes, all these three boys, but they had acute pancreatitis. So what is your comment on this? They did not have diabetes.
Uh, Sorry, I was reading some of the question answer. Can you repeat the last one?
See, I have seen a few patients with acute pancreatitis.
Okay.
Yeah, even young boys like 14 to 15 years old, three patients we had seen with acute pancreatitis and few adults also. But nobody had diabetes along with that. I mean, they did not develop diabetes.
These patients had COVID-19.
Yeah, with
Okay,
COVID-19.
that's a very important question and very good observation, Manisha, because the 2010 coronavirus paper, which looked at the ACE2 receptor on the pancreas, and then subsequently around 17% have pancreatitis, which is not very severe actually. It is mild pancreatitis, and
Yeah.
whether it's a good enough destruction to cause the hyperglycemia to occur is
Yeah.
anybody's guess.
Yeah.
But there is some patients, definitely very severe destruction is occurring, like two patients described by Shafi Kuche. And interestingly, Shafi is also has sent another paper on the same patient. I'm sure Ambrish knows that. Same patient, that these patients presented with ketoacidosis, and
Hmm.
within 6 weeks they were, after being on very heavy doses of insulin, they were converted to oral hyperglycemic agent without any problem. So initial destruction, whatever it is
Yeah.
possibly recovering over a period of time, but these data are very small. And
Hmm.
unless there is a larger case series, I will not be able to tell you more.
Yeah.
Sir, I have a question. What about the type 1 diabetics? Do they also have an increased mortality because they are younger? And most of my type 1s developed COVID and sailed through. But data from England is different, UK, US. There were lots of type 1 diabetes patients also. Mortality was higher in type 1. So, what is your take on this? What about type 1 diabetics?
I feel that type 1 diabetes who have a long duration may be having a higher mortality than type 1 diabetes who have a shorter duration. That's one thing very clear in type 1 diabetes, that 5 years nothing occurs. No macrovascular complication occurs, and only after 5 years it starts. So the effect of glycemia over the system in younger patients may take longer than a type 2 diabetes who is 50, 60 years, where even a short period of hyperglycemia or at admission hyperglycemia lends a higher mortality. So I would say they will be somehow protected because of the age. However, if it's a 15 years of type 1 diabetes and uncontrolled, probably will have a higher mortality. This is what my take is.
I think
There are a couple of questions here. I would like to answer some of them. One question, Dr. Luthra has said that in patients with acute pancreatitis, which I presented with a GLP-1 agonist was given. No, there was no GLP-1 agonist, and not even gliptin was being given. The second thing is, somebody said that how should we give patients sitagliptin and high dose of metformin? Yes, why not? I mean, I have no idea whether it is going to protect or not, but if a patient develops COVID-19, likely mortality will be less. This is what the data says. Somebody said that the low oxygen levels and we can still give the metformin. I would say no. And depends on how much low is oxygen. If it's less than 90, certainly I would take off all drugs and put on insulin. But if it's hovering around 94, 93 and patient is feeling fine and things, you will continue for a while and just look out for a lower oxygen level. Then there was another paper, another question.
One point I would like to highlight here, that as far as patients we have seen that in hospital patients, they are highly uncontrolled on diabetes and they require very high doses of insulin. Like every patient, we have to give long acting insulin also along with the short actings. And what I would suggest that we would not try to, get the sugars too down, because these people are not having proper food. Sometimes they have vomitings, loose motions and all such kind of things also. So we would like to keep it around 200 and 250 maybe, but not below
I
that.
would say, we keep it around 180, 200 and not let hypoglycemia occur, because the testing is going to be a problem. And somebody, before Ambrish has put his hands up, just one answer. Somebody said that reliability of SMBG in face of high dose of vitamin C. Yes, it is going to be a problem if patient is on intravenous 2 grams to 3 grams of vitamin C, which many people are giving. But if it's a 500 milligram of vitamin C, is not going to interfere too much. So be careful about that. If it's a small dose of vitamin C, you can do SMBG
Yeah. So Dr. Sharma is already, I think, we're running short of time, and Dr. Sharma has already, shared his screen. But last comment, sir, Dr. Mishra, I would just like to say, a patient is already on metformin, gets admitted and is critically ill, and there's a hypoxia, I think then we should stop metformin at that point of time. Not in OPD basis, but when patient is admitted and, there's a hypoxia, maybe sepsis, chances of
I've already answered that. I told you that. Ambrish, I think I would like to answer Ambrish's question.
No, it's a comment. I'll make it in my own talk then. We're running out of time. So we'll save time. Okay. Just an observation, not a question.
Yeah, Dr. J.K. Sharma.
Dr. Sharma, you are muted.
Yes. So, thank you, Dr. Vinod and Dr. Manisha Deshmukh for conducting the session very successfully, very meticulously. And thanks, Dr. Anup Mishra, for presenting such a wonderful state-of-the-art lecture. And now for the next lecture by Dr. Ambrish Mittal, I invite the chairpersons, Dr. Anil Virmani and Dr. Sudhir Sera. Dr. Anil Virmani is the chairman, Indian Association of Clinical Medicine, Jharkhand chapter. He is vice president of the Clinical Cardio Diabetes Society of India, regional faculty of number of schools, chairman, scientific committee, API, CSI, Jamshedpur chapter, past president, RSSDI, founder member of Clinical Cardio Diabetes Society of India, speaker at national, international conferences, trained more than 100 doctors in diabetes, is consultant physician and cardio-diabetologist at Jamshedpur, Jharkhand. I welcome Dr. Anil Virmani to the conference. To co-chair with that, Dr. Sudhir Sera, who is a fellow of Diabetes India and fellow of Royal College Physicians, Edinburgh, chief consultant, HOD Medicine at Sri Balaji Action Medical Institute, ex-tutor, PG Diabetes, Teaching University of South Wales, chief consultant, teacher and guide to DNP medicine program, more than 35 years of experience with special interest in diabetes and critical care. Numerous peer-reviewed papers in national and international journals and speaker at many national conferences. So now I request both these chairpersons to please invite Dr. Ambrish Mittal to deliver his talk and introduce Dr. Mittal.
Good morning, friends. It's an honor to introduce the speaker, Dr. Ambrish Mittal, who needs no introduction. In fact, he is the doyen of endocrinology in India. He is a Padma Bhushan and BC Roy awardee. He is the chairman and head of endocrinology and diabetes department in Max Healthcare, PanMax, a group of 16 hospitals. He is the domain expert in government Board of National Health Authority 2019 of India and president of AIMS Gorakhpur. Recently was presented the Laureate Award from Endocrinology Society of US for International Excellence. Dr. Mittal has been recipient of Fugatri Fellowship, Harvard Medical School, Japan International Cooperation Agency Fellowship, Boyframe Awardee of the ASMBR of IOF Amgen Health Professional Award, and Springer Citation Prize for his paper on global vitamin D status 2013. He received the IOF President's Award 2016. His current research interests include vitamin D nutrition, primary hyperparathyroidism, osteoporosis, cardiovascular outcome trials in diabetes, and that goes here.
Nash.
Nash goes here.
I don't know. Goes here. I don't know. That's some
So,
autocorrect.
In fact, Dr. Ambrish needs no introduction. He is one of the best speakers I've ever heard in national and international conferences. Over to you, Dr. Ambrish Mittal.
Thank you, sir.
Sir, please share your screen.
Yes. Yes. Is it visible?
Yes.
Okay, so in a complete shift from what my friend Anup was talking about, something I spoke about yesterday, or day before yesterday, he spoke about today, and amazing data on COVID-19, but I do make an appeal for people to generate more data from India, in this more quality data from India, and that is really important because we are heading to be probably, unfortunately, the epicenter of the epidemic, and if we don't provide good data and good guidance to our colleagues, it's not so great. Just two comments. Number one is, for all protocols related to diabetes, there is a Ministry of Health website or an AIMS website where there are very good protocols for inpatient management of hyperglycemia during COVID times. So all physicians can access them. It's free for all. You just click and you do Google search, you'll find it immediately. Very important for our clinical day-to-day things, because people are getting confused. Second is that in our own experience, where we are not yet published anything, but just finished the analysis of 413 consecutive patients of admitted for COVID. So moderate to severe, about 7 or 8 were mild, but 38% had diabetes. So moment you're looking at hospitalized patients, the proportion of people with diabetes goes up dramatically. And this is done little later in the course of COVID. Initially, a lot of people were getting admitted who had very mild symptoms. Later on, that stopped. So, and the outcomes were clearly worse. The other thing, one line before I move to this, is that not only is managing the diabetes there inpatient very tough, because the insulin requirements are astronomical. I have not seen even one hypoglycemia so far, just sharing my experience. And after discharge, it takes good 4 to 8 weeks, and in some patients almost 12 weeks to come back to where you were, even if you started with an HbA1c of 6.5. You know, a combination of COVID and steroid is really throwing the sugars off. It requires a lot of care. So the role of endocrinologist, diabetologist, physician in COVID, other than the infectious disease specialist, is also very important in the long-term outcome of these patients. Moving to my talk of GLP-1 RA and type 2 diabetes, and now this is like GLP-1 RA and type 2 diabetes is like a book. So I just chose two aspects because the title said From Leader to Rewind. And I will look at just these two studies and see what lessons they have for us clinicians. And I think that's the only purpose of this topic, is not to discuss all the mechanisms of GLP-1 RA. We can do that separately sometime. But the idea is to see what we can learn from these studies, how have they affected and how will they affect our clinical practice. So we, just to start to get the ball rolling, we know GLP-1 is an incretin with multiple effects on human physiology. We know that it's secreted by the L cells of the pancreas, and it is degraded by DPP-4, and hence DPP-4 inhibitors are used to treat diabetes because they enhance the action of GLP-1. And it has, in a very simplified way, adapted this from Drucker actually. If you look at the pancreas, which is still the main site of action, you will find that there is increase in glucose-dependent insulin secretion, the key word being glucose-dependent, overall increase in insulin synthesis, and reduction in glucose-dependent glucagon secretion, which is equally important in their action. And the liver, of course, there is issue about glucose production reduction. Heart, there is some degree of cardioprotection. There is a positive inotropic effect, but there's also a positive chronotropic effect. There's a slight increase in heart rate. And of course, we know that the stomach effect on reduction of gastric emptying is very marked and profound, and sometimes can be a source of significant side effects for these patients. and of course satiety. So there's a simplified action of GLP-1 that really explains to us how these drugs act, primarily on the pancreas, but also on the brain and stomach, and to some extent on the heart and liver. But today we will focus on the heart and see how that has impacted our clinical practice. There's a lot of mechanistic theories about effects of GLP-1 based on some interesting in vitro and animal studies. Definitely, well, there are human studies also on GLP-1 infusions following MI, etc. But I'm not going into that. But overall, the direct effects of GLP-1 are to improve endothelial function, reduce intracellular adhesion molecule, reduce vascular cell adhesion protein, increase nitric oxide, reduce vascular smooth muscle cell activation and proliferation, reduce vascular inflammation, reduce lipid accumulation. It sounds like a dream, but yes, they add on. They add on to these effects which are brought about by other therapies. Overall, the direction of effect of GLP-1 is on the positive side, even mechanistically, on the heart and vascular system. The only negative impact, as I said, is a slight increase in heart rate. And while it's doesn't commonly impact the outcomes, but there are one or two patients out of 100 who will get stuck because of a slight increase in heart rate. Overall, it's not a huge clinical impact. As I told you, GLP-1 itself has been used as infusions in cases of heart failure to actually improve the pump function of the heart. Now, we won't go into the story of CVOTs. You probably hear them 3 times a day and maybe 9 times a day on a weekend. So just that there's a whole lot of CVOT story. We know how the story started. We know the story of rosiglitazone. We also know that CVOTs became mandatory. We also know that CVOTs actually translated from safety trials to benefit trials. And on the one hand, the studies were basically designed to look at safety of these molecules, proving their safety for the heart. But later on data in 2015 onward, the scene changed, and we have 2 groups of molecules, the SGLT2 inhibitors, about which I'm not going to talk today, and the GLP-1 which have actually hit the sweet spot in the sense that they are not just cardiac safe, they may actually be beneficial for the heart in terms of reducing adverse outcomes. Let's go through that. These are the numerous, already the GLP-1 studies, and I'm not going to cover all the studies. I'm only going to talk about 2 studies. The 3 interesting studies in this are LEADER, REWIND, and of course the SUSTAIN study. Now, the thing with SUSTAIN and PIONEER is that they are with semaglutide, which is fascinating, and the SOUL study is ongoing right now. Amazing data, but again, semaglutide is still not here for us. So for us as clinicians, we have to basically look at liraglutide and dulaglutide. And there we are looking at freedom. We are looking at LEADER, and we are looking at REWIND, and that's the title of the talk given to me. So what is the real story of LEADER study? Solid study, 9,340 patients, double-blinded, 2-week placebo run-in. Liraglutide 0.6 to 1.8 depending on level of tolerance, plus standard of care. Other is placebo plus standard of care, and a good duration, 3.5 to 5 years, and then safety follow-up another 30 days. So the key inclusion criteria here are the type 2 diabetes, HbA1c more than 7, obviously, anti-diabetic drug naive, could be on OADs, could be anything. So all kinds of diabetes were included in LEADER. The important part is that these patients had established CV disease, or if they were over 60, they had numerous risk factors for CV disease. So either established CV disease or chronic renal failure, if over 50, or over 60 with risk factors. So they were all middle-aged and older patients, and they were at high risk or had established CVD. Bulk of patients had established CVD in LEADER. So this is a high cardiac risk population you are studying. And the exclusion were the usual exclusions. Obviously, you won't use it in people who have MTC or family history, or who've used GLP-1 and type 1 diabetes. The important point is very broad spectrum study, including all kinds of diabetes, but with high cardiac risk or established cardiovascular events. So I think this is important, because when you're looking at an event-driven study, which CVOTs are, it is important initially at least to look at very high risk subjects so that you get outcomes which are very clear. You get enough number of events so that you can discriminate between the molecule being tested versus placebo. And the primary outcome was the classic MACE, time to first MACE, CV death, non-fatal MI, non-fatal stroke. All of you know this by heart. There were secondary outcomes, a slightly complex expanded composite CV outcome, which included these three: CV death, non-fatal MI, non-fatal stroke, but also included CV death, non-fatal MI, also included coronary revascularization, unstable angina pectoris requiring hospitalization, or hospitalization for heart failure. It included, and then there's a separate one which is all-cause death. And very interestingly, each individual component of these. Now, when we are looking at this data, you have to understand these studies are essentially powered to answer this question. And everything else is a suggestion, and maybe it'll be proven to be correct or not correct, but it gives you a direction in which to carry out research. Sometimes we get carried away by subgroup analysis and by little fragments of every study, hair splitting everything, which is interesting academically, of course, but it may not translate into our clinical practice. The clinical practice outcome will be the primary outcome here, right? We may want to see what drove the primary outcome, in the sense that if you look at each of these separately, we'll be able to say, well, this is why the primary outcome was skewed in this direction. So let's look at that. It's a global trial, and there were some people from India also in that. The baseline characteristics, we already told you about the age. All patients were over 50, so 64, good 3,000 subjects in each arm. The baseline A1C was 8.7. So these are typical clinic patients who come to you with 8.5 HbA1Cs, and they were generally, like in the West, primarily almost all type 2 diabetes are overweight or obese. So 32 was the basal BMI. So this is the profile of the patients, and we don't have to labor this, but let's look at this part. Now, this is the placebo arm. We're looking at the primary outcome, a composite of CV death, non-fatal MI, non-fatal stroke. And this is the liraglutide arm. And this is a period of time from randomization, which is more than 4 years. If you look at this, you find that the hazard ratio for the liraglutide arm was 0.87. P less than 0.001 for non-inferiority. So one chapter is closed. Liraglutide is not unsafe for the heart, but also a P of 0.01 for superiority, just sort of touching significance, well, little more than significant, but nevertheless, something that could be translatable into clinical practice, that the primary outcome of MACE, 3-point MACE, was improved, was better in patients who put on liraglutide. And the hazard ratio was not like 0.5 or something, but definitely 0.87 on top of statin and other standard care is quite significant. And when you look at each of these individual components, and that's interesting, the time to CV death was hugely impacted. Okay, time to see, this was 0.01, this is 0.007, and the hazard ratio here is 0.78. So out of the three components, death is the most non-controversial and hardest component. And in that, with liraglutide, the hazard ratio was 0.78. I think that is significant. Okay. If you look at overall numbers, they may not seem so impressive. Okay. If you look at 4,668 patients here, 484, 4,672, 465. The numbers don't look so significant in a large sort of population, but nevertheless, it was statistically significant, and it is important to keep this in mind. 22% risk reduction versus placebo. So this is the patients who continued to be in the trial. Okay, this is the patients who continued to be in the trial. But this is how we are. This is the hazard ratio. Now, what is the time to, let me show you one more thing. Is it here? Okay, we'll omit that. We'll discuss it later. When you look at time to non-fatal myocardial infarction, you find that there is a difference between placebo and liraglutide. Again, the liraglutide had better outcomes, but if you look at just MI, non-fatal, the hazard ratio is 0.88, yes, but the p-value is not significant. Whether this is simply because the study was not powered enough to look at individual components, or whether non-fatal MI was really not impacted too much. And look at this. So you're talking of 12% reduction, but the p-value is not significant. Non-fatal stroke, again, nothing. 11% reduction, yes, trend is encouraging, but the hazard ratio is 0.89. So what does this show? That the 3-point MACE that was superior in liraglutide was actually driven largely by CV death, and also obviously then all-cause death was significantly impacted. So if you look at the p-values here, it's important that you realize that individual components only CV death was significant, and the number needed to prevent one MACE was 66 for 3 years. 104 for 3 years for CV death and all causes. So if you look at overall MACE, 66 patients for 3 years. Remember, when you're using Victoza or Trulicity or Eplivant or whatever, to prevent one MACE, you have to treat 66 patients for 33 years. That reality has to be with us. Our patients often go off the drug after 6 months, 1 year, whatever. So if you're really looking at a CV benefit, you have to use it for longer. And look at other GLP-1 RA trials, if when try to compare with Alexa, Leader, Sustain, Excel, Harmony, lixisenatide, semaglutide, exenatide, albiglutide, you find that most of them had prior CVD in a very high proportion, right? 75 to 100% had prior CVD. The mean age was somewhat similar. Sustain was a little younger. The point I'll make here without going into in depth is that with lixisenatide and exenatide, there seem to be not much benefit. So it seems that GLP receptor agonists that are GLP-1 analogs like liraglutide, dulaglutide, and semaglutide may actually be more cardioprotective than those that are exendin derivatives like lixisenatide and exenatide. So lixisenatide exenatide group does not seem to provide the same kind of cardioprotection as lira and semaglutide do. And if you look at these studies, this meta-analysis of MACE, just look at Leader and Sustain, which showed remarkable results. Again, Leader we already spoke about, and Sustain is semaglutide study, which again showed fairly significant impact on patients with established atherosclerotic vascular disease, but did not show so much impact in patients with who just had multiple risk factors. So patients who were seriously sick or had significant CAD or existing established CVD, they were the ones who benefited the most from semaglutide and liraglutide. And yes, maybe multiple risk factors, but these studies did not really bring that out very clearly. Now let's jump to dulaglutide. So we've learned about Leader. We've learned that it was an important study. We've learned that the hazard ratio was 0.87 for 3-point MACE. This was largely driven by reduction in CV death, and the others, the non-fatal MI and stroke, did not show much impact. And the fact that these patients were sick patients, and the impact was mostly seen in people who had pre-existing cardiovascular disease. I come to Rewind, which was a big hope for the company and for a lot of us who were excited about it. Rewind being a study with Trulicity or dulaglutide, which is a once a week molecule. And we looked at, again, well, A1C less than 9.5, but on 0 to 2 oral drugs. So you could have been on any kind of diabetic, but the only difference was that more than 50 with vascular disease, more than 60 and risk factors. Here they listed the risk factors, but also more than 55 with subclinical vascular disease. This wasn't there in Leader. So they added a group of more than 55 who had some tests which showed positive stress tests, more than 50% stenosis, ABI, EGFR less than 60. So all these they added as subclinical vascular disease as a separate group of inclusion. And the primary composite was same. And the right ticks indicate the ones where the primary composite was same as in Leader, which means first occurrence of a MACE outcome, non-fatal MI, non-fatal stroke or CV death. Secondary outcomes were a microvascular composite outcome, which was not seen in Leader. Hospitalization for unstable angina. Well, there was some evidence of renal change in Leader also, but we're not going into that. But that wasn't a listed composite outcome. hospitalization for unstable angina, hospitalization or for heart failure as a separate thing. There it was an expanded primary outcome. Here they looked at each of these individually, each component of the primary outcome and total mortality. So let's stick to the ones that are common. The primary composite, the component of primary outcome and total mortality. And Rewind didn't have anyone from Asia. It was not an Asian study, but again, 9,900 people. And again, it's Trulicity or dulaglutide once a week, 1.5 milligrams versus a placebo. And here starts the important part. Prior CV disease was present in only 30%, 31%. So it was more than 2/3 in LEADER and other trials, almost 3/4, or even more in some 100%. But here it is less. So you have a less sick population. Established CV disease was present in less than half the subjects in this trial as compared to LEADER trial. The diabetes related characteristics, these patients were better controlled overall. 7.3, 7.4, they were better controlled patients. We won't go into the other things, but the part I did not show in LEADER, but which was true, was that there was in both the arms, it was not perfect glycemic equipoise. Even in this, dulaglutide's effect on HbA1c made the study arm, actually the intervention arm, have a significantly lower A1c than the control arm. And I think that's important to understand, that in both these studies, in liraglutide, the difference was 0.3, a little more than 0.3, 0.4, and here it was 0.6 or something. So in both these studies, the GLP-1 RA arm had a lower HbA1c. And while we may say that a lowering of 0.4 or 0.6 HbA1c does not have much impact on macrovascular or cardiac outcomes, it's still important to keep this in mind. And if you look at the composite, CV composite, you really see same non-fatal MI, non-fatal stroke or CV death has a ratio almost similar, but p-value is a little different here because of variation. And you find that there's a clear benefit in terms of overall CV composite outcome, but it does not outscore liraglutide and definitely does not outscore semaglutide, which actually may turn out to be the best of all of these in terms of CV protection. Effect on non-fatal MI. What do you say? Nothing. Effect on non-fatal stroke, significant. Look at the difference, 0.76 here. Effect on CV death, not all that significant. So what determined dulaglutide's effect on CV outcomes was the effect on stroke. What determined liraglutide's effect on CV outcome was the effect on CV deaths. So I think this is important to understand. And all-cause death, yes, again, but again, not really touching much significance here. So when we look at this, a Lilly slide, when they released this data last year, placebo versus dulaglutide, right? But this tells you the real story. If you look at, it is a consistent effect, yes, but here's non-fatal stroke. This is a forest plot. To the left means it favors dulaglutide, to the right favors placebo. So dula was on the left and everything as expected. But a non-fatal stroke, CV death, non-fatal MI, all the bars are crossing the midline. So it was non-fatal stroke that drove this benefit. So it seems that the major effect was on stroke. Again, the study was not powered to look at each of these points individually very well, but nevertheless, MACE reduction significant, non-fatal stroke reduction significant. The number needed to treat to prevent one MACE was 66 over 3 years in LEADER, about 72 over 5 years in Rewind. So if you're looking at using dulaglutide to prevent one MACE, you will have to give 72 patients dulaglutide for 5 years. So keep that in mind. I mean, it's all good to realize the value of these drugs, how they're adding, also at the same time to keep a perspective as to how much expense you want to put the patient into and how you want to deal with it depends on the patient. Primarily driven by non-fatal stroke. So the difference here is that this is the previous, again, that slide showing prior CVD in most patients, 81% in LEADER, which is the main one we are comparing with. But when you look at rewind, you find that the participants were similar to the sort of ambulatory patients with type 2 diabetes and CV risk factors who are routinely seen in clinical practice. So if you work in a large cardiac hospital like I used to, and even now seeing a lot of cardiac patients, you actually are going to see much more of leader type of patients. If you're working in a clinic and an OPD setting, you're going to see more of rewind kind of patients, which means rewind, like the DAPA studies there, included a lot of patients who did not have very high CV risk and yet seem to show a benefit. And maybe that's the reason why the benefits are not so striking in the CV events, and especially in CV death, because you don't have enough patients who are sick. And this will give you an idea of the difference of how sick the patients were. One of the best ways, and I love this, I've always asked the trialists to share this data, which is usually not shared in the initial paper, but is the placebo MACE rates. If you have a high placebo MACE rate, then that means sick population, right? That is a proof. So leader is 3.9, rewind is only 2.7. When you have low rates in the placebo, overall rates are lower, and therefore the differences may not be so evident, right? This is proof of the sickness of the population. Alexa and Harmony had the sickest patients. And coming to the last 2 minutes of my talk, we know that based on all this, there have been changes saying that people who are at high risk should be put on possibly GLP-1 or SGLT2 right at the beginning. The ESC even says right at the beginning, even before metformin. But most guidelines now say that people who are at high risk should have one of these groups added after metformin. Those who are more at risk for heart failure and renal disease probably should be going for SGLT2. Those who are more at risk for CV event should possibly going for either GLP-1 or SGLT2. Now, one of the questions that often arises in the clinic, and I've just put this slide, and I'm sure you're aware of this, but very many times we are not able to distinguish this very clearly in a busy outpatient. This is a very simple way of looking at very high risk, and moderate risk. Very high risk is patients with diabetes and established CVD or established CKD or retinopathy, very high risk. High risk are those more than 10 years duration, but no target organ damage. But other risk factors, hypertension, smoking, whatever. Moderate risk are those young patients and duration less than 10 years without risk factors. Very easy to do in your clinic. And I think instead of going for all the scores that people talk about, which don't know how applicable they are, the Framingham and other scores in India, very high risk, high risk, high risk. Very high risk, established CVD, established target organ damage, more than 10 years diabetes, but in any case, you have established organ damage. High risk is more than 10 years without established organ damage. Moderate risk is younger patients and with no target damage and duration less than 10 years. So this is the way we look at it. Very high risk, and moderate risk. There is no low risk in diabetes. And you've seen this slide many times, but all I'm saying here is that SGLT2 or GLP-1 RAs are recommended in drug-naive patients, those who have ASCVD or very high risk as first line therapy also can be considered. This is especially true of European Society of Cardiology recommendations. And there is some logic to it. You can't completely dismiss that. And definitely they are recommended for patients on metformin with high CV risk or with established disease, irrespective of the HbA1c, right? And therefore, when you choose glucose-lowering agent now, you know that very well, you're looking at preventing heart disease, and definitely in people who have established heart disease, your choice of therapy will tilt towards GLP-1 RA or SGLT2. And now, of course, more and more for CKD also, especially early CKD, there is a huge thing about using SGLT2 earlier in the course of disease. That's a separate talk and a separate story. So again, you can also consider them in those without established CVD, but with very high risk indicators, as I already showed you. And last two slides, sorry, we'll just quickly show you. I can't resist showing this, that the lean study, which showed that liraglutide not only works for the heart, and you know about kidney data also, but there was clearly resolution of NASH with liraglutide, right? And dulaglutide in NAFLD in our own study, first author Shafi Kuche, which actually showed very clearly a reduction in liver fat. in NAFLD published just a month or two ago in Diabetology. So where we tried to say that using dulaglutide in open label study, using no placebo versus standard of care, there was a significant reduction, a difference of 26.4% between the standard care and dulaglutide group in the liver fat. And I think that's really important data, and we don't know how it pans out. We also don't know whether this is anything specific or just overall fat reduction. We can't prove that at the moment. But this is what the D-lift study, as Shafi likes to call it, shows that dulaglutide treatment reduced liver fat, reduced EGD levels, and did not have so much impact on liver stiffness in this, and did not have much impact on pancreatic fat. Thank you very much. This is part of the group that moved from Medanta to Max just a few weeks before COVID breakout and stopped us all in our tracks. And there's a much bigger group actually at Max, bigger than this. And we were waiting for the photo shoot, which was scheduled for end of March. But before that, COVID got the better of us. So we're going to come back with the larger pictures and the whole group. This is just the part that moved from Medanta. Thank you very much.
Thank you, Dr. Ambrish, for a wonderful and lucid talk. To set the ball rolling, let me ask you one question.
Yes.
Recently, there has been a lot of conflicting data regarding the efficacy of GLP receptor agonists in Asians, whether they work better in Asians or they work similar as they work in whites. What is your opinion regarding?
I know. I mean, the thing is that you want my opinion, or my opinion is that we are jumping the gun. My opinion is that the numbers are too small, which is at the end of every opinion, you will read that 3-4 lines are written there always, that while it is there, but we need dedicated studies. So I think by and large, let me tell you one thing. So far as drug action goes, I really am not convinced that there is a big difference in drug actions between Caucasians and South Asians. And, you know, most South Asians have not been able, we've not demonstrated any clear-cut genetic difference. We are more like Caucasians than like the Mongoloid races or the other races. Remember that. We are not like East Asians. So either we have our own data, which a lot of people are Mohan and Anup and others are trying to gather, or we follow the Caucasian data. So at the moment, I'll say yes, there are some discussion points, but I don't think there is any real difference.
And do you agree with the fact that even in patients without ASCVD, GLP-1 receptor agonist should be used before insulin?
Okay, I'm an endocrinologist, sir. So my issue is I love drugs that make my patient lose weight and don't cause hypoglycemia. So I am a big user of GLP-1 and I will continue to do so. I might get additional benefits in terms of reducing CV events. I'll be very happy. I might get additional benefits in terms of reducing even albuminuria. I'll be very happy. And if it turns out that they are doing very well for that, nothing could be better. But I will continue to use them for the simple reason that they help my patients lose weight, and the kind of environment I practice in, almost everybody is overweight or obese in Delhi corporate hospitals, right?
Dr. Mittal, there are no further questions, but I am forced to ask you a simple question. We take cardiovascular disease as one entity, and yet in the subgroup analysis, there is difference in all-cause death, non-fatal stroke or non-fatal MI. If this is one entity, why there should be differences in subgroup analysis? And isn't this a 5-year period or 3 to 5 year period too small for a cardiovascular disease trial? Because atherosclerosis takes years. Maybe there's a foot amputation, there's a peripheral artery disease or so, which might take 10 years or so. So your comments regarding that? I think his
Activity is lost, I think.
yeah, he's lost the connectivity. Okay, I thank Dr. Ambrish Mittal for his wonderful talk, and I hand over the mic to the organizers. Dr. J.K. Sharma, please.
Thank you. Thank you, Dr. Sudhir and Dr. Anil Vermani and Dr. Sudhir Sera. Am I audible, sir?
Yes, yes.
So thanks for the wonderful conduction of the talk. We are thankful to the industry partners for having educational support from AstraZeneca, Lilly, Sun, USP, MST, and Boehringer Ingelheim. Now, for the next session, I invite my friend Dr. Sujadeep Sen Gupta, who is MD Medicine, Fellow of Indian College of Physicians, Royal College of Physicians, Glasgow, and is a Fellow of Diabetes India. He is a consultant in internal medicine and diabetes at National Heart Institute and BM Specialty Clinic. He has lot many PG diplomas and PG certificate also. And to join Dr. Sen Gupta, I invite my another friend, Dr. Vipul Gupta. Dr. Surjadeep Sen Gupta is the person behind sanctioning all the budget. He is the treasurer, not only for this conference, for last 3 years continuously. Thanks, Dr. Sen Gupta. Dr. Vipul Gupta is founder and medical director of Gupta Ultrasound and Heart Care Center since 1997. And he has been awarded the Legend in Internal Medicine 2017 trophy from Times of India. Completed MBBS MD from PGIMS Rohtak, tutor of NEDP program in the field of diabetes, executive council member of Delhi RSSDI, and more than 20 publications. So now I hand over the proceedings to both my worthy friends, Dr. Sen Gupta and Dr. Vipul, to invite Professor Zargar, who will speak on 100 years journey of insulin, which is going to be very, very important. So Dr. Zargar to be invited. Dr. Sen Gupta, please.
Yeah. Thank you, Dr. Sharma. First of all, a very warm welcome to everyone for attending this annual conference of the RSSDI Delhi chapter. And very important session this one is. As we know, friends, that insulin remains the cornerstone of therapy across all spectrum of patients, and in complications especially, it is the only one of the last, go-to kind of medications. And though the format of insulinization has changed, has not changed much over the years, but there has been significant technological advances in the, in the formulations of various insulins. And no one better to dwell on this huge evolutionary journey over the last few decades than Professor Abdul Hamid Zargar, one of the pioneering endocrine doyens of the country. And it's my proud privilege to invite him. He has had a ringside view about the development right through, because he is one of the earliest DM endocrinologists of the country. He is the member of the high-powered committee of the Vision 2035 Health and Medical Education of the Government of India, chairman of the Independent Ethics Committee of Fortis Hospital Research and Research Center. He is also the past president of the Endocrine Society of India. Formerly, he is the member of the Medical Council and member of the Institute Board of AIIMS New Delhi, and also the ex-chairman Department of Endocrinology Director and ex-officio Secretary to the Government of Kashmir, Sher Kashmir Institute of Medical Sciences. My proud privilege to invite Professor Zargar, sir. Please go ahead, sir.
A very good morning, and thank you very much for this invitation. Always a pleasure. I always have thought, and many people believe I live in Delhi. Whenever people, invite me, in many of my those invites, Dr. Abdul Hamid Zargar bracket mein Delhi likha hota hai. I feel so much at home in New Delhi for decades and decades and decades. I think, I'm grateful to Dr. Sharma. He asked me to talk about this 100-year journey of insulin. We heard just now two very wonderful talks from two very wonderful professionals. But those are the things that we discuss every day, literally every weekend. When I was preparing for this talk and looking at the data and accumulating the data, what amazed me that the things that we take for granted today, Dr. Sen Gupta have not taken decades, have not taken centuries, have taken many thousands of years. And it really has a potential of humbling a person. That every time your head bloats, how good you are, what you do. And when you realize what people have done to ensure that we are where we are, it humbles you down. And that's what an honest assessment of history does. That's what an assessment we get from this.
We value is a little different here.
Just look at what we are going to walk through. Thousands of years before 1921, which was a milestone when we thought insulin was discovered. 100 years after 1921, and era after 2021, what do we anticipate if we extrapolate from the past? All of us know, if you look at the data, even before the Jesus Christ, 500 years before the Jesus Christ, there was a mention of diabetes in Egyptian scriptures. And in ancient India and China, there was a description of diabetes. And Aratus from Cappadocia, which was then in Greece and currently is in Turkey, created the term diabetes. And more than 1,500 years back, Indian physician Sushruta and surgeon Charkha talked about this disease then known as Madhumai. The thought process started centuries back. It was in 19th century when Claude Bernard discovered the glycogenic action of the liver, and Oskar Minkowski and Joseph von Mering recognized that diabetes is disease of the pancreas. This is the study that these two great guys in 1889, Oskar Minkowski and both German guys, that if you remove somebody's pancreas,
Diabetes is
a person will develop diabetes. And then Eugene, quite some time later, half a century later, found it is not the whole pancreas which is responsible for it. There are different segments of pancreas, and he identified islets and said, whatever is happening, the pathological process originates from islets. So from the whole body to pancreas to islets, the disease was identified. And then ultimately it was Banting, Best, MacLeod, and Collip who tried to get those pancreatic extracts which are liable to have that insulin-like activity, which ultimately would take care of diabetes. And all of us have seen this over ad libitum times, that Leonard Thompson was the first patient who received insulin, a 14-year kid who was 30 kgs only. And then in that particular period, in that initial period, they experimented with 6 individuals. And this is one of the girls, on the left side, before and after she was treated successfully with insulin in 1922. And this is when this saga of insulin discovery culminated, but the process had started long back, zeroing into the pancreas. Now, when these guys were granted Nobel Prize was given to Banting, MacLeod, and Collip, not to Best. And Banting was always disgruntled on this, that MacLeod did not deserve it. His contribution was not much. It was Best who was. And during the Nobel Committee, he said, I'm sharing my Nobel Prize with Best, who was a student, 8 years junior to him, lived for 3 decades after him. And he shared it with him as he should be given equal credit. But the Nobel Committee did not recognize him. And this Toronto group, that's where this Banting and Best's team and Collip was a chemist who was responsible for those extracts. And Banting was himself a surgeon. And MacLeod was the guy, whose lab they were working on. And they professionally connected with Eli Lilly, who developed a method of precipitating a purer form of insulin from bovine and porcine sources. And it was in 1923 when in Copenhagen, a non-profit organization known as Nordisk also wanted to rights make insulin in Europe. And by the end of 23, a good part of the Western world had those primitive insulins that we have known.
In Copenhagen, a non-profit organization known as...
Now, in the same Novo lab, Hasdon was the person who was working, the middle guy here, who from these bovine and porcine sources from which this raw insulin was obtained, wanted to change it in such a fashion that its half-life could be increased, because otherwise the half-life of insulin was whatever is the half-life of crystalline insulin, the endogenous insulin. And he ended up in formulating this neutral protamine Hasdon insulin, also known as isophane. So from those bovine and porcine insulins, we started getting longer-acting insulins, the conventional longer-acting insulins, protamine, zinc, isophane, neutral, or NPH, and then a barrage of lent insulins, different forms of the insulins. Everything changed with this guy, whom we as endocrinologists and diabetologists do not remember much. Professor Frederick Sanger. He is the person who actually isolated the molecule of insulin and showed us its different structure, its amino acid sequence. And with his work, we started the specialty of proteomics, and on his work, he was awarded a Nobel Prize in 1958. And extrapolating that work into developing radioimmunoassay, Rosalind Viello, who was working in a hospital in New York, was awarded Nobel Prize 2 decades thereafter. What ways this created was that now we knew the structure of the insulin molecule. So now in molecular biology labs, people started experimenting with this molecule. Now, conventionally, for 3-4 decades after 1921, we only had bovine and porcine insulin, and we also knew how to convert it into a longer insulin, like NPH insulin or lent insulins. And knowledge of the molecular structure changed that thought process when first time in 1982, Lilly introduced genetically engineered human insulin. Then when you use Escherichia coli, a bacteria and a yeast, the DNA of that to replicate the DNA that gives rise to insulin. Now, for the first time, the time had come that you could create insulin ad libitum in the lab. But it had to go through many trials and tribulations before it would reach a stage where it would go to the market. When this recombinant DNA technology was introduced, with time, what molecular biologists, what chemists started doing, they started looking at those amino acid sequences in the insulin molecule that were actually responsible for tagging to the insulin receptor. They were also looking for the site which would be susceptible to those enzymes which we can collectively call insulinases, that would destroy this insulin, that has the potential of degrading the proteins or polypeptides, so that those sequences can be blocked or substitutions could be put in those areas, and accordingly, the half-life of these molecules can be changed. And it was for the first time in 1995 that Eli Lilly created a short-acting insulin. Till that time, we had a regular insulin And then we had a short-acting insulin in the form of Lysipro, which was we can call it a insulin designed in the lab. So they started being known as designer insulins. Aspart insulin in a similar fashion was created in Novo Nordisk lab, short-acting insulin, and in a similar fashion, glulysin in Sanofi labs started getting made. Now, this was giving us now from crude extracts to bovine porcine insulins to NPHs, now then human insulins from the Escherichia coli, and now redesigning the sequence of this insulin, we got quick-acting insulins. And then over a period of time, scientists in the labs restructure these molecules to change or the sequence of these amino acids or alter them in such a fashion that they work in the circulation for a longer time. They remain in the intravascular compartment for the longer time. And the breakthrough came when glargine was found. And then thereafter, Novo Nordisk again came with the longish insulin, Datimar, and both of them were a huge step forwards from NPH and Lent insulins, and a new era of basal insulin had come to the fore. Then over a period of time, in another decade, Novo reached another milestone when it created a genuinely more than 24 hours half-life insulin that was Degludec. So on the one hand, the shorter insulins were getting crisper, longer insulins were getting wider, so that, a true basal insulin could be created, first from an NPH, then Lente, which actually were 18 to 24 hours unpredictably, and then Datimar, which was 22 hours, 20 hours, glargine, truly 24 hours, and then Degludec, which was more than that, almost 36 hours, so that, it truly would give a steady state in the 3 days. So from that crude extract, from that point of identifying that pancreas creates this, then identifying that there's a different cell that creates it, we had come to a stage where this was being made in the laboratory, and you would determine that what sort of an insulin you need in the market today for our own patients. So when Tresiba was launched in 2013, a combination with Aspart was launched in 2014. Toujeo, which is a more concentrated form of glargine, was launched in 2015. And ultra-short-acting insulin, a more refined version of Aspart, Fiasp, was launched a couple of years back. Today, people are working on a molecule known as insulin icodec. And the way we have today, if you remember, Amrish was just now talking about GLP-1 receptor agonists and cardiovascular disease. In fact, GLP-1 receptor agonists came to the market much before DPP-4 inhibitors, axinatide. The problem was it was injectable. The problem was it was shorter acting. You had to go it more than once. And then came liraglutide, which was once in a day, or lexinatide, which was once in a day. Then dulaglutide, which was formulated in such a fashion that you could give it once in a week. So in a similar case, situation is changing vis-a-vis insulin. That this particular molecule, I'm sure in next couple of years, would be reaching phase 3 clinical trials if it goes initial experimentation very well. So we might have a genuine insulin that is a basal insulin, which is weekly, the way we give dulaglutide today, which is weekly. And not only that, now already, people have started combining, looking at the benefits of GLP-1 receptor agonists. Basal insulins and GLP-1 receptor agonists. We already have marketed, approved, FDA-approved, DCGI-approved combinations that are available globally today and are likely to be available in the Indian subcontinent. Now, recapitulating, look at this. I'm saying, like, This would tell you and me how fortunate we are today. This is the vial that was available there. And I tell you, when I look at that iletin, you'll be amazed, though, our institution was the last institution where Eli Lilly supplied this iletin. Because at that given time, this iletin would cost 80 rupees. And Eli Lilly would give it to our own institution for 60 rupees. And they wrote a note to me once that said, we are stopping this iletin formation. But if you want some, we can create some supply for you in one go. Then we are stopping the plant. So that is where we started from. And look at the syringes on the left. Gratefully, I haven't used the one on the left side. This is how insulin was getting injected. And look at the right. And this one we have used. We used to boil it down, for a decade, maybe even more. And then inject insulin. And then imagine injecting that regular insulin 3 times a day, then separately injecting an NPH once or twice a day in type 1 diabetic patients or that Lent insulin. Now, life progressively became better. From those vials and syringes, now those sophisticated pens of today. 4 generations of pens, every second year that needle gets smaller and the pen gets better and sleeker. And you can use it as a pen and once you go somewhere for a dinner for a day or two. Now we have jet injectors. Wait for quite some time, inhaled insulin. It did not pick up in a very big way because one, the rate of absorption from the pulmonary mucosa was rather limited. So a lot of insulin would get wasted. A lot of people developed allergic phenomena locally. And there was a huge doubt that if in significant number of people, it might lead to some form of a fibrotic disease of the lung. And from those crude insulins, now we have, all of now we have insulin pumps, we have continuous glucose monitors. I remember when I got the first artificial pancreas in my own CGMS machine, we needed a room to keep it at skims. But today, the whole process has been so much miniaturized with the current technology. So things have moved at a very rapid pace in the recent decades. This tells us in totality, summarizes how this insulin has made a movement right from in 1890, when, as I showed you, Von Mering and Minkowski studied that pancreatectomy gives insulin, and from in 1920, early 1920, when Benting, Best, and Collip and Meckler discovered that this pancreatic extract has that potential of causing a hypoglycemic activity, and they started using it therapeutically. And thereafter, how it got proteominized and how human insulin started coming, and how then after the Sanger's work in 1958, people started thinking of not only using the E. coli machinery to make human insulin, but how to cause changes in that molecule so that we can determine in the lab the longevity or short duration of action of that particular molecule. So in conclusion, I would say a lot of interesting developments happening in the insulin space. But what we see happening at a very rapid pace for the last 2 decades actually started a couple of 100 years back when people zeroed in on that pancreas. Newer treatments which offer flexibility and good quality of life to patients likely to keep on getting discovered and keep on getting better. The only problem would be what segment of population globally and what segment of population in the subcontinent can afford that newer forms of modes of therapy that are getting now. For our generation, a big challenge would be how we ensure the maximum benefit to our own patient population who are culturally very heterogeneous, economically very heterogeneous, educationally very heterogeneous, how to customize the current therapeutics accordingly. And I'm sure at the end of the day, with all these mechanizations, the current insulins are likely to progressively become more acceptable, improve not only the quality of life, but the quantum of post-diabetes years too. Thank you so much.
Thank you, sir.
Thank
Thank you, Dr. Jargar. It has been always a pleasure listening to you, taking us to the journey of insulin over the last decade, where we had such a primitive insulin to start with, and now latest ultra modern insulin, which are longer acting and shorter acting insulin also. I think we are very fortunate to practice in this era of modernization, where we have technology to back up, and we have so many insulins in our armamentarium where we can pick and choose. But you are correctly said that we need to utilize these insulins to the maximum and give the benefit to the patients. I think also the weekly insulin, which is in the pipeline, the ICODEC, should change also the scenario where the patients will have the benefit of lesser pricks and the painful experience which normally they are dreaded of using the insulin. Also, maybe the oral insulins, which have also been, there for some time, has not shown the prominence effect, and they have not been used that quickly. I fully thank Dr. Jargar for such a nice deliberation of the talk. Dr. Sengupta, anything you want to add?
Thank you, sir. That was an awesome deliberation and taking us through the
Dr.
entire
Sengupta,
journey.
I am Dr. Vinod Kumar. Can I make a very brief comment if you permit me?
Please, sir. Please do, sir. Please do.
Dr. Jargar, your journey was both cherishing and sentimental. There are two more Nobel Prize winners in the field of insulin. One was Dorothy Hodgkins in 1964, who discovered the crystallographic
Absolutely, sir.
structure of insulin.
Absolutely.
And another one was Dr. Burson, Solomon Burson, who was the boss of Rosalind Yellow. Both had got joint Nobel Prizes, and I had a very lucky opportunity to have met both of them. And in one of the visits, Dr. Burson, when he came to All India Institute of Medical Sciences, I was assigned to take him to a toilet because he was feeling pressure, and I was looking for a clean toilet, and I couldn't find for 5 minutes, and he asked me, how long you will take more? That was one. And then Rosalind Yellow, I had also met in a party, and I had a good talk with her. One of the great scientists in India, immediately junior to me, Dr. N. Kuchupele, was sent to Dr. Burson's laboratory to work for 1 year. And this was, for me, it was very sentimental and this. And I would also like to say that much before the purified insulins came to the Indian market, somewhere in 1975, Dr. Ahuja and myself, we had carried out clinical trials on Act-Rapid and Rapidard insulin, and then the monocomponent insulins came, and after that, much water has flown, as you have beautifully described in the journey. Thank you very much.
Pleasure, sir. Pleasure, sir.
Thank you, Dr. Vinod Kumar. I think it is pleasure to have you on board, because you already know that how the journey has progressed over the years and how it has revolutionized the usage of insulin over the years. Thank you.
Thank you. Thank you.
One very significant development has been, reduction in the insulin allergies with the technological advancements. And thank you so much for taking us through this wonderful journey. Thank you. Thank you. I now hand over the podium to Dr. Sharma, sir. Any questions? I didn't see any in the chat box.
There are none in the chat box, so we can conclude the talk.
Yeah, sure. Dr. Sharma, please.
Thank you very much. Thank you very much, both the chairpersons and Professor Jargar, for the wonderful talk. Now for the next proceedings, I invite Dr. Vipul Gupta to carry forward and invite both these chairpersons and introduce them.
Thank you. Thank you, Dr. J.K. Sharma. Let us go to the next session, which is the paradoxes in type 2 diabetes by Dr. Anil Bansali. To carry out that session, I call upon our two worthy chairpersons, Dr. Girish Khurana, who is the founder and medical director of Vidya Medical Center. Sir, where is the slide introduction? Introduction slide, sir.
Dr. Bansali, sir, give me 2 minutes. Let me chairpersons be introduced properly. Otherwise, they will create hassle in your talk.
Yeah. Just give us 2 minutes, sir. Just let me go back to the sorry. And he is the alumni of PGIMS Rohtak. He is secretary of API District Chapter Haryana, tutor of NEDP in the field of diabetes, EC member of our RSSDI Delhi chapter, and he has numerous publications in index journals, in national and international journals. Dr. Girish Khurana, please. And our next chairperson is Dr. Vijay Arora. He is a senior consultant and director, Department of Internal Medicine, Max Super Specialty Hospital, Patparganj. He is a very dear friend and my class fellow and batchmate. Let him now take you to the next this session and introduce Dr. Anil Bansali. Dr. Girish and Dr. Vijay, please.
Dr. Girish.
Dr. Girish and Dr. Vijay, kindly unmute, and Dr. Vijay Arora, Dr. Girish Khurana.
Hello.
Yes, Dr. Girish.
Good morning, everyone. Now I'll request Dr. Bansali to deliver his talk on paradoxes in type 2 diabetes mellitus. Dr. Bansali is a well-known figure and is a renowned teacher. He is professor and head department of endocrinology, PGIMR Chandigarh, and he is having a numerous awards to his credit, Dr. B.C. Rai Award, and he is a fellow of Research Society of Diabetes in India. He was president of Endocrine Society in 2012. He has won various awards like WIDF Outstanding Investigator Award, Professor B.S. Raheja Memorial Oration. He has been awarded with Professor M. N. Sen ICMR Award, and he is a fellow of Royal College of Physicians, Glasgow, and he has numerous publications to his credit. So this is an interesting topic which he is going to speak, and something new which we will learn from him. We always keep on learning from a person like him.
Sir,
over
please
to
screen Dr. Bansali, sir.
Over to Dr. Bansali.
Thank you. Thank you for kind introduction. At the outset, I am thankful to Dr. J.K. Sharma for inviting me to this prestigious conference. We have already listened to 3 illustrious speakers prior to me that. However, this topic which I have chosen is slightly different and based on a conceptual understanding in the management of diabetes. So therefore, this talk will be useful for most of the audience. The points to ponder, which will include diagnosis, the clinical examination, the certain points or certain paradoxes in management, particularly lifestyle modification and anti-diabetic medications, and something about complications. The diagnosis of diabetes is usually established by the symptoms and the random plasma glucose of more than 200 milligram per deciliter, or a fasting plasma glucose of 126, or a 2 hours PPG of 200 milligram after 75 gram glucose load, or hemoglobin A1C of 6.5%. And these values, whatever is abnormal, which is to be confirmed if it is equivocal. What I mean to say that hemoglobin A1C now is in a greater use to make a diagnosis of hemoglobin A1, to make a diagnosis of diabetes, and there are much discordances with hemoglobin A1C and fasting plasma glucose. Similarly, the discordance between 2-hour PPG and hemoglobin A1C. If you look for that, fasting plasma glucose better correlates with hemoglobin A1C almost half of the patients, while half of the patients, they do have a discordance, means fasting is more than 126 and hemoglobin A1C is less than 6.5, or vice versa, that fasting plasma glucose is less than 126 and hemoglobin A1C is more than 6.5. The figure becomes more wider when the discordance between 2-hour PPG and hemoglobin A1C becomes almost 1/3 in each scenario. So we are finding a lack of correlation between a hemoglobin A1C and the glucose values, despite the hemoglobin A1C is a measure of the cumulative glycemic burden. This is the data from the Chinese study, and which shows that those who have got one of the important determinant is a concurrent presence of anemia or a concurrent iron deficiency. And certainly you have got a problem with hemoglobin A1C, as majority of our population is also anemic. So one of the reasons for that, why you have got a discordance, it is something around the 53% concordance in a man with diabetes, while with a woman with diabetes with a normal hemoglobin is around 50%. So and this figure goes varying. If there is iron deficiency anemia, you have got around 50%, and around the hemoglobin A1C is relatively higher when you have a concurrent iron deficiency anemia, and 75% of the patients had a higher hemoglobin A1C. So the discordance between fasting and this is okay. Just yes. So this is further shown that even in a Caucasian population, the concordance between hemoglobin A1C and fasting plasma glucose is only in 22%, while with the hemoglobin A1C and the fasting plasma is only 40% of the patients, while with the 2-hour PPG it is around 33%. So this is our data of the glycated hemoglobin in community-based survey, and where we examined the 2,272 individuals with a current cutoff of hemoglobin A1C of 6.5. We have got a specificity of around 88%, meaning by that the 12% of the patients, they do have a miss in the diagnosis, either by taking a fasting plasma glucose of more than 126 over a 2-hour PPG of more than 200 milligram per day. If we go further, the possible explanations for a discordance between hemoglobin A1C and the glucose values, which are still considered.
Hello, Anji sir.
Hemoglobin A1C is a measure of cumulative glycemic burden. It represents the recent or explosive onset of
Slides are here, sir.
Slides are visible.
Off kare na.
Please make it slideshow. Slides full screen.
Okay. Slide visible, sir?
Yes, yes, sir.
Sir,
they are visible, but you should keep it on slideshow.
You close on the top end where it is written outline, slides outline, and then there is a cross.
Okay.
Yeah.
Just on the top icon line, there's written.
This one, yeah.
This one, slideshow.
No.
Yeah. No.
Let's continue.
Press Control plus F5.
Control plus
F5.
F5.
No, sir.
Only F5.
Only F5. Okay. I think better was. Okay, now visible, sir?
Sir, press F5.
Now press F5.
F5, ne?
F1.
F1.
F1, not F5. Escape and close to it, F1.
सर ये एरो के सबसे नीचे जहां कप बना हुआ है आप सिर्फ उसको प्रेस कर दीजिए हो जाएगा या नीचे 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 जहां आप नीचे थे ना अभी कर्सर
हाँ
तो और नीचे आइए सर और
next to this yes
sir
yes now it is addresses in hemoglobin A1C with advancing age, and even with the advancing age you have to increase in hemoglobin A1C, and that is because mainly the people are at this stage they are fast glycators, but the slow deglycation process leads to this. So one has to be wary about that. If the age is more than 50 to 59 years or 59 years plus, then your hemoglobin A1C is again higher despite the glucose profile, both fasting and 2-hour PG is normal. So you can miss the diagnosis even by making a diagnosis with the hemoglobin A1C. Now let us talk about something in paradoxes in clinical examination. These are the two phases of insulin resistance. On one side, you see the extreme degree of acanthosis nigricans, and you can see it's almost grade 4. And on the other side, you see a lipoatrophic diabetes. You also see a Dupuytren contractures, which you can see in most of the situations like chronic liver disease or even the manual laborers can have. But diabetics, almost 30 to 40%, they do have a Dupuytren contracture. Another paradox in clinical examination, like many times we don't find a foot pulses and patient is having a diabetic foot ulcer, then it is likely to be ischemic ulcer. If the pulse will be bounding and patient is having a DFU, then it is likely to be a Charcot's neuroarthropathy or neuropathic ulcer. If the pulse is absent and diabetic foot ulcer is absent, then you think of a coexisting collaterals or a normal aberrations which happens in 10% of patients. If we talk about the management aspects and what are the paradoxes, we see that the weight regained despite continued lifestyle modification. And this is usually happening in patients that after some time they lose weight initially after this lifestyle modification program, but later on they start regaining weight, what we call as a yo-yo phenomenon. And this has been explained by the adipocyte starvation. And you have got a reduction in fat mass. The reduction in fat mass leads to decrease in fatty acids. The adipocytes are stressed, and this is called as the adipocyte starvation. This adipocyte starvation leads to decrease in lipolysis. So there's a decrease in free fatty acids, so which promotes the energy expenditure, decrease the energy expenditure and increase the energy uptake. On the other side, the decrease in lipolysis leads to increase in expression of GLUT4 because of reduction in lipotoxicity, as well as the fatty acid transporters. In addition, there is an increase in retinol binding proteins, which is also got an effect on appetite. So many factors, the homeostatic mechanisms are operative to regain the weight once you after initially lose the weight. And that's why the lifestyle modification program to begin with seems to be very good, but it is very difficult to sustain. The next question comes is that clinically we see in many patients with the type 2 diabetes are obese, already having a BMI of 25 plus, but sometimes we always talk about that the weight gain in type 2 diabetes is healthy or not. It is never healthy. We always talk about that. And if you look for a fat topography in patients with type 2 diabetes, the plasma free fatty acids increase, the muscle fat is increased, the liver fat is increased, arterial fat is increased, the subacute fat is increased, and there is an increase in intra-abdominal fat. So this is all altered topography in patients with diabetes. And let us see that. And we always, whenever we try to reduce the hemoglobin A1C by most of the modalities, you leave aside your GLP-1 and DPP-4 and SGLT2, the weight gain is inevitable and imminent. However, this is the weight gain with most of the anti-diabetic medications. And you can see that almost the GLP-1, they lose weight by 3 to 4 kg and SGLT2 inhibitors by 2 to 3 kg, and the rest of the drugs are usually associated either weight gain or weight neutral. The weight gain is detrimental because it leads to around 7% increase in the risk of heart failure. It also, data shows that there is a more in incidence of CSD, stroke, CVD, and total mortality with weight gain. However, in a proactive trial, there is only one factor which predicted that participants would not die, and you can guess what is that factor, and that factor was a weight gain. So only those who gain weight on pioglitazone therapy, the weight gain with that is healthy because it is a subacute fat, and the visceral fat is remarkably reduced. You have a reduction in TG, free fatty acids, you have a reduction in intramuscular fat, you have a liver fat is also reduced, and even the pancreatic fat is also reduced. So weight gain with pioglitazone is healthier in that way because you get a more subacute fat rather than a visceral fat. This is our data of the adiponectin and leptin with the use of pioglitazone and metformin. And what it showed that the leptin levels did not change much with pioglitazone, while the adiponectin, which is an insulin sensitizer, changed from 6 microgram per ml to 17.9 or 18 microgram per ml. However, there was no change in leptin, while the metformin could reduce the leptin significantly, but there was no change in adiponectin. We also use insulin in an insulin-resistant state. So this is also a paradox because using insulin in a patient with insulin-resistant state, it is justified. Yes, the patients with even type 2 diabetes, they are insulin deficient. And if we can see this plot, is that based on the euglycemic clamp studies, the total glucose uptake at any level of glucose is lower in patients with type 2 diabetes as compared to controls because of the tissue insulin resistance or because of the target tissue insulin resistance. We can overcome this insulin resistance by shifting this dose response curve. And the dose response curve, what it shows that normally only 10% of insulin receptors are at function. The rest of the 90% of insulins are at spare. So these are called as spare receptors, and you can overcome by increasing in the doses of insulin to overcome the insulin resistance. As you can see that by increasing the doses, you can shift the curve to the right and overcome the insulin resistance, and you can have a better glycemic control with that. So that makes a rationale of using insulin even in insulin resistant states because you can overcome as a part of a dose response curve, as a part of a spare receptor phenomenon, and as a part of they are also insulin deficient. We have already listened about a talk on GLP-1 analogs. So our vasculoprotective anti-diabetic medications are always cardioprotective. I think we have to segregate and we have to dissect out that. There is a different effect of the different anti-diabetic medications on cardiac muscles or cardiac myocytes as well as on coronary vasculature. Let us see that SGLT2 and cardiovascular outcome. there was a 14% risk reduction with SGLT2 inhibitor, and the 3-point MACE was reduced with canagliflozin, and which was significant. If you go further, on a heart cardiovascular outcome with this, on a heart failure, there was a 33% risk reduction in heart failure. So SGLT2 inhibitors has got an effect on both 3-point MACE as well as on heart failure. If you see that a GLP-1 receptor agonist analog, which Dr. Mittal also alluded, and you have a 13% reduction, which was significant with liraglutide on cardiovascular outcomes. So 3-point MACE was significantly reduced. However, on the heart failure, there was a reduction of around 13%, which was not statistically significant. So even a GLP-1 receptor agonist analogs are having a beneficial effect on coronary events, but they are, or 3-point MACE, but they are not having an effect on heart failure. So you have got a dichotomy between the different class of anti-diabetic medications. Some have a beneficial effects on myocytes, and some have a benefits on vasculature. A word about a PPR gamma agonist, pioglitazone. It reduces the cardiovascular event, and here you can see that in a hazard ratio was 0.84, means a 16% was reduced with pioglitazone on cardiovascular events, or particularly stroke. And even this meta-analysis also shows that there was a significant reduction in cardiovascular events. And if you talk about the proactive trial on recurrent stroke in patients with that, was where the pioglitazone was the most effective, and there was a risk reduction by around 40%. So you can see that around 47%. You can see that there was even on a vasculature, there are some drugs, anti-diabetic drugs, they do have a more effect, particularly on cerebral vasculature. These drugs are more effective. She's waiting for the The changes in percent edema volume. The percent edema volume was significantly changed, and the reason for improvement in the cardiovascular events was changes in edema volume, and that was around, with pioglitazone, that was around 0.16. If you talk about heart failure, the drug has got a detrimental. Drug has got a detrimental effect on heart failure, and there was a reduction by the 59% on that. So one can understand that the pioglitazone might be good for a coronary protection, but may not be good for the cardiac myocytes. So this is the summary table of the different cardiovascular benefits. The cardiovascular death, MI, stroke, heart failure, and CKD. These three classes have got different drugs because they are all cardiovascular events and related risk factors. Another paradox which you see in clinical practice is declining EGFR. Still, the drugs are renoprotective. The SGLT2 inhibitors, they have a renoprotective effect, and this is mainly because of the restoration of the TG feedback. You have got an initial decline in EGFR followed by the sustain and maintenance of the EGFR to the same level, at least for a period of next 6 years. While with a placebo, you have a persistent and continuous decline in EGFR. So that is CV data. If you see that about the regression of albuminuria was remarkably seen with this, while the progression of albuminuria was remarkably reduced. If you talk about that, the SGLT2 inhibitors, they lowers the intraglomerular pressure, mainly because of the SGLT2 inhibitors, they restore the TG feedback, which leads to, because of the increased delivery of the sodium to the macula densa, and this increased delivery of the sodium to the macula densa leads to release of more adenosine and leads to afferent arteriole constriction, and thereby restoring the intraglomerular hypertension is reduced. So meaning by that, this restoration of a TG feedback is very, very useful for
dynamics that we feel that this model would have certain deficiencies that we should be working upon, or specifically any other ideations, as an open ideations, any other comments from
the worsening of complications with intensive.
Dr. Sagar, what do you mean by facilitation? I mean, what is step 3?
So step 3, basically, we are looking at is maybe an implementable action plan. So depending on this risk assessment tool, and so what we understand is the actual.
There's some background noise. There's some background noise. Kindly unmute.
Excuse me. For the sake of grace and decorum, please mute all the other microphones other than the speaker, please.
Please, Rajesh will do it, Dr. Lalwani. Dr. Sharma, please request him to mute everybody.
Mute everybody, please.
So we have got another paradox is the worsening of complications with intensive treatment. So the intensive glycemic control was associated with worsening of retinopathy. However, later on there was a stabilization and followed by improvement. But this happened in 13% of participants had early worsening of retinopathy in the intensive arm in DCCT. The other complications which are worsening with that is a macular edema, which that happens with not only with intensive insulin but with pioglitazone. There is a worsening of retinopathy, liraglutide, and there is a worsening of neuropathy because of initial intensive insulin therapy. The various anti-diabetic drugs are used in non-diabetic status. Like PCOD, we use a metformin and pioglitazone. NASH, pio, metformin, and SGLT2. In CHF, we have a SGLT2 and DAPA heart failure even in non-diabetic. Obesity, we have both GLP-1 and SGLT2. CKD, SGLT2, and diamond shows even in a non-diabetic CKD and lipoatrophy use pioglitazone. So this is the data of pioglitazone in patients with NASH, and there was a change in status score and change in a liver injury score. And further, we have got a small data of a metformin used in NASH, and that also showed there was a decrease in enzymes with NASH, and there was also a decrease in status score. So to summarize, the paradoxes in diabetes are encountered in day-to-day practice in diagnosis, in clinical examination, and there may be many more in fact. This I have just tried to summarize what we see in clinical practice, and physicians should be aware about these oddities to avoid the problems. Thank you for your patience.
Girish sir, you please unmute yourself. Dr. Girish, please unmute.
Yes, thank you, Dr. Bhansali, for a wonderful talk and taking us through all the paradoxes which we see in our clinical practice. So all physicians, they should be cautious of these paradoxes and while using them in their clinical field. So before we start asking the questions, one question I would like to ask you, Dr. Bhansali, as you have rightly said, that most of these patients, they have iron deficiencies, particularly females and those who are pregnant, and 50% of them, they are having these deficiencies. So how we can calculate HbA1c in these patients? And number two, 40% of the patients, they have deuteric contracture as per your study, and how to correct this contracture?
So the first question is about alters the hemoglobin A1c, and that is mainly because of the fact that because the RBC turnover is faster. So the younger erythrocytes, they do produce a more problem, but I don't think there is any correctional factor for correcting this hemoglobin A1c for the corresponding glucose values. So I think the ideal hemoglobin A1c for our Asian scenario was 12 for the female and the 13 for the men, and then the hemoglobin A1c value can be correctly represented. The other point which you asked the question was the Dupuytren contracture. Dupuytren contracture is seen in diabetic patients, and we have published our data in diabetic hands. Around 40% of people have. So people have used the local steroid injections, one, and secondly, people have otherwise gone for plastic surgery.
Sir, I have a question. What are your views regarding combining pioglitazone with SGLT2 inhibitors?
Okay. So I think the major disadvantage with the pioglitazone for which we are worrisome, I think even the weight gain is healthier. But still, the way, if you want to counteract with the pioglitazone and SGLT2 inhibitor, at least the weight part will be taken care, and the rest, I think, that both have got a equally benefit, and both will be, I think, complementary to each other if you combine the two. So on coronary vasculature, both are good. On heart failure, SGLT2 is good. Pio is bad, so SGLT2 will take care of that. And in addition, the effect on lipid profile will be more beneficial. Adiponectin will be also beneficial. So I think the combination of the two will be definitely complementary.
So in people with non-alcoholic fatty liver disease, diabetics with non-alcoholic fatty liver disease, is glitazone the first choice? And up to what age can we use pioglitazone? Can we use it in the elderly?
Yeah, I think there is no contraindication for using the pioglitazone in elderly, except those who have sustained fractures. So if there is a history of fracture, particularly in women, because then the pioglitazone produces a predisposition for more fractures. And I don't think, and those who have already established cardiovascular disease, then the pioglitazone should be avoided. Otherwise, I don't think age is a contraindication for that. Rather with the aging, there is a marrow adipose tissues increase. I think that can be reduced by that. So that may be useful.
So if there are no more questions, I will hand over the mic to Dr. Vipul Gupta. Thank you, Dr. Bhansali, once again for your presentation.
Thank you, chairpersons, for conducting the session so nicely. Let us now move on to the next session, SGLT2 in the new era of heart failure trial. What is the relevance, by Dr. S.R. Arvind. To conduct that session, I call upon our next chairpersons, Dr. Brij Makkad and Dr. V.K. Goel. Dr. Makkad needs no introduction. He is the director of Dr. Makkad's Diabetes and Obesity Center, New Delhi. He is the honorary secretary RSSDI 2017 to 2019. He's a member of ACE. He was a member of ACE International Committee 2014 and 2016 to 2017. He has a vast exposure of international work in San Francisco, Cleveland Clinic, John Hopkins, and other Mayo Clinic. He's a course director, we know, of Cleveland Clinic Advanced Certification Course Diabetes from last 10 years, and he has a numerous publication to his credit. Dr. B.M. Makkad, please. We have Dr. V.K. Goel also to accompany him, who is the head of Department of Medicine, Mata Chanan Devi Hospital. He is faculty of National Board of Examinations, and he is the secretary of Delhi and North Zone Association of National Board of Accredited Institutions. And Dr. V.K. Goel. Over to Dr. B.M. Makkad and Dr. V.K. Goel to invite our speaker, Dr. S.R. Arvind.
This session is sponsored by AstraZeneca.
Thank you, Dr. Vipul, for a very kind introduction. Good morning, everyone. At the outset, I would like to thank on behalf of my co-chairperson, Chairman Dr. V.K. Goel, who's a dear friend, and on my personal behalf to RSSDI Delhi chapter for this great opportunity. And it's indeed a great, opportunity to chair a session for Dr. Arvind, who's not only a dear friend, but also a great, diabetologist from the city of Bangalore, and he's a fantastic speaker also. And I'll hand over to Dr. V.K. Goel to formally introduce Dr. Arvind.
Thank you, Dr. Makkad. It is my proud privilege to introduce Dr. S.R. Arvind, whom I have met few times. He is a chief consultant at Diacon Hospital, IDF Center of Excellence. He is director Diacon Hospital, Bangalore. He is a consultant diabetologist at Columbia Asia and Apollo Hospital. He is the course director, PG students at RGU, HS and RSSDI JNU University. He was president RSSDI 2015 and 16. He is president of Diabetes India. He has conducted over 92 phase 2-3 studies. He has over 100 publications and has authority over many textbook chapters. He has a Guinness Book record holder for highest number of foot screening in a day in 2013. And he was awarded Lifetime Achievement Award by Karnataka RSSDI in 2013 and Diabetes India 2018. So I introduce Dr. Arvind and invite him to start his talk, please. Thank you.
Thank you, Dr. Goel, and thank you, Makkar. At the outset, let me congratulate RSSDI Delhi chapter. I can see Meenal here, Shalini here, Dr. Sharma, for wonderfully organizing this virtual meeting. I know it's been the COVID times and then all of us were down, but it's always good to see each one of you on the screen. At least I'm sure in a couple of months we will be seeing each other face to face. With that, I will share my screen. The IT team can tell me whether they can see my screen now. I'm going into the full screen mode.
Yeah, it is visible.
Okay, thank you. I think I can see the full screen. So I think there was some introduction about SGLT2 from the previous talks, but then one of the best lectures that I've heard about SGLT2, the paradigm shift, was from Dr. Eugene Grunwald on the 4th of October when he spoke at the ADA Primer meeting. And it was almost 3-4 years since I had heard him speak, and this was a great lecture. In fact, I did hear his Lancet lecture that was way back in 2015. So we've been talking about SGLT2 inhibitors in the era of heart failure trials. Now the question is, what is the relevance? Every day in and day out, we have been talking about
macrovascular diseases. And when we talk of macrovascular conditions, we talk of MI, stroke, peripheral vascular disease, and these are the things. But we are forgetting that 1 in 5 people will develop heart failure during their lifetime. And close to 64 million actually are suffering. The rate is increasing, and it's turning out to be as malignant as some of the common cancers in each gender. Now, this is something that we should not forget. That is why you see this slide here, the probability of survival with cancer both in men and women. So is it really this cancerous? Then if so, why are we really missing heart failure in our patients with diabetes? Now, this is a very interesting slide, and this is what I was talking about. This was the 2015 Lancet lecture by Dr. Eugene Braunwald when he spoke of the war against the heart failure. Now, what he was trying to tell us at that time itself was, if you look from 2002 to 2010, there is a definite increase in the event rate, case fatality, and mortality rate when it comes to myocardial infarction. But then when you look at heart failure, there seems to be an increase, whether it is in men or in women. There is a definite increase, and it continues to increase. So that means we are missing out on heart failure definitely in the management trials, because we are able to bring down the event rate, case fatality, mortality rate with MI, but somehow heart failure, we are not being able to do much. I mean, that was the crux of his talk. Now, going with the same thing, now if you look at this here, whether somebody has diabetes or has no diabetes, if you look at the data from the US National Health Survey, the major CV diseases seems to be coming down. IST is coming down, stroke is coming down. But what we are missing out is heart failure and arrhythmias. So the mortality improvement, though seen with other events, is not being seen in heart failure and arrhythmia. This is something that we now have to sit up and think. Okay, we have been talking about MI and stroke and PVD, but we are totally forgetting the heart failure. Well, there are reasons for forgetting that. 1 in 5 may have heart failure. Now, if you look at the modifiable risk factors, you'll be surprised to know that diabetes is one of the most important determinant of development of heart failure compared to the other factors. We have been treating hypertension, we have been treating obesity, we have been treating dyslipidemia. We are basically requesting people to stop smoking. We are looking at the CV risk factors, but still diabetes is the most important determinant just to cause the heart failure itself. That's because diabetes can lead to heart failure through 2 mechanisms. One is atherosclerotic mediated, other is atherosclerotic independent. So our concentration is only been towards this. Well, somebody has an MI that results in a heart failure with reduction in the ejection fraction, and then there is myocardial damage and they go into heart failure. There is another pathway which we are forgetting, where there are inflammatory microvascular effects. And what are these inflammatory microvascular effects? These are the ones which are explained down here. So as treating physicians, from day one, we should actually start looking into this. Let's ask ourselves a question now. What occurs first in diabetes? Now, this is something, okay? Well, many of us will start scratching our head. Okay, what occurs first? Heart failure, MI versus stroke. In fact, you will be surprised if I tell you from the data that it is the heart failure. MI and stroke, yes, are extremely important. Yes, we are seeing, but we are missing heart failure, which is likely to occur much before that. And this is exactly what this paper is trying to tell us. Heart failure was the first manifestation of type 2 diabetes related CV disease more often than was MI and stroke. So most of the trials have been concentrating on 3-point MACE, 4-point MACE, MI, etc., cardiovascular death. But now I think it's time that they should concentrate on heart failure and PAD, because if you look at this data, it's very clear. Your CVA and MI is somewhere down below. Heart failure seems to be happening earlier. If this is true, why are we missing the heart failure? The reason is very, very simple. We are not picking up heart failure in India. When patients come, they have very vague symptoms. All that we do is we do an ECG, we take the blood pressure, and only if there are fine crepitations, breathlessness, or if they have orthopnea and things like that, we take it seriously. But the early phase of heart failure, pro-BNP, is something that we need to start doing in our population. And that is exactly what this Trivandrum Heart Failure Registry has done. Now, if you look at the data, you will sit up and see at least 8 to 10 million patients with heart failure in India. It's huge. 1% of adult population. Post-admission mortality close to 30%. And medication adherence is 25 to 50%. Now, if you look at this is the frightening line that I have read. The prevalence of heart failure in patients was 22.5% below 30 years and about 15% above 50 years. So India has a relatively young population with heart failure. And if someone has time, I think they should go through this Trivandrum Heart Failure Registry, or probably talk to Dr. Tiny Nair, who is very passionate about talking this. So how do we differ from the Western data? This is where it is. Indian patients present with heart failure at a much younger age. Diabetes is more prevalent among Indians than those in the West. And most importantly, the in-hospitality observed, at least in the Trivandrum data, was almost double compared to that reported in the other registry. So heart failure is increasing. It is prevalent. Probably we are missing it. I think it's time to treat the heart failure. Okay, now we come back to the treatment part of the heart failure. The standard treatment in our days when we were doing medicine was, of course, ACE, ARB, and then diuretics. Then we saw the era of ARNI. Very clearly, ARNI showed it was 20% more superior, or a 20% increased benefit compared to the standard of care, which was enalapril and diuretics, but still a good residual risk was there. Now, with this as the background, and with the knowledge that both heart failure and diabetes probably share the pathological features, especially endothelial dysfunction, insulin resistance, mitochondrial dysfunction, RAS activation, and inflammation, the scientists started to think, okay, there is some similarity with heart failure and diabetes when it comes to the pathophysiology. Can we try something different? And by that time, the real world data of DAPA was already ready. And we had seen the results, which was fantastic. Hospitalization due to heart failure was definitely low. Okay, so DAPA could definitely say from the real world CVD evidence that definitely this drug is working on heart failure. So the background was this. We know SGLT2 inhibitors prevent the development of heart failure in type 2 diabetes. Can they be used to treat patients with established heart failure? That was the important question. The benefit of SGLT2 may be glucose independent. Now, can SGLT2 be used to treat patients without type 2 diabetes? Because this was very relevant. Okay, it may prevent, but can I use it after heart failure is established? Well, it works in diabetics. Now, can I use it in non-diabetics? So on this hypothesis, it was tested that SGLT2 inhibitor DAPA 10mg once a day was added to standard therapy in patients with heart failure and reduced ejection fraction, because you have two pathways, you remember, both with and without type 2 diabetes. Now, this is the design. I will not go into the details of the design, The standard of care was perfect. So DAPA went into one arm and then the placebo went into another arm. And the patients were seen. And what was the primary endpoint? It was not 3-point, 4-point, not MACE. No. Here, for the first time to first occurrence of any of the components of the composite, that is CV death or hospitalization due to heart failure or an urgent heart failure visit. So this was the primary endpoint. And these were the key baseline characters, almost similar between DAPA and placebo, nothing to choose here. And these were the drugs that the patients were taking. The standard of care also had a good number of patients on ARNI, along with, of course, diuretics, ACE inhibitors, and other medications. And this is the list of the drugs that they were taking for diabetes. Now, one glimpse at this slide clearly tells you whether you look at cardiovascular death, hospitalization for heart failure or urgent heart failure, this was the primary endpoint, or the other things here. The group which took DAPA had a clear benefit, and the benefit ranged anywhere from about 18% to up to 30%. In fact, the best in the primary outcome was about 26% risk reduction, which was fantastic. So people needed the proof. The real world data was there. People were skeptical. Many of us say, no, we need more solid evidence. We need a placebo controlled trial. And here was the result of the DAPA heart failure. Now, when you look at the adverse events, very little to choose. There were hardly anything compared to DAPA and placebo. In fact, DAPA did better in all angles. Now look at the two groups. One had diabetes and other has non-diabetes. And this is where it becomes very interesting. Now this is where a drug which came into the market to be given to diabetologists, endocrinologists, actually moved away from us and it was gifted away to the cardiologists. When you look at the primary outcome, composite outcome of CV death, heart failure, hospitalization, and urgent heart failure visit, whether you have diabetes or you have no diabetes, guys, DAPA did better compared to the placebo. Now, this is when people started keeping their fingers on their nose and saying, what are we seeing with this drug? I mean, this came for diabetes. Then they said it reduces a bit of weight, and then they said it also reduces a bit of blood pressure. Now this seems to be working extremely well on heart failure, both with and without diabetes. Now let's look at the renal analysis. This was the next question that people were asking. This was also there in the secondary endpoints. What happens if eGFR is more than 60? And what happens if eGFR is less than 60? Now we have the answers very clearly. Whether eGFR is less than 60 or eGFR is more than 60, trust me guys, DAPA definitely does exactly the same. Whether it is a CV death, hospitalization due to heart failure or death. Remember, eGFR becomes very important for reduction of the glucose. But when it comes to the extra glycemic effects of this drug, it does not matter at what level you are giving this drug. It definitely has benefits on heart failure across the GFR levels. Now, if you look at the renal safety of this drug, this is fantastic. Now, I'll just show you this. If you look at this, renal serious adverse events was less in the DAPA group. Of course, we knew about this. We knew that it helps preserving the renal system. So compared to the placebo, this group did well. Serious adverse kidney infection as reported by the investigator was lower, of course, in the DAPA group. Doubling of creatinine was lower in DAPA group compared to the placebo. So renal safety again was established in people who had heart failure with reduced ejection fraction. So if there is a physician, diabetologist, or an endocrinologist who is worried about using DAPA in a patient with a low eGFR, thinking that it may do something to the renal system, well, here is the data, nothing is going to happen. Now, this is a very exciting thing. And this is for Makkar because Makkar is getting old, you know. So he will always think that, okay, in case if I have to take DAPA, now can I take DAPA? Now, different age groups have been seen here, and I don't want to say Makkar comes in this age group, and I come in this age group. No, I think even lower than that. Okay, jokes apart, the important thing is, irrespective of the age, there were patients more than 75 years. There were patients between 65 and 74. There were patients less than 55, 55, 64 across the age group. If you look at the outcomes based on the age on a continuous variable, you will be surprised to find whether it is the primary outcome or CV death, all-cause death, etc., whatever it is, was exactly better for DAPA compared to the placebo. So age is not a factor. EGFR is not a factor. So you are now very, very safe to actually use this drug. Now, it is the same thing in the elderly age group. If you look at the adverse serious events, hardly anything. In fact, the DAPA did better compared to placebo. Placebo had more adverse event in the elderly group compared to DAPA. So it seems to be working very well. Now, we go to the subgroup analysis very quickly and try to see. Now, there will always be physicians, there will always be doctors, there will always be cardiologists who will say, okay, my patient is already on the best of standard of care, including ARNI. Now, do I have to use DAPA over and above ARNI? Now, this is the data for you people to know. The benefit that you get by adding DAPA is consistent regardless of the background. Whether you are using your diuretics, whether you are using your ACE-ARBs, whether you are using your ARNI. In fact, the DAPA group did better with or without ARNI. Now, that's the message that we have to carry. And this is again with the diuretic. Again, the DAPA did good. So you don't have to worry about the standard of care. The standard of care before this trial was your ACE, ARB, diuretics followed by ARNI, because that came last. But now you know that when you add an SGLT2, especially DAPA in this case, you're going to get benefits irrespective of the baseline. Now, that is the most important message. In fact, if you read the cell metabolism previews, it's very clear. In fact, Dr. Braunwald was one of the authors. Now, if you have a house with number of drugs for heart failure, DAPA has just entered that house. We had ACE-ARBs, you had beta blockers, you had aldosterone antagonists, you had ARNI coming in. Now, ladies and gentlemen, sitting right in front of the house as a pillar of treatment for type 2 diabetes or no diabetes with reduced ejection fraction or without reduced ejection fraction in patients with heart failure, it is going to be DAPA. And after looking at all the data, in fact, the FDA also approved this drug to be used in class 2 to class 4 heart failure with reduced ejection fractions. So I stop here and I'll stop sharing my screen. So a lot of things have happened since this drug has been introduced. I don't know what more surprises we are going to have with this drug. SGLT class has totally changed. You know, it has brought diabetologists, it has brought physicians, it has brought cardiologists, it has brought the renal, everybody together. So I can now see the faces of some of the people. So Bridge Makkar, if you're worried about the age, can you use it? You're 70 plus. Yes, you can use an SGLT2. It is safe. You don't have to worry. I and Madhu are in the 30s, so it's okay.
Never mind. Good, Arvind, that you acknowledge my seniority on the screen. Thank you for that.
No, but Dr. Arvind, for glycemic benefits, and the age would be different, is it different? And for benefits on heart failure. And one more thing I want to ask you is that most of our type 2s and the elderly are frail. So age is not a number. If you are frail, can you use it? Because they cause weight loss also. So can you use it in frail type 2 diabetics who are elderly and have sarcopenia?
No, in fact, here the hypothalamus sets itself so fast. You may lose 1 or 2 kgs initially, but then again the weight comes back to you. Now, your first question, glycemic control, yes, in one set of patient when your EGFR is high above 45, you get the best glycemic control. But then for heart failure benefits, you don't look at the EGFR at all. So these are extra glycemic benefits of this drug.
I would be scared of using it in a frail individual.
So Arvind, taking further from where Dr. Meena put that question, I think bigger chance, the question is not weight loss only, there is, element of dehydration which can affect these people more. And there is a risk of fall which can be very dangerous in people who are frail. So I think that one area, I think I am also skeptical using SGLT2 inhibitors, but certainly age is not a factor. So you have enough data to say that can be safely used in elderly patients. Important thing is we are getting so much data on all these SGLT2 inhibitors, and all trials have different designs, different populations, slightly tweaked differently endpoints. So what is your take? You think they all come under the same class with similar benefits, or they are similar with differences?
I just had the same question that you had in mind. I mean, is it a class effect? So very clearly, Braunwald's lecture on the 4th of October clarified that doubt. It is a class effect. It's absolutely a class effect. So irrespective of what SGLT2
Even other SGLT2 inhibitors, they have the data.
yes, especially the ones which have been available with us now. But for FDA to put the label, they will ask you to do some of these trials and then give the evidence. So therefore, at this point of time, EMPA and DAPA have this label already. And CANA is also getting it on the renal safety. So if other manufacturers also do the trials, probably they will also get that labeling.
See, if you look at the trial data, there we end up finding some or other differences every time. Even if you're using similar molecules, look at the GLP-1 trials. At the end, somewhere the 3-point MACE is driven by heart death, CV death. Somewhere it is driven by stroke. Somewhere it is driven by MI. But at the end, primary endpoint, 3-point MACE is significantly reduced. Now, which one is better than other? Always a question if you go into statistics. So I think there is the message should be that we need to use with a lot of clinical judgment in clinical practice.
Yeah, I think
we just can't keep on dissecting statistics for all the patients.
Absolutely, you're very right. You should never compare one trial with another trial because the population is going to be different and their baseline characteristics are going to be different. I think as a molecule sense, this was an AstraZeneca sponsored talk on the DAPA heart failure with reduced reduction fraction. We took the data from that particular trial. But then if you do it for EMPA also, probably you will also have a similar data.
I think we end up with similar discussion and similar data.
So I think the important message is SGLT2 is a drug here to stay, definitely for heart failure. Okay, it may not stop the new onset of MI, but definitely composite death, CV deaths are definitely reduced. Hospitalization due to heart failure is definitely reduced, and it does reduce glucose and some amount of weight.
And has good renal outcome as well.
Dr. Makkar and
Arvind, there is a small question. This is Dr.
Dr.
Lalwani.
Makkar and Dr. Makkar and Dr. Arvind, do you think the patients who are early cardiomyopathy and diabetes or a non-diabetic, is SGLT2 going to replace the standard care of treatment like ACE inhibitor or the other things in coming time?
Sir, I asked the same question. I'm not an expert.
Mid-range ejection fraction, 45-50% of ejection fraction, early cardiomyopathy. Do you think the SGLT2 non-diabetic, is it going to replace the standard care?
Yeah, I mean, I've been asking the same question to Dr. Tiny Nair. Okay, so he said we may not have the data, but why not? We may not have the data, but why not? But I'm not a cardiologist. I'm not an expert, so I will not be able to give my opinion on that.
But I think important thing to keep in mind is that all these studies done with SGLT2 inhibitors are added to standard of care, and where 95% patients
Already
are on ACE or ARB. So you can't, extrapolate that data to using them in preference to ACE or ARB till we have very clear-cut, studies where they are compared with ACE ARB.
Dr. Makkar, if not replaced, at least add it in non-diabetics.
So add-on has recommendation.
Add-on is allowed.
But
add-on is
using them before ACE-ARB, standalone, we don't have any data. So we can't say that it will work that way.
All trials have been
chairpersons
done in EF less than 45%.
Dr. Lalwani has a question. I think Dr. Lalwani has a question.
Let us chairpersons with due permission, let me ask Arvind, what is his take on Milton Packer's suggestion on combination therapy of MRA, neprilysin inhibitor, ARNI plus SGLT2 inhibitor as leptin inhibitor in obesity-related heart failure and other forms of, say, amyloidosis type of heart failures, metabolic heart failures, cardiomyopathies like that. What's your take on that, sir?
So I haven't really gone through this. I don't think I should make a comment when I'm not very comfortable about this particular question, because I'm not an expert on that, especially with obesity. But non-obese patients where the standard of care of diuretics with ACE and ARNI being used for heart failure, adding SGLT2 is perfectly okay. And that's what the cardiologists have started doing. We have an obesity person here, Bridge Makkar.
Yeah, he can probably.
You can answer this question for weight reduction.
Again, my answer would be that it is very difficult to answer such a question based on our own hypothesis. Yes, we may attempt in clinical practice looking at the rationale that we can derive out of these trials, but we need to have data to say yes. We don't have any data on such a combination therapy for obese patients with the cardiomyopathy or reduced ejection fraction.
But Makkar, we don't have data on 40% and above ejection fraction also, whether they work or not. But Arvind said, yes, why not?
No. We have. No, I didn't get the question clearly, Lalwani. Can you repeat?
No, thing is that we don't have data with ejection fractions normal and mid-range with dapagliflozin. Still, we are trying to recommend dapagliflozin in normal non-diabetics as well, saying that why it cannot be extrapolated. It should be the same. But the same can be applied to obesity also. Why not? The same data can be applied here. If they work there, they might be working.
You are combining, when you ask that question, you are combining to address leptin, to address heart failure, to address kidney and everything. So such a combination, I am not sure. Again, extrapolating the data is always questionable, but yes, on clinical judgment, you can do it. Nobody can stop anybody.
I agree.
I
agree, but I was very excited when Milton Packer suggested this, because he is also an authority as big as Eugene Braun.
I agree. But once you are putting it on paper as a prescription, I think we need to think a lot of things. So I think we are also running short of time, so we have to close this session. I would like to thank Arvind for a wonderful presentation, and at the same time, during the presentation itself, clarifying a lot of doubts about the SGLT2 inhibitor usage, and of course, acknowledging my seniority on screen. Thank you, Arvind. And thank you, RSSDI Delhi chapter, for the opportunity.
Thank you so much, everybody. Thank you, RSSDI.
Thank you, my worthy chairpersons and my speaker. Now let us move on to the next topic, and next is a very important part. We have a chairman oration by our worthy chairperson, Dr. Meena Chavda. She'll be speaking on diabetes in young, empowering the family. To chair that session, I'll call upon Dr. S.V. Madhu. Dr. S.V. Madhu is a known personality. He is an immediate past president, Endocrine Society of India, past president, RSSDI, editor-in-chief of IJ-DDC, and he has over 250 national and international publications and several awards and accolades to his credit. Dr. S.V. Madhu, please. To accompany him, I have Dr. R.K. Lalwani, another very senior member of our RSSDI Delhi chapter. He is a recipient of PHFI Scroll of Honor 2011, 12 and 13. And he is author of Diabetes Mellitus Type 2, a clinical companion. Second edition is also now ready for publication. He was a principal investigator of Thyroid India and Depression in Diabetes. He is the author and director of courses tutored 12 and 13, and he was the past chairman of RSSDI Delhi chapter. Dr. Lalwani, please to invite our speaker and our chairperson, Dr. Meena Chabra, for the presidential oration. Over to the chairpersons, please.
We are thankful to UST Private Limited for supporting our RSSDI Delhi chapter annual conference 2020.
Thank you, Dr. J.K. Sharma. And with the kind permission of Dr. S.V. Madhu, my senior co-chairperson, let me introduce Dr. Meena Chabra, who of course needs no introduction to any of the people living and residing in Delhi and even across the nation. But is customary senior visiting consultant and diabetes specialist at Sir Gangaram Hospital, is having her own practice, and I personally know her that she is having a huge database on type 1 diabetes, and she must be congratulated for that. So he is very restless, very energetic, runs a charitable trust also, Trilok Singh Memorial Dream Trust, and part of the committee of the joint consensus guidelines, which we published just now. Of course, she is our current president, has got many honors as judge for FTR, the scientific posters, and has always been an active contributor to any conference on diabetes across the country. He has got many awards: Diabetes Awareness Initiative Award, Distinguished Service Award, Excellence of Diabetes Care Award, Dr. V.D. Kumar Oration, she received in 2019, Excellence in the Field of Cardiology at annual CME. Now, with this short introduction, I invite Dr. Meena Chabra with the due permission of my co-chair, senior co-chair, Dr. S.V. Madhu. Dr. Meena Chabra, the dais is all yours. Please take over for the presidential oration.
Thank you so much for those kind words. And it's my honor to have Professor S.V. Madhu chair my oration. Thank you, sir. And thank you, Dr. Lalwani. So good afternoon, everybody. I will be talking about diabetes in the young and my own work in how I feel that empowering the family is the way forward. I call my work accountable care. So I call it MCC, or Meena Chabra's accountable care model. Now, what is this model all about? Accountable care is to manage the healthcare needs of a young diabetic patient holistically on a long-term basis. And it's a partnership between the physician, which is me, the patient, and the care coordinators, which are usually
not visible. The slides are not visible.
Not visible, ma'am. Your slides.
Slides are not visible. No?
No, the slides are not visible.
Share your desk, ma'am.
You need to again reshare. Stop sharing and then again start sharing.
Reshare. Mr. Rajesh, please help Dr. Meena. Yeah.
Yeah, now you again start sharing.
Yeah, that's correct.
Yes, now you go to screen share. Slides दिख रहे हैं.
Yeah.
Can you see?
Yes, now visible.
So I will talk about how I use the accountable care model in empowering the family of the young diabetic. Now, accountable care means managing the healthcare needs holistically on a long-term basis. And this is a partnership between the physician, the patient, and the care coordinator, which is usually the family. I have added a fourth dimension to it, which is the peer. Now, holistic approach obviously matters. The good physician treats the disease. The great physician treats the patient who has the disease and also treats the family. Now, awareness is the first step to any kind of change. You need more understanding and empathy, and you need less blame and shame as far as the young diabetics are concerned. This is a brief of my programs that I've done, my philanthropy programs and the awareness programs. Awareness about obesity, importance of exercise, healthy eating habits. I always highlight sleep hygiene and awareness programs for teachers. I have convinced several school authorities to introduce healthier options on the menu of school canteens. In community settings and resident welfare associations, we highlight benefits of regular walk. I have formed a phone a friend walk group of elderly people, and we provide cars to reach the park. And this is very successful. If one patient does not come for a walk for 3 days, the others call the patient. I also share healthy breakfast to promote healthy eating habits. Awareness through media. We all know media plays a vital role in spreading public awareness. I have contributed numerous articles and columns in leading newspapers and magazines, both in English and vernacular languages, to spread awareness about prevention and management of diabetes through various TV shows. These are some of the media clippings, vernacular media as well. Awareness through social media. We've generated blogs and created social media campaigns to exchange correct information on diabetes treatment. On every World Diabetes Day, I start this, my diabetes campaign on Facebook, and my own patients come out with their version on what diabetes means to them. Now, events in association with RSSDI Delhi. I've been an active member of the RSSDI Delhi since its inception. I did a full day workshop on uses of insulin where 60 medical professionals participated, and it was a very enriching experience. And what I learned from this was that there is still scope for improvement in the knowledge and perception of insulin usage. We need educational interventions like ours to familiarize our physicians with both outpatient and inpatient insulin usage. I would repeat this, without data, you're just another person with an opinion. So I do contribute data. Professor S.V. Madhu is here, I'm in his arm, and I contribute data on YDR, Young Diabetes Research, a Young Diabetes Registry in India. We are registering all diabetics who were diagnosed before the age of 25. Now contribution, this is my humble contribution to epidemiological work. And this YDR data is being compared to the search data in the United States. And this is an international harmonization of youth diabetes registries, and the registries are ongoing. And I'm here sitting in front of Professor S.V. Madhu and have been contributing to that data. Now, this is another oral paper about my work that I presented, that clinical decision-making strategies can be more effective if you use an accountable care model. Now, this is a female endocrinology meeting that we did virtually for all women, not just doctors, and we spoke to them about type 2 diabetes and pregnancy and gestational diabetes. We also talked to them about the 2-generation risk that type 2 diabetes mother begets a type 2 diabetic generation. This is my engagement with the patient. This is my hands-on cooking. I teach them how to make low-calorie cooking. This is where we teach them yoga, and I do exercise and yoga myself and teach them. Patient engagement is the key for better outcomes. Then developing a customized document, and what prompted me to do this. So one of my patients, while she was traveling to traveling to Delhi, on her way broke her insulin cartridge vial, and she did not have any regular insulin. She went into ketosis, and she was continuously in touch with me from the train on the phone. And at Agra, she had to get down, and then in an ambulance, she was transferred to All India Institute of Medical Sciences, where she reached in DKA. This prompted me to make a customized travel document, which I hand over to all my type 1 diabetic patients, as well as the type 2s who are young. This is a very, very interesting document, and I tell them to check the document and checklist before they embark on a journey. Now, during COVID times, it has become even more interesting. Now, what was more interesting is that creativity is the key to success. There was saving of time by the young diabetic patient. They started having flexibility in appointments. They were very happy. And the best thing that happened was that peer-to-peer support could be facilitated. So what I always wanted, that on a platform, I wanted to invite one of my type 1s who's been, well trained and who could actually train. So we trained the trainer, and then we want him to train the type 1 diabetic patients. So we had a virtual patient network, and we would select patients, give digital prescriptions. The families would be sitting, as well as the families of the diabetic who's been insulin dependent for a while. And so we had a very, very nice virtual connect during COVID times. This led to increase in the ability to adjust therapy independently. They could consistently touch point with me, because otherwise they had to travel all the way, take my appointment. And this facilitated peer-to-peer support. And massive learnings during COVID times, social network analysis. We found that type 1s, most of our patients are very tech savvy. In fact, they even help their grandparents. Then learning that technology as an enabler for the need for electronic data record, it was very easy. I had 3,000 virtual consultations in the last 6 months, and there's been an explosion in virtual diabetes management program, and the type 1 diabetics, believe me, have really been benefited. So holistic care, which was enhanced during COVID era, we were doing this, but to call a peer and to explain, we had to coordinate between the new patient of type 1 diabetes, his family, and the patient who has already had diabetes for a while and his family to come to the clinic at the same time. But with this online program, we have a common platform, and holistic care has been enhanced. So now we have the patient, the physician, the parents, the peer or the friends, and we even invite a psychologist. So this has been a very good pentad of a cluster program where we can target the type 1 diabetes and the young diabetics who are type 2 also, and to control their diabetes better. Now, connecting dots for improvised outcomes. This is very interesting. When a type 1 junior, that is not junior in age, but type 1 junior, I mean somebody who's been diagnosed with type 1 diabetes now, connects to the type 1 senior. Senior is somebody not senior in age, but who's had diabetes type 1 for a while. So they can connect to each other. They can relate to each other. There is a peer and a friend contact. They can connect to each other telephonically. I have told my entire group to put their HbA1cs on the WhatsApp platform, and we encourage each other. There is no shaming, but if the HbA1c is not controlled, we encourage the other members of the group, the peers, to motivate those who are not within target. The parents also. And geographical barriers have been eroded, and we have patients from far and behold calling us for the management of diabetes. So I like to say that families, the support you will never have to pay for, because come rain or shine, they'll be there to cheer you on with every one of your life goals. It takes a village to raise a child. Teach a man to fish and he will never starve. So my message to you doctors is, we need to step down from our pedestals and tell our patients, well, this is the dose, just write a prescription and send them away. We have to empower the patients and their families. We have to teach them. We have to empower them. These are the miles and milestones, my sweet road to conquering diabetes. It wasn't a one-day journey. It's a 25-year-old long journey with all my patients. On World Diabetes Day, we organize diabetes awareness walks. We do detection camps. These are some of the very interesting pictures with my type 1 diabetic patients. And we were 20 doctors from Gangaram who joined the type 1 diabetics with wonderful slogans. This is awareness through various camps, the World Diabetes Day. One thing I would like to highlight is that we should not brush diabetes under the carpet. So when I meet my type 1 diabetic and their family for the first time, I tell them, it will not be okay. That's a lie. I tell them, it will be difficult. It will be doable, but difficult. I tell them, I love you, I'll help you, but you'll have to go through it. You'll have to learn. I'm able to teach you. My nutritionist is there to guide you. My psychologist is there, but it will not be so simple. Then this is my Women to Women initiative, awareness and empowerment program to educate and teach women physicians and dietitians from rural areas on prevention and management of diabetes. This was a community-based approach that emphasized on gestational diabetes and associated risks, and how it can affect a woman and her newborn. Patient-centered approach to manage diabetes in women. This was a community-based approach to help women fight diabetes in Delhi. So what we did was trained 100 women physicians and GPs, and then each one went to 5 schools to talk about gestational diabetes. And in my own clinic, twice a week, I have an in-clinic awareness camp. I have a free camp for exclusive insulin consultation. I have a family engagement program to develop strong mental health of the patients. I've joined the Rotary Club, interact with women, important tool to control chronic diseases, focus on adopting healthy food habits, and I've also demonstrated cooking in the Rotary Club. Now, these are my awareness through art and posters. This is very interesting. We put up these posters in various important places, the resident welfare associations. For past 3 years, along with my adopted type 1 patients, I've been regularly participating in the Rahagiri event, which was a part of RSSDI 1 year. Then the consistent messages at various talk shows is timely screening and intervention can prevent diabetes. Don't ignore the first signs of diabetes and lifestyle modification. Now, ICMR in-depth study conducted in 4 different zones of rural and urban India has revealed increase in prevalence of diabetes. Type 1 diabetes is increasing at a rate of 3% every year, and cases of GDM have increased tremendously. I spearheaded Jagran Pehal, an initiative to generate awareness about gestational diabetes. This is the newspaper, Dainik Jagran, and this was a part of World Diabetes Foundation. We went to schools. I went to at least 25 schools and spoke to 16 and 17-year-old girls and just told them about the importance of doing blood sugar test during pregnancy. Why we targeted 16 and 17? Because in the MCD schools and the schools in the urban slums, these are the girls who get married by the time they're 18, 19. So Jagran Pehal was a very nice initiative. And we also visit urban slums and do various tests to detect diabetes. My motto is, if you can't feed 100 people, then feed just one. So I do adopt a lot of type 1 diabetic patients and sponsor their treatment. I also empower GPs from rural areas, and I design programs for the GPs. They go back well informed. They come and stay in my clinic for about 3 months. The idea is to educate as many physicians to reduce and share the burden of diabetes care. So in the past 20, 25 years, I have trained at least 150 GPs who have gone back to the rural area and are empowered now to manage diabetes. Now, I support children with diabetes. I've adopted type 1 and type 2 diabetic children. I support their treatment, medications like insulin. We provide free glucometers to the needy patients. We also provide sticks at a very reasonable price. And we also support their education-based needs. This is being achieved through my charitable trust called DREAM. Idea is not just to support my patients, but also to gainfully rehabilitate them. We've actually, some of them have become diabetic educators, some of them have become nutritionists, one has become a gym instructor. And data supports that empowered patients tend to live a healthier and a longer life. This is my trust, Sardar Lok Singh Memorial Dream Trust, in the name of my late father-in-law and General Williams Masonic Polyclinic. I initiated the first ever state-of-the-art diabetes clinic where we see 60 patients every week. We have a dedicated team of nutritionists and foot care workers. We do all tests and essential health care at subsidized rates. It's a very successful model because it offers affordable treatment to the low-income families. Now, we organize monthly meetings and we call a nurse educator. And what we do is we reiterate how to manage hypoglycemia, how to inject, rotation of sites, how to change needles, how to store insulin, how to dispose of the sharps. In fact, some of my type 1s leave their needles in my clinic and then we take it to Gangaram Hospital. And strategically plan these meetings. We also have educational sessions by eminent doctors. So management of diabetes in resource-poor setting is my passion. So I passionately educate the families, and we provide all these things, insulin syringes, glucose testing, all at a reasonable price. So this is our program. We went to, I took all my type 1 diabetic diabetic patients to Agra for a trip where we did think everyone should be doing breakfast in time, injection, lunch, and we could successfully motivate those who were not taking pre-lunch insulins. We could motivate them to take their pre-lunch insulins because we checked post-lunch, and those who were taking pre-lunch dose of regular insulin had a better sugar than those who were not taking. And because of their peers and this program, I feel that lots of my type 1s agreed to take the afternoon pre-lunch shot of insulin. So we have built a support chain. Managing diabetes, doctors, I reiterate, is more than writing a prescription. It's not just about diet. Understand the trials and tribulations of a diabetic. I make sure that we make a chain where we all support each other. It could be emotionally by providing mental strength, sharing experiences, teaching how to use insulin. We've organized treks for a type 1 diabetic patient to increase their confidence level and self-belief and motivate them to lead a normal life. This was a fun way to educate patients about the importance of eating well, resting well, complications on greater heights, and keeping hydrated while trekking. Mental health program with Dale Carnegie. I've done several such programs with Dale Carnegie because studies reveal that people with diabetes have a greater risk of depression. Mental health and diabetes management is said to be interlinked. And this program helped the families to cope up with the mental stress. Fitness initiative with Yogdhan Foundation. We have regular yoga camps. I have an offline and online diabetes support group called Dream Best Friends. And I'm proudly saying that I'm available 24/7 for my patients if they have a problem. These support groups keep the patients engaged and motivated. We have open discussions. We have a quiz. We also have a party where we all cook together and eat together. Now, this is sensitizing the teachers. This was an oral presentation in the ISPAD meeting in Hyderabad. It was a school health program for 900 school children with type 1 diabetes. And we spoke to the teachers because some students say that we're not allowed to go to the washroom when they have hyperglycemia. Then they may have a hypo where they're not allowed to eat a snack. So we sensitize the teachers to the needs of a type 1 diabetic patient. Then I'm the course director for Diploma in Diabetes program affiliated with the Sikkim Manipal University. We also have a matrimonial alliance group where we arrange alliance between diabetic adolescents so that they lead a happy and fulfilled life. So my aim is to educate, empower, and enlighten. Educated and empowered diabetics live longer. Empowered patients know their rights. And at the end, managing diabetes is all about changing the perspective of patients and their families about diabetes and life as a whole. So these are some of my patients, type 1 warriors, who featured in prominent magazines. These are my 3 brand ambassadors. They're showing off their 24 flash glucose monitoring. They're not worried about getting married. We have empowered them that it is education, which is more important than just thinking about marriage. These 3 girls are flaunting their Libre Pro. So it all starts with one drop. And like Martin Luther King Jr. has rightly said, if you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. But whatever you do, you have to keep moving forward. Be the one everyone can count on. There is sometimes an emotional attachment to a cause or the simple urge to act and make a positive change. Let's join the cause. At some point, all of us will be touched by diabetes in some way or the other. Please, doctors, participate in more diabetes-related programs. Upgrade yourself so that you can manage your patients better. There is no right time, no right age, or right opportunity, because time is always right to do what is right. We ourselves feel, and I humbly submit that whatever we have done is just a drop in the ocean. But if that drop were not there, I think the ocean would be less by that missing drop. A big thank you for all those who have been part of my journey, my husband, my daughter, my parents, and my sibling. I conclude by saying, I can do things you cannot. You can do things I cannot. But together we can do great things. Thanks for a patient listening. And at the end of my oration, I again reiterate that once I have empowered families, it has led to a better control of diabetes, a reduction in the microvascular complications, and I can actually see the results of my work in 25 years. Thank you.
Well, that was
Very good,
excellent,
very
Dr.
good.
Meena. Dr. S.V. Madhu, please, would you like to join us now?
Yeah. Let me just first congratulate Dr. Meena on a wonderful oration. It's been a privilege to chair this kind of an inspiratory oration. 16 years after this chapter was instituted, chairing itself is a privilege, and it's nice to know. And she has reiterated so well that it's the care of a diabetic is much beyond the clinic and research, and you need a lot of outreach activities, engagement of family, and so on. And unless we focus on these aspects of diabetes care, especially in the young diabetic, the treatment of such patients is never successful. And thank you, Dr. Meena, for that wonderful oration.
Thank you, Dr. Madhu. And I must add, Dr. Meena, every slide was inspirational, no doubt, as Dr. Madhu pointed out. Yes, but the three things which were profoundly important were your personal involvement in each of the programs and the inclusion of psychologists, which you have done formally in your programs. And third was, which caught my eyeballs, was that poor resource group was in focus in a separate program. That's wonderful. Well,
Sir, I would
we
like
must be...
tell RSSDI to include these 5 Ps: the patient, the
Yeah.
physician, the peer, the a psychologist. So when we include the 5 Ps and the parents, so when we include 5P program, it becomes easier. So diabetes management is not just on the patient and the doctor.
Absolutely, absolutely. I fully agree, Dr. Meena. And what I am missing profoundly again here is we should have a recorded applause with us. Where are the event people? We must be having recorded applause, which should be played right now. Anyway, with this,
we can applaud otherwise also. Live applaud.
Thank you for, and with this we conclude the oration, presidential oration. If Dr. Madhu has another input for all of us, we will be enlightened to have it.
No, it's just
Otherwise,
I wish to thank RSD Delhi chapter, Dr. Sharma and Dr. Meena for inviting me to chair this prestigious session. Thank you.
Thank you. It's over to organizers.
Thanks, Dr. Lalwani, and thanks, Dr. S.V. Madhu, for chairing the session. And 3 cheers for our dynamic chairperson, Dr. Meena Chawda, for such a beautiful oration. Now, to carry forward the program, I hand over the podium to Dr. Shalini Jaggi for the inauguration program and the other further proceedings. Dr. Shalini Jaggi, please.
Thank you so much, sir. So good afternoon, everyone. I think we're all having a great time listening to all our experts. And after that excellent chairman's oration, I think it's just the time for the inaugural ceremony. So without much ado, I would like to welcome all of you for this inaugural ceremony. With that, formally, and I would like to invite our chairman, Dr. Meena Chawda, and Dr. J.K. Sharma, our secretary, on the virtual dais for the inaugural. With that, I welcome our President RSSDI, Dr. Banshi Sabu. I welcome all the dignitaries who are currently present, Dr. Madhu, Dr. Sharma, and all our EC members. I would request everyone to kindly put on your videos and join us for the inaugural ceremony now. So a warm welcome to everyone for this inaugural ceremony for our virtual RSSDI annual chapter conference. I would invite Dr. Meena Chawda to first deliver her chairman's address.
Thank you, Shalini. Dear colleagues, as chairman RSSDI Delhi chapter, for a long time, I didn't know, because I'm the first woman chairman, whether I should call myself chairman or chairperson. But I think I'm happy calling myself chairman. And I'm also the scientific chair of this annual virtual conference. It gives me great pleasure to present before you an academic feast that is a basket of knowledge to empower all of you. Rightfully, we have chosen the theme diabetes today and tomorrow, because this is an era of evidence-based medicine and clinical trials are being conducted on newer therapies. Recommendations for management of diabetes and prevention and treatment of complications are updated by various organizations and societies regularly, and we all have to be updated. Now, we have rapidly moved from a glucocentric approach to a vascular glucocentric approach, where end organ protection is the ultimate goal of all therapies targeted at the management of diabetes. Management of diabetes is holistic and individualized. The last decade, we saw various cardiovascular outcome trials where all new therapies for diabetes had to prove cardiovascular safety. But in March 2020, the FDA mandated that now with newer therapies, you not only prove cardiovascular safety, you also prove safety in the patients with chronic kidney disease, in the elderly patients, the high-risk patients, the pregnant women, and the young patients. So it keeps changing, and that is why our theme, diabetes today and diabetes tomorrow. We have a galaxy of speakers from across India, and also we have international speakers. We have 2 speakers from the United States, and I'm really privileged to be here and addressing all of you. In the time of the COVID pandemic, we all have known how technology has changed our lives. It has highlighted how we connect to our patients technologically, and it has also helped to connect with our not just our patients, with each other. So it's been a scientific feast. We can just at the click of a button listen to stalwarts speaking all over the world in the field of diabetes. We can actually listen to the dignitaries from all over the world. So this conference is an endeavor to share and gain knowledge. I hope it is an enriching experience for all of you. I wish to thank all my speakers and moderators. I also wish to thank the organizing committee, my Honorary Secretary, Dr. J.K. Sharma, the Joint Secretary, Dr. Shalini Jaggi, our Treasurer, Dr. Sen Gupta, my all other EC members, our patrons, and our, so they're all here, our mentors and our patrons. And I end by saying that I'm sure you're going to enjoy the deliberations. Long live RSSDI.
Thank you so much, Madam. May I now invite our Honorary Secretary, Dr. J.K. Sharma, to present the Secretary's report.
Thank you, Dr. Shalini. First of all, I am thankful to our Chairman, Dr. Meena Chabra, for giving me this opportunity to put forth the Secretary's report. And I welcome all, as I have already mentioned, to start with all the patrons, our past chairmen, advisors, our present governing council, office bearers, members, all the delegates. This year has been very, very difficult for all of us because of the COVID-19 situation. And we all know about that 6 months have passed by now. We planned many things. Physically, the one very important was the village adoption, and we identified 3 villages. Dr. Vipul Gupta, Dr. R.K. Maria, and Dr. Vijay Arora, they identified each one village, but we could not go to the village physically because of these problems. And in the present time, even we could not finalize this. We had a bi-monthly meeting where the insulin, it was an insulin workshop, rather insulin talk, and then we had few these EC meetings also, and we discussed many things. In the last national RSSDI, 2 of our past presidents, Dr. Rajiv Chawla now and Dr. B.M. Makkar, now they are the advisors to our RSSDI Delhi chapter. They are part of the national EC, past president, and now one important post Dr. Rajiv Chawla is holding is he is the editor of the 5th this edition of the book on RSSDI book on diabetes, RSSDI textbook. And Dr. Makkad is also there, and I congratulate Dr. Shalini for being the national EC member, which I'm also a part of that. So what I don't have much to share with you because of this COVID and all these problems, but we are in a process to start very early, and maybe by the end of this financial year, we will be able to do many more activities, and whatever lacunages we will have, we will definitely try to correct them in the next physical form meetings and the physical working over the period. So with that, I thank you everybody, and I hand over to Dr. Shalini. Thank you all.
Thank you so much, JK sir, for that report. We now move on to Saraswati Vandana, which will be carried on live by none other than a very talented young advocate, Ms. Rajalakshmi Sengupta, who happens to be the daughter of our treasurer, Dr. S. Sengupta. So I would request Rajalakshmi to kindly sing the Saraswati Vandana to start this inaugural ceremony.
কিছুই জ্বলছে না।
So this is a virtual lamp lighting.
This is the actual lamp lighting.
Lamp lighting.
We can see it virtually.
Dr. Sabu.
So she's on.
Ya kundendu tushar har dhavala ya shubhra vastra vrita या वीणावर दण्डमण्डितकरा या श्वेत पद्मासना या ब्रह्मच्युत शङ्कर प्रवृत्ति देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निशेष जाड्यापहा
Thank you.
Thank you for that very beautiful rendition, Rajalakshmi. With that, we move on to our, we would like to welcome our President, Dr. Banshi Sabu. Sir, are you there? Can you please?
I think Dr. Bansi will take another 5 minutes to join.
Okay.
So during that time, may I request Dr. Vinod Kumar sir to give blessings on this occasion of our first virtual meeting of RSSDI Delhi chapter. Dr. Vinod Kumar sir, please. Sir, unmute yourself.
My best wishes are always there for RSSDI. Every time when I attend a RSSDI event, I always recollect that today it is 48 years old, and after another 2 years, it will complete half a century, and this will almost coincide with the discovery of insulin, which was 100 years before. So I think we have a very fortunate coincidence that we are going to see. And I wish and appeal to the organizers and stalwarts of RSSDI to celebrate 50th year of its founding. That will be in 2022. And of course, a year earlier, you will all be celebrating the discovery of insulin, which will be 100 years old. I would like to just mention that when RSSDI was born in 1972, there were only, in the beginning, we only 6 people got together. And I would not hesitate to name them. It was Professor Ahuja, Dr. O.B. Gupta, Dr. Sam G.P. Moses, Professor M. Vishwanathan, Dr. M.K. Chetri from Calcutta, and 1 or 2 more. And they gave all their blood and sweat to irrigate this organization for over and over many years. And as more and more people joined, by 1979, that is 7 years after its birth, I relinquished the secretaryship after 7 years. And then at that time, I remember there were about 40 members of RSSDI as a live member. And now you can see from 1979 to now 2020, how many hundreds and thousands of people have joined. And I am very, very happy that RSSDI has grown to an organization of more than 7,000 members, and it is the largest organization in Asia. So what more pride we can derive from such a phenomenal growth of this organization. Once again, thank you very much for asking me to give my best wishes. Thank you.
Thank you, sir. Now, may I request Professor S.V. Madhu to say few words of blessings to our RSSDI Delhi chapter.
Thank you, Dr. Sharma. It's been a pleasure going through the proceedings of the RSSDI Delhi chapter today, since morning, and particularly the oration, as I said before. Regarding the RSSDI Delhi chapter, we all know that this is the 16th annual conference, and the chapter was founded about 16 years back. It's difficult to believe that 16 years have passed, and we are gloriously moving forward and achieving newer heights under new leaderships year after year. And I always wish that the chapter in particular should flourish, and it's already one of the most vibrant chapters, and it should continue to remain and become even more vibrant in the years to come. And it should fulfill all the goals of the national chapter. And we all know that over the years, the Delhi chapter has contributed significantly to the national body in terms of membership, in terms of the work contribution to the national level endeavors. And I wish all of you, and Dr. J.K. Sharma in particular, he is a member of the National Executive, to make significant contributions and keep the flag of Delhi chapter alive. Thanks once again, and long live RSSDI Delhi chapter.
Thank you very much, sir. And now we have another very senior person with us, Dr. Vinod Mittal. Dr. Vinod Mittal, please say a few words to our youngsters. Dr. Mittal, please unmute.
Thank you, Dr. J.K. Sharma, for inviting me to say a few words. As Dr. Meena Chabra, Dr. Makkar also, and everyone has said, almost 16 years back, we created this chapter. It was 2005, and I am there since beginning. And chapter has grown from leaps to bound, and really, we have done many good education programs, not only the scientific programs, even for patients and for paramedics also. And every year we've been having annual conferences. This is first time we are having virtual because of COVID. And we have already hosted 2 times national RSSDI conferences also in 2006 and 2013. And they were all, both of them were a big success. So I again wish everyone all the very best. Now we have a very dynamic team. Dr. Meena, Dr. J.K. Sharma, then Dr. Shalini Jaggi, Vipul, Girish, Dr. Bakshi. So, everyone is now, and I wish them all the best so that, we continue to keep the image and work harder to take it to a greater height. All the very best to everyone.
Thank you, Dr. Mittal. Now we have our chief guest, Dr. Bansi Sabu, with us.
हाँ जी सर, आपको इनवाइट.
Dr. Bansi Sabu with us. Dr. Sabu, please unmute.
हाँ जी.
Yes, sir. Dr. J.K. Sharma, sir. Namaskar.
Thank you, sir. Thank you.
Respected dignitaries, we have Dr. S.V. Madhu with us, the past president of RSSDI Endocrine Society. Dr. Respected dignitaries who are there. There are many colleagues and friends who are with us. Dr. Jingan, I can see now, and many more friends of mine who are there. So I really feel privileged to stand here in front of you as the president of RSSDI. Before I start, I must congratulate the entire RSSDI team Delhi for organizing a wonderful conference, mainly to Dr. J.K. Sharma and Dr. Meena Chabra and other members of this RSSDI Delhi chapter meeting who are virtually doing a congress or a conference. And Dr. J.K. Sharma, I was following him since last 15-20 days. On every day, he was writing to so many persons to join for this. So it had not become just a RSSDA Delhi chapter meeting, rather it's become a national meeting. We were getting so many persons, and today we are going to have some international speaker also who will be joining for this meeting too. I welcome you all for this Delhi chapter RSSDI meeting as the president of RSSDI National. And my vision for this year, which we have done already, and that was RSSDI District Coordinator Program with the help of all my senior colleagues. This we have decided where at RSSDI Jaipur itself, when I took over as the president of RSSDI, that we should have a district coordinators from each district of India, and we have more than 700 districts which are there. So we have a dedicated state chapter, but still what we had seen that are 80% of our members of RSSDI, they belong to the urban area of our country. I mean, either they are of a bigger city or a metro city or tier 2 or tier 3 city. We could not get many doctors who are from the rural area. And what we want that our RSSDI guideline that should reach to each and every physician who is practicing in our country. And we have more than 40,000 doctors who are practicing diabetes. And it was our great pleasure that this year we have more than 700 district coordinators. With the help of different state chapters, we could have it. And with the support of USV, we could launch our program, and now more than 100 such CME already happened. And I once again thank Dr. S.V. Madhu and Dr. Rajiv Chawla who were there to train all those district coordinators. We have done our first program with the Train the Trainer program. All those 700 doctors were there on our first meeting of this district coordinator, where we have educated them. We had made 2 modules, which is one related to the guideline, and second was related to how they should use this guideline in their clinical practice, a case-based discussion, and that's what we have done. And again, to share with all of you, it's again that KDIGO had just released their guideline of a diabetes and a kidney in the patients of a kidney, the management of diabetes, and where they had used a similar type of therapeutic circle, which what we are using in our RSSDI therapeutic wheel, and which we are going to write to all our members that yes, our RSSDI therapeutic wheel and this guideline which we have done internationally also is getting accepted or getting recognized too. This year we have done 2 more programs, which is one is type 1 diabetes network and a diabetes technology network, which we had created with our dedicated force, which is in country, and again with the help of state chapter. So state chapter is very important. Each state chapter have identified some 3 and 4 doctors who are interested either in technology or in taking care of type 1 diabetic patients. And because of that, now we have a almost 100 centers who are dedicated center for our type 1 care as well as for technology. Once again, thanks to our RSSDI social media team. Because of social media team, now our RSSDI is getting recognized not only amongst the physicians and doctors, which we are doing a lot of activities, but I think the social media team is working very hard. And we have Dr. Shalini Jaggi, who is also the part of EC of RSSDI National, who is heading this RSSDI social media team along with 4 or 5 more members from across the country. And we are doing really great work. Every Thursday, we have Diabetes Bites for that. 2 more programs which we are going to launch with our annual meeting, which we are going to have again on a digital platform on the same dates, which are 26, 27, 28, 29. That one, we have created last year under the leadership of Rajiv Chawla, a educator program, a RSSDI with a dedicated educator program for physician assistant. And this program, again, we wanted to launch through our district coordinator, because what we are thinking is that in a rural area, a physician who is working all alone, or he may have 1 assistant, and we want to educate him only to become a dedicated diabetic educator. He can be an educator, he's a dietitian, he is doing everything for that particular doctor. So that is a dedicated educator program which we want to do for our this district coordinator. Through this district coordinator, we have already completed the modules and we are going to launch maybe before our RSSDI. We have also launched, we are launching with IDA, which is Indian Dietetic Association. With them, we are launching a project which is diabetes specific nutritionist. So these are IDA member who are already dietitian. They are member of Indian Dietetic Association. Along with them, RSSDI doctors and some dedicated nutritionists from the IDA. We will be educating, teaching them with the 6 modules, and we will making these dietitian a diabetic specific nutritionist. So they will be working in our hospitals, in our diabetes clinic or diabetic care centers. There they can, they are primarily dealing with only with the diabetic patients with their complications, and they will be giving them a nutritionist. So these 2 more programs which we are going to have. Now from 16th of this month, 16th of October, as IPL is going on, and we thought that let us have a Indian Diabetes League also, which is similar to IPL. So IDL, we are going to have an Indian Diabetes League, where the 2 different state chapters team are going to have on a one debatable topic, on a one controversial topic. So the 2 teams will be there. We will be sending the detailed program in a day or 2 to all of you. And again, the state chapters are working very along with the national chapter very efficiently, so we can have this dedicated program on an IDL, which is Indian Diabetes League. And all our past presidents will be the main, they are the legend of diabetes, and they will be giving their final answer. So I know these 2 on controversial topic, there will be debate, but the final answer will be given by our past president. So that is what we had thought of a program. Once again, I will request as a national president, all those who are not the members of RSSDI, please become the member of RSSDI. Our RSSDI membership drive is always there. I request all of you, all those who are organizer, all those who are the part of this RSSDI Delhi chapter, please make many more, because we have more than 40,000 physicians who are working actively as far as diabetes is concerned. But at this point of time, RSSDI having a membership of around 8,000. So that is what I will request all of you to become member of RSSDI. And if you have any other suggestion, it's welcome, and we are always open for that discussion also. Once again, thank you and congratulations to RSSDI Delhi chapter team and organizing committee of Delhi for giving me an opportunity. And thank you very much once again for a wonderful, congratulations to all of you for a wonderful conference which you are going to organize. Thank you.
Thank you so much, Mr. President, sir. It's always great to work under your dynamic leadership. With that, may I now request Dr. S. Gupta, our treasurer, to deliver his vote of thanks.
Yeah, thank you, Dr. Shalini. Thank you all. It's my very pleasant duty to propose a vote of thanks to Dr. Banshi Sabu, our national president, for gracing the occasion, our esteemed faculty for having deliberated so beautifully, wonderfully on the multiple number of topics, our dear delegates without whom no conference can be successful. My vote of thanks to the industry participation for providing the logistic supports and the background, and Mr. Rajesh ji and his team of Concept for working out the program minuteness and the logistics wonderfully. And lastly, to my fellow colleagues of the executive committee of the RSSDI Delhi chapter for having given their unstinted support right through and for making this program a success. Thanks one and all. Thank you. Long live RSSDI.
Thank you so much, Dr. Sen Gupta. So with this, we come to the end of the inaugural ceremony, and it is also the time for the very prestigious National President Oration. For chairing the oration, may I request our Delhi chairperson, Dr. Meena Chabra. We all know her. She is Senior Visiting Consultant, Diabetes Specialist, Sir Gangaram Hospital. She's given us a very passionate oration and introduced all her work. So I think when we've seen that work, this entire CV has absolutely no significance. But of course, she's an achiever. I also welcome our Honorary Secretary, Delhi Chapter, Dr. J.K. Sharma, who's the Medical Director, Central Delhi Diabetes Center, another very dynamic and active person in the diabetes arena. He's a national EC member as well. He's also the chairman of IPF, visiting professor and faculty, Department of Medicine, JN Medical College. He's fellow of all the 4 Royal Colleges of Physicians, London, Edinburgh, Glasgow, and Ireland. Of course, a member of ACE. He's the Overseas Regional Advisor, Royal College of Physicians of Edinburgh for North and Central India, and many, many more responsibilities to his credit. With that, I request our chairpersons to welcome and introduce our National President, Dr. Banshi Sabu, sir.
Thank you, Dr. Shalini. So with the permission of our chairman, Dr. Meena Chabra, I would like to introduce our President, Mr. President RSSDI National, Dr. Banshi Sabu, who is not only MD and fellowship of, from multiple colleges, he is also PhD, Chief Diabetologist and Chairman Diabetes Care and Hormone Clinic at Ahmedabad. Honored with Fellowship of American College of Endocrinology, American College of Physicians, International College of Nutrition, Royal College of Physicians, MNMS, President RSSDI, President of AIAARO, Indian Obesity Society, Honorary Secretary of Diabetes in Asia Study Group, Honorary Secretary of Diabetes India. He has launched a project Diabetes Free India 2030, acknowledged by Honorable President of India, late Sri Pranab Mukherjee ji, founder of NGO, managing editor. And if I'll start narrating everything about Dr. Banshi Sabu, I think time will be short. We have already heard the address by our president, Dr. Banshi Sabu, and I think anybody and everybody who is a diabetic patient, not only a diabetic patient, a doctor treating diabetic patients, knows Dr. Banshi Sabu nationally as well as internationally. And I'll not come in between his oration. So I invite Dr. Banshi Sabu to please share his screen and give us the oration. Dr. Banshi Sabu, please. Please unmute yourself, Dr. Banshi. Please unmute yourself.
I'm fine. Am I okay?
Yes, sir.
Can you see my slides?
Yes, sir.
Okay. So first of all, once again, RSSDI Delhi chapter, mainly to Dr. Meena Chabra and Dr. J.K. Sharma for giving me an opportunity. And thanks, Dr. J.K. Sharma, for very kind introduction. What I am going to talk about the time in range, which is really change the concept of glycemic monitoring. So we are moving beyond A1C, which is the regular way of monitoring our diabetic patients. So my agenda will be, we are having an era of A1C, and then I will be talking about its limitation. We will be talking about the novel glucose monitoring metric, which is time in range, some guidelines, what are the available for time in range, and some practical implication. We will have one case which we will be discussing. As we know that almost 28 years before, quarter century ago, DCCT trial had established the importance of A1C. And I'm sure all of you will agree that it is the DCCT trial which had talked about A1C, lesser the A1C, less the complication for type 1 diabetic patient. And similar thing was there once we have UK PDS trial, and for many more clinical trials, all of them had used A1C as a glucose monitoring metric, and that had decided that lesser the A1C, better the outcome for most of the diabetic patients to have a long-term diabetes complication. But A1C has its own limitation. It does not capture the hypoglycemia. People with diabetes whose A1C level are below 7, they spend more than 90 minutes per day with a mean glucose level of less than 70. So I mean, those patients to whom you are thinking they are doing very well, their A1C is less than 7, and we are very happy, but their A1C may be less than 7, but they are spending more than 90 minutes of the time in 24 hours less than 70 milligram. This is one of the impact study where participants were similarly well-controlled diabetes, and they have spent more than 200 minutes per day with mean blood glucose level of less than 70. In an impact, they had used even a continuous glucose monitoring to find out how many of the patients they are having below time below range. It does not capture individual difference in A1C. You have a varying patterns of a glycemic control with identical A1C level and a similar mean glucose concentration also. You have a two different type of glycemic pattern, but still the A1C may be the same. There are certain conditions which are like anemia, some hemoglobinopathies, iron deficiency, or even pregnancy. They can also confound the A1C measurement too. It does not capture the glycemic variability. It had shown that the glycemic variability with increased risk of hypoglycemia have a worsen, they increase the cardiac vascular outcome as well as all-cause mortality. So glycemic variability have a directly correlation with increasing the cardiovascular mortality as well as the bad cardiovascular outcome too. So you may have a two different type of patients with the same A1C. The patients who have high glycemic variability, the other patients may have a low glycemic variability also. So the utility of A1C, yes, A1C is very, very important for all those at least type 2 diabetic patients. If you have a type 1 diabetic patient who is doing a continuous glucose monitoring and achieving a time in range, even you may think of not doing A1C, but for all those type 2 diabetic patients where we are doing intermittent continuous glucose monitoring, the A1C is very, very important. But this A1C importance can be, this utility of A1C can be enhanced by complementing using the continuous glucose monitoring also. So I mean, intermittently using continuous glucose monitoring along with A1C, definitely the utility of A1C will be much higher in compared to the patients who are using only A1C. Let me give an example. A patient who is doing self-monitoring of blood glucose even 3 to 4 times in a day. This is a type 1 diabetic patient doing before breakfast. He is doing before lunchtime, even after breakfast, even at bedtime also. All 3 or 4 times of the sugar is most of the time the sugar is coming between 140 to 100 only. So I mean, all 4 sugar reports are fine. But when we do the continuous glucose monitoring, we can see the peaks between the 2 sugar reports, and then we can see some of the hypoglycemia maybe before lunch and maybe midnight or evening time also sugar. So the continuous glucose monitoring is like doing a continuous video recording, while doing a random blood glucose giving only a sugar report, it's just like taking a photo. So a glucose reports is much more than getting, I mean, a trend, because that only you can get through a continuous glucose monitoring, which you just can't get only by doing a random blood glucose monitoring. So on that, there was a consensus on a use of a continuous glucose monitoring. How often we should do a continuous glucose monitoring. For type 1, it was made that if it can be done for all the patients, there is nothing like it. That was what the consensus was. For type 2 diabetic patients, at least intermittent use of continuous glucose monitoring will help them. And that was in 2017. This guideline was made along with ATTD. I was part of it. It was published in Diabetes Care. And on the same, what the benefit of this continuous glucose monitoring? I had already talked about the DCCT trial, which had happened in 1983. The average A1C of the patients who were in the DCCT trial was 9. We wanted to have the A1C of less than 7, but we could achieve the mean A1C of 7.2. But to get A1C from 9 to 7.2 in DCCT trial, the severe hypoglycemia risk was 62 per 100 patients a year. And the benefit of continuous glucose monitoring was there in JDRF CGM trial, which happened in 2008. And these all type 1 diabetic patients who are using continuous glucose monitoring, the baseline A1C of these patients was 7.6, and they could achieve the median A1C of 7.1. The severe hypo rate from 62, it has decreased 20 per 100 patient year. So I mean, you can see the significance of using a continuous glucose monitoring in a type 1 diabetic patients. In a pivotal trial, in this particular trial, in a pediatric and adult patient, the risk of hypoglycemia, because they were using not only continuous glucose monitoring, but for giving insulin, they were using the continuous insulin infusion pump also. And the baseline A1C was 7.7, and from 7.7, they reduced to 6.9. That is what the target for type 1 diabetes. Below 7, the median A1C, they could get the 6.9 without risk of hypoglycemia. The severe hypo rate was 0, and that's very, very important. So the importance of continuous glucose monitoring in a type 1 diabetic patient is huge, and that what we can achieve a target A1C even without getting significant severe hypoglycemia also. So the novel metric had come, the time in range. If you are doing a continuous glucose monitoring for your patient, the new metric for measuring the glycemic control is just not the A1C, it is the time in range. So what exactly the time in range? Time in range refers to time spent in an individual target glucose range. I mean, that is what 70 to 180 milligram. But occasionally with the patient who is pregnancy or with having the pregnancy, this target is slightly more tighter, that is 70 to 140. So that is how much time somebody is having in 24 hours. He is getting in this glucose in range, that is 70 to 180, that is time in range. The percentage of time when it goes below that, what we call is time below range, and when it goes above range, it is what we call is time above range, which is indicates hypo or hyperglycemia respectively. Time in range may be used an appropriate endpoint in a clinical research as a measure of glycemic control in patients with type 2 diabetes as well as in type 1 diabetes. Emerging evidence are there to time in range is inversely correlated to risk of developing microvascular as well as macrovascular complication in patients of diabetes, again in type 1 as well as in type 2 diabetes. So time in range, I am showing this is an ambulatory glucose profile because this is more commonly used in our country. But now the cesium data of Medtronic as well as those who are using the Dexcom data, they also started using the software which is called as an ambulatory glucose profile AZP. And this AZP gives you this type of data where you can see the data with the sugar reports which is coming in a graphical form. Those which is between 70 to 180, we call that a glucose in range. And that is what, if they are out of 24 hours, how much time they are spending between 70 to 180, we call them time in range. Those time when patient is going above that, we call them time above range, and those which is going below it, we call that time below range. The why time in range is so important. You may have a patient at the same A1C but a different TIR profile. So I mean a same patient who is coming to you with a 7 A1C, but at that point of time 58% of the time the sugar is going below range. And there is a time when the same patient is coming to you again next time and he's again A1C is 7, and this time he's having A1C, I mean A1C is 7 but the time below range is 29%, and the third time the patient after whatever the modification which you could do it, and now he's still achieving the A1C of 7, but this time his time in range is 7%. So I mean that is what we are looking for. You may have a patient who had come to you with a 7 A1C, but when you are doing continuous glucose monitoring, you are finding patient is getting a lot of hypoglycemia. You change the therapy and patient is on continuous monitor. Again, the hypoglycemia is decreasing, and there is a one time when you have reached a point where the person is almost 100% of the time he is in range. That is what 70%, more than 70% of the time now person is in the range, and the risk of hypoglycemia is less than 5%, and he is achieving A1C of 7. So I mean the same patient who will say that my A1C is still same, but now the quality of life will be much more different. So there is a significant difference between the A1C and time in range. A1C evaluates single value, while time in range, it evaluates continuous glucose level. A1C compare with 3 months, while time in range compare any time period. A1C does not capture hypoglycemia or hyperglycemic level which is occurring on the same day, while time in range capture all glucose level and in a given time frame, or it identifies time within the safe range. A1C does not have any effect. The immediate effect of therapy cannot be recorded by getting A1C report, while immediate effect of acute effect of therapy can be seen in a time in range profile. The HbA1c is a bad correlation with the patient reported outcome, while the time in range have a good correlation with patient reported outcome, which I had shown with the same patient with the same A1C, but still one time he was having a significant and severe hypoglycemia, while other time it was not. A1C, there is a high susceptibility to interference, various labs, anemia, age, while the time in range, now with the even the different modes which we are using, Dexcom, Medtronic, Abbott Libre, they all have, but still the time in range will show almost similar results. At present, the A1C had shown multiple long-term study, and we don't have that many studies for time in range because it's a new concept. It is developing, but still I would like to show some of the study. The validation of time in range, that's very, very important, because that is the first question that somebody is going to have, that in last 25 years, we have so many studies which have shown the outcome measure of A1C, but we don't have so many studies for time in range. But there are few clinical trials which has been published. And one of the important trial, which is not the trial actually, rather a paper which is published, because in DC city, there were patients who were doing 7-point self-monitoring of blood glucose. So all those 7 points which was taken, and then they tried to make the graph for these patients. And those patients, after making the graph, if the time in range which is coming in an intensive arm was 52%, while in a conventional group, it was 31%. So I mean, with these 7-point self-monitoring of plasma glucose, they have made the graph, and out of them, 52% in an intensive arm were coming in a time in range, while in a conventional arm it was only 31%. And what those who had seen, those patients whose time in range was more in compared to these, they have lesser complication. The complication mainly of microvascular complication in type 1 diabetic patients, mainly of retinopathy. The time in range was 32% in those who were developing microalbuminuria, while 42% patients who were not developing microalbuminuria, because their time in range was 42%. So even there was a significant difference between a 31% to 32% to 42%, while 32% to 44%. So now you can see, if somebody will able to achieve a time in range for more than 70% of the time, you can see a significant difference as far as microvascular complications are concerned in type 1 diabetic patients. And this is the same study where each 10% less time in range, there was an increased risk of microvascular complication. More the time in range, lesser the complication of microvascular complication. Now, do we have a similar type of data for type 2 diabetic patients? Yes, recently a paper was published from Korea where they had done an association of time in range and a prevalence of diabetes retinopathy in type 2 diabetic patients. What they have done, in a type 2 diabetic patient, they have put on the continuous glucose monitoring, and they had seen that time in range was significantly associated with prevalence of all stages of diabetic retinopathy. Patients with more advanced diabetic retinopathy showed significantly less time in range, while the time in range shown an independent association with diabetic retinopathy even after other factors of A1C like adjusted. So I mean, these two patients may have a similar A1C, but the patients who have better time in range were having less diabetic retinopathy. Now, this is as far as microvascular complication is well correlated even in type 2 diabetic patients also. What about the type 2 diabetic patients with a macrovascular complication? The time in range was correlated with carotid intima media thickness. The patient who have better time in range in type 2 diabetic patient, in the same study, in a type 2 diabetic patients, they tried to do the carotid intima media thickness, and they found those patients have a better time in range, have lesser intima media thickness in compared to the patient who have less time in range, have more carotid intima media thickness. Now, what the guideline is talking about time in range? This guideline in 2019, again, I was the part of this guideline in an ATTD, more than 40 experts were there and at Berlin, and we had come out with a guideline after doing a continuous glucose monitoring. If we have, what we want that in each and every patient will have 3 different type of their sugar range, and those patients between 70 to 180, our aim is to increase in time in range, while those patients whose sugar is above it, we call it time above range. Those patients below it, we call it time below range. So the primary goal for effective and a safe glucose control is to increase the time in range while reducing the time below range. So there is an international consensus for a CGM data interpretation. Those who are type 1 or type 2 diabetic patient, they should have more than 70% of their time between 70 to 180. If they are not able to achieve more than 70% of the time in this target range, then we should change the therapy. This is very important. We should change the therapy. The hypoglycemia, they should not have more than 5% of the time. So this is again very important. If they are having more than 5% of the time in hypoglycemia, we have to change the therapy. Now, those who are elderly, type 2 diabetic patients or type 1 diabetic patients, or those who have severe risk of hypoglycemia or hypoglycemia unawareness, still we want to have them to have a time in range more than 50% of the time. But here the risk of hypoglycemia is high. We don't want them to have even more than 1% of the time to go in a hypoglycemia. So this is again very important. Not even more than 1% of the time it should go more than 7, less than 70. If they go, we have to change the therapy. When a type 1 diabetic person is becoming pregnant, then this range is again the more than 70% of the time, but the tighter the glucose control, it becomes between 63 to 140. If somebody is a type 2 and becoming pregnant, or pre-gestational diabetes or GDM patient, 90% of the time this sugar range should be between 63 to 140. So that is what the target, and this is what the international consensus. In another way, this is same what I had talked about. So the ADA in 2019 and 2020, they have taken this as a part of a guideline. The time in range is associated with risk of microvascular complication, and it can be used as an assessment for a glycemic control. The time below and time above range and time in range are very useful parameters for re-evaluation of the treatment regime, whatever treatment which we are giving to our patient. As far as American Association of Clinical Endocrinology, in 2020, they had also talked about the continuous glucose monitoring. The use of CGM, whenever it is indicated, assist the patient in reaching the glycemic goal safely. So I mean, using the continuous glucose monitoring for our patients, more and more we should use it. And this is what in their highlights of American Association of Clinical Endocrinology. If you see the AS guideline in this tabular form, they had used the monitoring part, the blood glucose monitoring. CGM is preferred. So this is for type 2 diabetic patient. So CGM is been recommended for type 2 diabetic patient in the algorithm, in an executive summary, where 11 principles of managing type 2 diabetes, and this hints at the increasing importance of time in range. The last part is a case-based discussion. This is, I am sure many of us are using in our clinical practice. This is the Libre Pro reports, which it had shown the time in range. I mean, you can see the time in target, which is equivalent to time in range. You can see individual day wise also that how much time the person is remaining in the range, and which is between 45, 47% to the 73, and then you can get the average. But what we want for individual day also, we want it should be more than 70%. The first thing we should go for the time below range, that is time below target. Here it is written, it should be less than 5%. If it is less than 5%, we are okay. But there are times when it is more than 27 and 28. Make sure that it should be less than 5%. And then time above range, it should not be more than 25% of the time. So if it is more, then we have to change the therapy for this patient. I give an example that this is one of the patient who had come to me whose A1C was 9.1. This patient was already on a triple drug therapy. He was on metformin, glimepiride, and DPP-4. Patient had come and patient was advised insulin therapy. And as per 9.1 with a triple drug therapy, he was an ideal candidate to start with the insulin, but patient was reluctant to start the patient on insulin. I have done continuous glucose monitoring. We call the patient after 5 days, and I had shown that, see, all the time your sugar reports are high. It is better we start you on a basal insulin, or other thing what we can do is we stop you from the DPP-4 and we add the GLP-1 and SGLT2 both. So instead of that, now 2 drug, you will be on 4 drug, but this is what we will do, and we are decreasing your glimepiride. On a telephonic consultation, you will be surprised after adding the patient on GLP-1, SGLT2, metformin, and the glimepiride on telephonic consultation, I had to reduce the dose of from 4 to 2 to 1, and ultimately it was 0. When patient had come on 12th day, this was the report of the patient. And again, then I explained, now you don't need the molecule which can lead to hypoglycemia, and patient was continued with these 3 drugs only, and you can see 24 hours the patient sugar is well controlled. So this is what the importance of doing a continuous glucose monitoring in our type 2 diabetic patients also, which decides and which gives us the idea that what therapy will be best for this particular patient. The patient who was supposed to be, as per the guideline, as per the A1C of 9, as per the triple drug combination which he was taking, he should be on insulin, and now the patient is only on GLP-1, SGLT2, and on metformin. He had again come after 6 months, and we had seen his A1C is lesser than 6.5 without getting any hypoglycemia. So to summarize my talk, we know that HbA1c is a gold standard for diabetes management. However, it does not demonstrate a holistic and individualized glucose profile. The glycemic variability is associated with increased risk of severe hypoglycemia, diabetic complication, and reduced quality of life. Time in range provides a closer view of the person's glycemic status, and it aids in better glycemic control. Increasing time in range has been shown to have association with reducing micro and macrovascular complication in people with diabetes. International guidelines have now been updated to include the consensus on CGM data interpretation. A need to exist, we have to move beyond A1C alone and also consider continuous glucose monitoring for optimizing diabetes management. Thank you. Thank you very much. Once again, thanks to RSSDI Delhi Chapter Organizing Committee and Chapter Chairman and Secretary for giving me an opportunity. Thank you very much.
Thank you, Dr. Bansi. Now I invite Dr. Meena Chavda to give final comments because there will not be any question in this oration. Dr. Meena, please.
So thank you, Dr. Bansi, for an excellent talk. But Dr. Bansi, you were late by 5 minutes and we have recorded that.
No, you had given me, I think 1:33 I started. So
I'm
sharp
so
at
sorry.
4 o'clock I
That's
finished.
in a lighter vein because Dr. Makkar was called elderly in one of our previous talks. So awesome lecture on time and range. And now we are moving forward. And I have seen when you took the patients for a type 1 trek, Dr. Bansi, it was amazing how my 3 patients who went for the trek came back empowered. And those 3 then, they told everybody else. And that is how they were flaunting their flash
All
glucose
on the
monitors.
continuous glucose monitoring.
Yeah. So Dr. Bansi, you are the pioneer and a very, very big thank you for motivating even my 3 patients, then who motivated the others so that flash glucose monitoring became very, very popular among all my type 1s. So I think an awesome lecture, and as usual, you motivate many more people to follow in your footsteps. Thank you so much.
Thank you.
That wonderful oration.
Thank
you. Thank you, Dr. Bansi. And now I thank you, Dr. Shalini, as well, because for the next session, we have Dr. Girish Khurana to take care. Dr. Girish Khurana, please. Is Dr. Girish Khurana there? Dr. Girish?
Yes, sir. Coming.
Please start.
The
next session is on endocrinologist approach in managing diabetes in elderly.
Yeah, good afternoon, everyone. And on behalf of RSSDI Delhi chapter, I welcome all the delegates and speakers. And to start with this second half of our conference, which should have been a post-lunch, but since we don't have any lunch today, there has been no scope. Our chairman has not set any lunch today. So in this session, I would invite Dr. Sujit Jha for his lecture on endocrinologist approach in management of elderly. And to chair this important session, we have none other than Professor Vinod Kumar and Dr. O.P. Sharma sir for chairing this session. And Dr. Vinod Kumar is a legend in himself, and I don't think he needs an introduction. He is a founder secretary of RSSDI, and he has so many accolades to his record, and he has been recipient of various awards, including Distinguished Service Awards from RSSDI. He has been a professor and head of PGI Chandigarh Department of Endocrinology, and he is on panels of various advisory boards. And the second one is Dr. O.P. Sharma, who again is a patron and a teacher distinguished. He is a professor of geriatric medicine, working currently in Indraprastha Apollo Hospital, New Delhi. And he is General Secretary of Geriatric Society of India, and he has been a core committee member of International Council on Adult Immunization. So I would request these 2 chairpersons, who are our mentors and teachers well, to conduct the session on management of diabetes in elderly. Over to you, sir.
This session also a sponsored session by MST. Yes.
Well, we both chairpersons are extremely grateful to RSSDI Delhi chapter and Dr. Meena Chavda and J.K. Sharma, Girish in particular, for this opportunity. In this session, we have a very firebrand speaker, none other than Dr. Sujit Jha from MEX. Sujit has a long clinical experience as an endocrinologist. He has been involved in various trials I don't think anybody will miss the name of Modi 2 gene, where he played an important role. He, besides being an excellent clinician, has been a teacher and is a teacher in India about the MRCP examinations. He has been an examiner of MRCP also. What people do not know about him and what we personally know, and I think many of the RSSDI core committee people will know, that he's the only person I know of who induced hypoglycemia in himself to have the feel of hypoglycemia, which his patients might be having occasionally. Let's be wiser to learn from Dr. Sujit Jha the special aspects of diabetes in elderly, because I know hypoglycemia is one of the big concerns which can lead to stroke, atrial fibrillation, and many other problems. He is going to take us to the journey where he's going to tell us the management of diabetes in elderly patients. Over to you, Sujit.
Thanks,
Look
Professor
forward for a
Sharma. Thank
wonderful
you.
lesson from
Thanks
you.
for the nice introduction, sir. And it's always very scary to talk about the real professors. We are pseudo professors. You have started teaching and gradually getting older, become a professor. So nice to see Professor Kumar and Professor Sharma. And I must start. Dr. Sharma, सुनाई तो दे रही है ना? दिख भी रहा है मेरा?
Yes.
Sir, you are audible, your slides
Yes,
are
sir.
visible, and you are also visible.
Good.
Please continue. Please continue.
So, when I was doing a medical education in UK, and one of my boss was geriatric professor, and he said that, and I was trying to choose endocrinology. He said, if you are a gutsy physician, you be a geriatrician. Because there is no evidence. I'm talking about 20 years ago, 15, 20 years ago. So if you have a gutsy physician, you need to be a geriatrician. And if you want a solid number, if you don't have a brain, then become a cardiologist. With all due respect to all the cardiologists in this session, he said, because there's so much of evidence. I'm talking 20 years ago, so much of evidence of aspirin, statins, blah, blah, blah. So being an endocrinologist doesn't mean you can be an elderly physician as well. But so I'm very careful on what I'm going to talk about it. I must say, I'm not very happy with Dr. J.K. Sharma and Meena. I have to spend 30 hours with this, sir. बहुत समय लगा इसमें. So I will try to be concise and I'll try to be, I've read a lot about it because I'm encroaching the area which is not that evidence backed. You talk about EMPA-REG study, I can talk in the middle of the night after a couple of whiskey, but this is a tough topic to get into. And I'll try to generalize it. The aging population is there. We know that, I'm not going to go on number of aging population, how much we have, and it's very important to understand this is an increasing population. The more we live longer, the more it is. And unfortunately, in India, still the cardiovascular and diabetes is rising, but elderly population would go up because ultimately we have started treating diabetes, blood pressure. As you can see, the Italian village is dying because why? Because their age of the population was 85. Average village population, because they've been treating diabetes and cardiovascular disease. In our country, it's a bit slow to start, but we still have a long aging population. It's a huge burden to healthcare system because they are not just one disease. It's a multiple disease in elderly itself. They could be fit elderly, they could be unwell elderly. So it is a huge burden to the healthcare system, which can allocate the budget, and increasing population in the United States, it is increasing. We all know this graph is familiar. The beta cell has been done right from the age 35 to 65. The impaired glucose tolerance test, the first phase and the second phase go by age. So even if you're not so-called prone to have diabetes, you will eventually develop diabetes. So because your beta cell is failing. The general assessment when I'm talking about diabetes, you can't take a 75 years old and treat diabetes like a 30 years, which Meena had the opportunity to talk about young diabetes. They are different lot. They have a huge other issues which can play up, and you have the blood test which will give you the battery of blood results, not simply an HbA1c and the creatinine and the proteinuria, but we have different results which might confuse you sometimes because the thyroid dysfunctions, the TSH going up high, the FT4 going low, so right to adrenal dysfunctions with the hyponatremia going on, you're wondering about hypercortisolism. So there are a lot of things which plays up. So it's not easy, if you find low sodium in an elderly, you start mind thinking that what's going on here, is it the drug induced or is it excess water, SIDH? So it's a complex endocrine pathology because each organ starts having age related changes, and that age related needs to be looked into, right from the skin thinning to muscle loss injecting subcutaneous insulin. So because the bone metabolism changes, risk of osteoporosis is age related by the time you start using drugs. So it's a lot of things to happen. I'm not going to bore you, but I just want to flash one thing. And because I'm talking to a lot of geriatricians in front of me, so I must say that you assess it as a physician, you must assess everything. You can't simply assess HbA1c, cholesterol, and kidney function test the way the number game that we are endocrinologists tends to play with it. You need to look into, as I've worked in geriatrics for a year, it's very important. And my geriatrician consultant will ask me, can patient see properly? Can patient hear properly? Can patient walk properly? Can patient eat properly? Can he have normal functional ability? So these are different questionnaire, cognitive functions, memory. So you need to be very careful. Depression is very high among the patients. You need to have a whole spectrum. You could put a geriatrician hat in our setting. So it's older patients can have different comorbid conditions I was discussing, including the functional disability and depressions and fractures risk. So you need to have overall look patients. I'm not saying just 65 or 75 years old gentleman or a lady, but it's about any patients. You have to look into other comorbid conditions, and it's very important to look for the cognitive dysfunctions, cancer, previous cancer, what has been the problem with the treatment, what's been the creatinine, EGFR. So it has to be looked into the multiple assessment. So there is the mortality. I'm not going to, I looked into the details about how the mortality would be higher with age. We are talking about geriatrics and elderly population. And I'm mainly talking about 65. I know elderly has been a huge debate about when do you call elderly. Some people call it 75, but I'm mainly talking about 65 plus. And if you just look at the graph in front of you, if you have age match control, the diabetes within different A1C going from 6.9 to going to 9.7 tends to increase. At the same time, if you go below 6 also, it's a U-shaped curve, which can make you much more prone to death as well, even with the metformin therapy that have been increased death with an HbA1c of below 6. So you have to be careful. At the same time, we know that increasing A1c tends to have more deaths, more in number of years of diabetes, more retinopathy. I remember one prof in retina, from Moosefield told me, if you don't have retinal changes in 10, 15 years time, the patient has been wrongly diagnosed diabetes. So though we are seeing that changes, sometimes some patients, you don't see any retinal changes, minimal changes, but I'm talking about late 90s and early 2000, when the prof in retina specialist was a wonderful professor, and he taught me spent a lot of sessions with him, and he said, if you don't see changes, just ask the GPs was the absorption, distribution, metabolism of the drugs, and elimination tends to change. So patients tend to have more slower absorption, the gastric pH tends to go up, GI mortality tends to go down. There is a total water distribution tends to go back. Patients have a lean body weight base mass, decrease enzyme inductions, decrease hepatic mass, decrease renal clearance. So there are multiple things which are happening. This itself is another topic to talk about, but I'm just trying to highlight that these things would happen, and that tends to determine how to deal with the drug. Believe me or not, that out of elderly populations in the United Kingdom, 1/4 of admissions are because of the drug polypharmacy. And if my boss will say, look, once the patient is more than 3 drugs, please meet him in emergency in next 100 days time as a geriatrician. So, he used to be very clear about it. Once you have prescribed 4 or 5 drugs, be prepared that this patient would come in emergency and you will be on call and you'll regret prescribing a drug. So you need to be very careful in prescribing a drug. Yes, there is an evidence base. Yes, patients are different. And geriatrician, you need to be really putting your physician hat and know all the side effect, polypharmacy, drug interactions, slow start, steady start. You need to be very careful about it. And, and as I've discussed, there could be different issues, changing dynamics in the family. India has got a different family structures, unlike UK, US, where social services are there, nursing home patients are there. They have a different set of problems, but the poor understanding, sometimes communications, hearing, hard of hearing, they may have better understanding, they have better brains, they have better experience, but they have a poor understanding that may make you decrease compliance with the drug. A lot of aspects, finances, retired people, so a lot of aspect would be guiding it. I'm just talking about the general drugs, We are talking about the COVID times, large number of patients on steroids, almost everybody on COVID-19 above 65 are put on steroids, and we are seeing large number of sugar going up. And I must tell one thing, that steroid-induced diabetes are very difficult to handle. And I wish I would take one topic and lecture on this, that dexamethasone-induced diabetes, because you tend to see an 8 to 10 hours rise. Next morning, blood sugar goes to 90, and the blood sugar can go to 550 at late afternoon, late evening. And that is one of the problems that what we face with steroids. And we know about thiazides, we know about other antidepressants. So patients could be, you may be prescribing so-called endocrinologist, diabetologist, physician as one set of drug, but the patient could be another set of drugs. You can't say, ye meri cardiologist wali dawa hai. You know, this is what I hate sometimes, when sometimes patients or doctors say, ये तो cardiology wali dawa hai, but you have to look at the interactions. There's no called cardiology wali dawa. This is your medications. You should always please encourage them to make a list of medications, multiple vitamins they are taking now, zinc, all that stuff. So you have to be very careful what drugs they're on, and selected disease that may aggregate the medication conditions that we all know about it. I'm just highlighting that how the steroids are being used, number of anticholinergics, number of other hypertensive drugs which can be used. So what are the strategies? Is very important. These are very standard, nothing special about it. In elderly, you must not discriminate them. Give them a whole assessment, a battery of tests which is internationally accepted guidelines, but think about vaccination as well. I'll come back later. But anybody who's 60, 65 or 70 years old, the functional status, the cardiovascular status has to be looked into. You cannot just have the HbA1c and the blood pressure, though we are in the telemedicine world, which is difficult time, but the functional status and component is very important. Who's the carer, who's calling, who's giving you the data, is the patient having blood sugar reading. So you have to have a whole risk benefit to analyze. And we have been prescribing insulin on a teleconsults, scary for all of us, but you need to understand who's at home, who's sleeping with him, who can give a call. All that stuff is very important. And also, we need to understand that, the patient with diabetes needs to have a different goal. And as the topic is elderly diabetes, it is different from young people or middle-aged people below 65. I'm not saying that age is the only thing. You can have a fit 75, you can have an HbA1c of 6.5, you don't discriminate that, but the functional status, how much frail that patient is, how much mobility patient is the patient bedbound, can go to walk and do shopping, can drive. So I've got my elderly father who's 85 years old. Believe it or not, he had got a screen. He started seeing patients. We couldn't stop it. All four brothers tried to stop him. He is active, seeing very, and asked me difficult question on diabetes and endocrinology from his clinic sometimes. But I couldn't discriminate him. So he's fit and fine, thank God. And others who are fit should not be discriminated. At the same time, those are frail, need to be looking into how they are, and the targets are different, which is in front of you. Most of you will look at the screen and use your physician bet. Don't use your cardiologist, endocrinologist number game bet. You need to calm down with an elderly population. Mainly I'm talking about the several comorbid conditions. Don't go by numbers so much. Go by what patient can take, what patient can achieve, and what you can achieve. So it's very important that not enough trials, and somehow discriminatory trials are there where you don't do 75, because there I can't blame them. Doing a trial in 75 is on its own challenge. Older patients and A1C could be an issue here as well, because the patient can have chronic kidney disease, chronic liver disease, can have anemia, can have recent transfusion because of other things. Patient can have acute illness and hospitalization. So there are different factors. When you look at the report, you need to see that patient has been hospitalized recently or not. If the patient has a recent blood loss, can change your HbA1c. This is the most important slide, I would say. The green one, fit, don't discriminate, don't be ageist, be life expectancy could be higher. You can't predict somebody's life. If and just by looking at the number, you need to understand that how much patient mobile, what was the previous diagnosis, what the patient did have a previous cardiovascular disease, but roughly can have life expectancy estimated. If the patient have good life expectancies, go aggressive, but beware of hypoglycemia. Any age, be it 30 years old, but when it comes to 65, 75 years older, you need to be very careful. You don't need to achieve 6 HbA1c. Please be careful on that, especially above 75. the life expectancy is less than 10 years time, you can play around at 8. But if you have a very frail patients, sometimes it's difficult to achieve in Delhi population because people keep checking Delhi sugars, they look in the internet, very difficult, and they come back with a blood sugar of 130, fasting very high in a stroke that we don't need to bring it down. It's very important to individualize the course. So you again going back to put your physician's hat, think about overall patient status. So there are different disadvantages of hyperglycemia besides dehydration, cognition effect, risk of infections, functional decline, falling, increased risk of falling. There is a lower reabsorptions from the tubules as well. So what the whole thing has shown, including the cord shown, has shown patients, trials have shown that hyperglycemia is an important aspect. You cannot ignore it, but as long as be worry about the polypharmacy as well. And we know that once you decrease the HbA1c in any population, the risk of hyperglycemia increases. And we all know that wonderful agents like insulin and sulfonylurea, that what we use in general practice, what we use in general population is got risk you do, the more the hyperglycemia you create.
Dr. Jha, you have 2 minutes more, sir.
About 30 minutes, I thought.
No, sir.
This started 2:15.
10 minutes question answer.
Okay, sorry, I've got two. Sorry,
not many people would like to ask you questions also.
Okay. So I'll take 3 minutes more, so 5 minutes. So lifestyle modification. Yeah.
Please continue.
Yeah. So lifestyle modification is very important. It works. One word. Even elderly, the DPP prevention studies have clearly shown, because they have better adherence in lifestyle prevention, it works in majority of the people. And if you do the medical nutrition therapy, it also works. It brings sugars down in a randomized control study above 65. Drugs, I'll come back to one. I made it, after long thinking. And there are 2 slides I would like to show. Please be aware, on the far extreme, glimepiride works forever in elderly population. Please don't think you give a 0.5 of glimepiride, it will last forever if the kidney functions are higher. The biological activity can be 36 hours. I have seen 6 days hypoglycemia with glimepiride, and we investigated everything. And once the glimepiride effect lost, so be careful about glimepiride, believe me or not. Especially I'm talking about that elderly population with a renal dysfunction. So be careful, be aware of short action and how much they're aware of. Metformin, controversy happened, but metformin still low evidence to not to use it. GI side effect is a huge trouble. If you have a diarrhea, always stop metformin. Unexplained weight loss, always stop metformin. Sitagliptin, DP4 inhibitors are a good choice in patients with elderly populations compared to the SGLT inhibitors because of the way it works. So I would like to just stay on this graph, that metformin, be careful about the diarrhea, sulfonylurea, avoid fixed dose combination in elderly, because if you're giving morning, evening, you can have hypoglycemia. Alpha glucosidase, you can create diarrhea. Glinides, hypoglycemia. DP4, it's not because it's MSD sponsored. I tell you that DP4s are one of the safest in elderly who are frail and fragile with a one long-acting insulin if you require it. I always say, one long-acting insulin with DP4s. And SGLT inhibitors, volume depletions, be aware about it. If you look at the evidence on CV outcome studies, EMPA-REG, sub-analysis, and Canvas have shown elderly populations benefit. GLP leader studies, subgroup analysis, not much benefit. Insulin, be careful, use it in majority of the patients with osmotic symptoms. So I think I already discussed that. I will just skip on summary of evidence on is that it's a U-shaped curve. Don't go below 6.5 and 7. Be careful about below 7. Don't go above 9. Cardiovascular disease, hypertension, ACE inhibitors, yes, ARB, but if it's too late to protect it, don't use it because you will play with the potassium and the creatinine. Calcium channel blockers are better. You do have advantage with hypertension. You do, I'm sorry, I thought it's 20 minutes, 25 minutes, so I'm sorry. I'll just skip it, 1 or 2 minute slide. Aspirin, dyslipidemia, statin is a must in one word. Be careful about side effects. Don't have to add fenofibrates. Most guidelines suggest statins. Aspirin, not for primary prevention, for secondary prevention. Now, pneumonia, 3 times much more risk, must vaccinate. RSSDI guidelines clearly suggest vaccinations by PPVSV 23 vaccines, 1 and after 165 repeat again. This is the max data about diabetes. This is a patient who the 77 patients with diabetes, majority of them ended in ICU, 14% died. So there are 3 times mortality. If you look at this graph, I know I'm running the slides. If you look at 3 comorbid conditions in max data of more than 1,000 patients, the mortality increases with the COVID-19. I couldn't skip not talking about COVID-19. So endocrine issues, osteoporosis with glitazones, some question about canaflosin, and the conclusion is that it's a elderly is not a homogeneous group of population, heterogeneous group of populations. Don't discriminate then. Be aggressive about control, but be aggressive about the hypoglycemia. Be aware of what side effects you can create, and you can prevent cardiovascular disease, stroke, disability by using the cardiovascular medicine. Must vaccinate them, and talk nutrition, talk about the diet. Over to Dr. Sharma. Sorry about
thank
running.
You so much. Thank you so much, Sujit, for a wonderful overview of aging, the various changes due to aging, the issues regarding pharmacokinetics and pharmacodynamics, and the guidelines how to use them. May I request Dr. Vinod Kumar now to conduct the Q&A session. Over to you, Vinod Kumar, sir.
Well, Dr. Jha, can you hear me?
Yeah, we can.
Yes, Dr. Jha, you have made the whole complex subject expressed in such a simple and beautiful language. And I think your lecture once again highlights the fact that the elderly individuals are highly complex and heterogeneous. This is in relation to caring for any disease, particularly for diabetes. And I would like to specially emphasize the 2 major problems in elderly people which have strong bearing for the care of diabetes. One is dementia, other is frailty. You did mention about frailty as well as cognitive impairment, but I would like to say that people who have dementia, even early stage dementia, they cannot self-care. They do not know when and what kind of medication they have to take. They don't recognize the medicines after some time. They forget when they have taken the meal. They forget when they have taken the water. And therefore, they are not able to self-care. And the same, to a large extent, applies to frailty, where the mind does not die, but the body is slowly dying. They are having disability. They again cannot take care of themselves. So with all this view in mind, I would just like to appeal to the RSSDI that although the RSSDI has made beautiful recommendations for diabetes standard care, but I would like to point out that many advanced countries who have much lesser population of elderly people than what India has, they have separate recommendations for standard care of diabetes in elderly. Like, for example, American Geriatric Society, Canadian Geriatric Society, and also the European Geriatric Society. And I'm very happy to tell you that at the level of Ministry of Health, under the Ayushman Bharat scheme, while looking into the operationalization of the health and wellness centers, we are also designing the standard of care of various diseases, including diabetes. And I would appeal to RSSDI that please either make these recommendations or send 1 or 2 experts. You can send them to me and I can put them into the Ministry of Health expert group, because these standards of care for diabetes and elderly are very different. And you know, in view of the COVID-19, the vulnerability of elderly individuals on multitudinal susceptibilities has come to the light. And now these days we are talking about elderly people almost daily on some subject or the other. So I think this is the right time, and the future is not very far when there will be 1 out of every 3 persons in India will be more than 60 years old. So we have to prepare ourselves. So this is my appeal to RSDI. And I once again very much appreciate that Dr. Jha has brought out these points at forth in such a beautiful lecture. Thank you, Dr. Jha.
Sir, I think we may give some opportunity to the participants. If anybody wishes to ask a question to the learned speaker, he or she is welcome.
So, Dr. Sharma, my question is, age is not a number. It is sarcopenia, frailty. And as a nation, we eat low protein. So aren't we elderly earlier? And we don't exercise. particularly muscle strengthening exercises. So do you think we can we have different guidelines because we are sarcopenic, frail, or elderly?
Madam, it's a very important question. I think Dr. Jha would like to answer.
Dr. Sharma, go ahead. I think better you answer it, sir.
Oh, thank you so much for the opportunity. You are very kind. Dr. Chhabda, it's a very important question that you have raised. That is one of the reasons, as Dr. Jha explained in his talk and Dr. Vinod Kumar also pointed out, that we always look for ADL, activities of daily living, and accordingly after seeing them, after getting satisfied, then only we empower them. Regarding sarcopenia and protein intake, it's a very valid question, and that is the reason that we as physicians are always careful in prescribing such drugs which are either albumin bound or globulin bound, because in them their pharmacokinetics may vary. This is true that in India, the nutritional issues are always prime. And as a matter of fact, we should have comparatively less stricter guidelines for control of sugars and be vigilant more about the side effects. However,
can I add to what Dr. Sharma says?
Yes, sir.
Well, I would just like to point out to Dr. Meena Chhabda that there are many elderly diabetic people who start losing weight after the age of 70, 75 or 80. And this is an unintentional, unexplained weight loss. For example, 5 to 6 kilograms in 1 year. And then what is the reason? That there are two reasons. One reason is that they are losing the muscle mass. They are getting sarcopenic. But from outward, they look obese or overweight. So this is sarcopenic obesity. So you have to increase the protein intake. And unfortunately, many of these people are poor. They are on high carbohydrate diet, and that to the cheaper carbohydrates, because they cannot chew the complex carbohydrates or for that matter, any other food stuff because of their teeth problem. So because of poverty, because of the changes in their aging, they are taking carbohydrates. So once they have a loss of weight and they have sarcopenia, they must somehow switch on to protein. And there are some proteins which are inexpensive, but the advice is lacking. That is number one. Number two, some of these people who are losing weight unintentionally, they are on metformin. Some of them are 1 gram twice a day under no close medical supervision. And the cause of this weight loss is metformin. I just saw one paper that Dr. Sujit Jha said, recommending the stoppage of metformin in some elderly people. So in these patients, the metformin must be reduced, although it is a wonder drug for diabetes control, but not at that age when they are losing weight. So you have to bring down the dose or even stop it. And metformin has another problem. It causes vitamin B12 deficiency and it therefore enhances the cognitive impairment. So these are the practical tips that one should know when you are dealing with elderly people with diabetes, and especially relevant to the question that Dr. Meena Chhabda has asked. Thank you.
Thank you.
I think it's a very important thing that we always stress that metformin first, but that should not be a case in case of elderly.
Yes.
Elderly who are either losing weight or who have GI intolerance, in them metformin should not be used. And however, vitamin B12 supplementation should always be done, like vitamin D supplementation, which is very relevant during the COVID periods. As a matter of fact, initially when the data came that there was 14% fatalities in elderly, I was quite worked up and I tried to get sub-analysis done. And it was found that it was not because of the age, but it was because of the uncontrolled comorbidities that these people were falling prey to COVID. And the commonest name was uncontrolled diabetes. So I think endocrinologists have a bigger role to play during the COVID period. Thank you so much. By thanking the learned speaker, we would like to wind up the session.
Last point I want to say that
yes,
the guidelines which exist for standard of care for diabetes, they are often divided into three kinds of elderly people: the dependent, the partially dependent, and independent. And another way of classifying them from the point of view of diabetic management is those who are independent, those who have dementia, and those who have frailty. All these tables are given in various guidelines all across the world, particularly in the Western countries. So I would once again appeal that we should get up to make these guidelines in India also. Thank you.
Thank you so much.
Thank you. So one last word, please use basal insulin if you're getting trouble with elderly patient with weight loss, which I wanted to highlight in my next slide. 5-6 units, there is some patients do so well. So that's one take home message as well. Don't be reluctant to give insulin. They don't get so much of hyperglycemia. Thoda sa insulin,
we fully agree with you. We fully agree with you, Sujit.
Sure.
Basal insulin plays a very important role, especially in a situation when they are losing weight. Thank you so much.
Thank you. Thanks, Dr. Sharma. Thanks, Meena. Thank you, Dr. Sharma. Thank you, Dr.
Thank you, Dr. Sujit. I am taking little liberty, Dr. Girish, in welcoming Dr. from USA, and she was not supposed to come, but it is her dedication towards RSSDI Delhi chapter and her love for we all the members of RSSDI Delhi chapter. And the name is was Dr. Usha Sriram. I think everybody knows Dr. Usha Sriram. And I welcome Dr. Usha Sriram from the Governing Council of RSSDI Delhi chapter. And Dr. A.K. Das has also joined. So now this next symposium on nutrition will be taken care by 4 people, Dr. Shalini, Dr. Usha Sriram, Dr. Kavita Gupta, and Dr. Rucha Mehta. So I invite Dr. Girish to please introduce Dr. Shalini. Dr. Girish.
Okay. Now I invite Dr. Shalini Jaggi to...
Usha, I'm grateful to you for writing the first chapter on nutrition in my first book in 1999. Thank you, Usha.
Wow.
Carry on.
Thank you. Thank you so much.
So to start with this symposium on nutrition, I would like to invite Dr. Shalini Jaggi to moderate and chair this very important session. Dr. Shalini Jaggi is a member executive council of RSSDI National, and she is joint secretary of our RSSDI Delhi chapter, and she is on governing council board of DIPSI. She has a recipient of National Fellowship of RSSDI. She has done a number of courses, and she is a faculty and tutor of Cardiff University and University of South Wales. And she has done observership at Joslin Diabetes Center, Boston and West New York. She is a certified trainer in insulin pumps and CGMS, and she has got numerous publications in reputed national and international journals to her credit. I'll invite Dr. Shalini Jaggi to please introduce the panelists in our next symposium.
Thank you so much, Dr. Girish. Let me first categorically welcome Dr. Usha. The story behind the entire miscommunication has been that Dr. Usha has been on our panel for the nutrition symposium right from the beginning when we conceived the program. 3-4 days, she was suddenly not reachable. That's when we got news that she had to rush to the US for some emergency. And then as a contingency, it was decided that just in case we are not able to get madam at the last moment, probably I will fill in. But we're so happy that ma'am has actually stood by her commitment. She's woken up so late in the night. I think it's 2 a.m. in the US now. And
No, 4 a.m.
4 a.m. Oh my God. So, 45 minutes before this session started, I actually called her up, just to ensure that ma'am has woken up. So that's the amount of commitment, because yes, she had said, yes, she will be part of the symposium and she'll moderate it. She's actually made it a point to get up so late, so early in the morning, let me say that, and be part of this symposium. So a special thank you to Usha ma'am for honoring us and joining us so late in the hour to keep up your commitment with us. Before we proceed further, let me just introduce the panel formally now. So we have Dr. Rucha Mehta, another very young budding endocrinologist and diabetologist, a very close friend, and one of the peers I actually admire for her knowledge. She is endocrinologist and diabetologist of Edmo Clinic, Ahmedabad, and also Apollo Hospitals, Ahmedabad. She's chair of Research Ethics Committee at Mulji Bhai Patel Urological Hospital in Nadia, panel of expert group of diabetes and obesity of joint RSSDI ESI clinical practice guidelines. She's been the HOD Endocrine Department, Global Hospitals, Mumbai, director of research, Western University, California, clinical faculty, UCLA, and director of diabetes clinic, VA Hospital, San Antonio, Texas. And she's hugely interested in a lot of academics. So welcome, Rucha. Happy to have you on our panel. I also welcome Dr. Kavita Gupta, Director Nutritionist Diabetes Educators, Sunil's Diabetes Care and Research Center Private Limited, Nagpur. She's presented research papers at various national and international conferences. We've always seen her a very, very common face when it comes to any discussion on nutrition. She's also the Honorary Secretary of the Indian Dietetics Association, Nagpur chapter, and Joint Secretary Association of Diabetes Educators. She has a keen interest in pumps, CGMS, diabetes education, and has a special interest in type 1 diabetes, GDM, and obesity. So welcome, Dr. Kavita Gupta. I would also like to share Dr. Usha's introduction slide here that I have. So Usha ma'am is a very, very common face, a very popular face when it comes to endocrinology, and especially the women's issues when it comes to diabetes and endocrinology. Madam is HOD, Department of General Medicine, TAG VHS at Chennai, and is also consultant endocrinologist and diabetologist with profound passion for women and diabetes, women and endocrinology, and hence she is the founder of DIVAS, an association of a lot of endocrinologists and diabetologists with special interest in women. So she's gotten all the women all across India together in this organization, and we're all trying to spread the message of women's health all across, not only in India, but globally. So welcome all of you, and I'll hand over the proceedings to Dr. Usha. Let me just stop sharing. Yeah. So welcome, Usha ma'am, and you're free. Please take over.
Thank you so much, Shalini. You've all been so gracious and kind. Actually, I'm jet lagged and quite awake and no problems. I'm so happy to be, joining all of you. And this topic particularly is so important. And I'm so happy that Kavita is part of this panel, because I think when it comes to managing diabetes, and this is a very interesting thing from the last session to move on to this one, because such important points were brought up about sarcopenia and nutrition in the elderly. I mean, I learned so much just by listening to that session. So there is such a nice, interesting, bridge to this session. Nutrition is we talk about 4 pillars of diabetes management. Probably nutrition is like the most important, biggest pillar in all forms of diabetes. So, but the thing about nutrition is it has evolved over the centuries, from being, giving people liquid diet to high carb diet to high fat diet to, low carb diet, to where we are now about intermittent fasting and keto and paleo and all kinds of diets like that. So there's even we as physicians, I think, need more clarity on this. Can you imagine the patient who has diabetes with Google and WhatsApp University and all that? They have so much of disinformation about nutrition. So what we'll do today is just very briefly, I just wanted to show a couple of slides on the historical perspective and also how important nutrition is in diabetes management. We discuss about 3 or 4 clinical scenarios, and finally a little sneak peek into what's coming up in the future, probably when it comes to nutrition. So if you can share the slides, from that end, I sent the slides, if it's possible.
Yeah, I can do that. Should I do that, Shalini?
Only because I'm standing up in the terrace with my phone, so I don't wake up the others.
Dr. Usha, you can just tell me when you want me to change the slide. I've got your slides here.
Yeah, you can go to the next slide. So, like I said, what we will do is just briefly look at the historical, some information of historical interest, and then the importance of nutrition, clinical scenarios, and a look through the crystal ball. Next slide. So, see, as far as historical perspective, I think that particular slide has not shown up. They have shown as early as in the early part of the 20th century, that increased intake of carbohydrates and sugar was one of the big negatives when it comes to Indian diet, and lifestyle modification and dietary interventions have been the key components of therapeutic strategies in patients with diabetes. And I think everyone on this panel and who's listening knows that modification of the diet itself, how much it can improve the glucose control, the variability, the blood pressure control, lipid control, weight management, all the key aspects of what we are trying to do with the nutrition. Next slide, please. So there it is. So this is a beautiful piece of information I wanted to show, that in 1907, and this was published in the BMJ in 1907, and said that made an alarming observation that type 2 diabetes was increasing rapidly among the wealthy Bengali Indians living in Kolkata, whereas it was still rare among the poor Punjabi. And so now we know all those things have changed, and Chandigarh and Punjab and Haryana, probably some of the richest parts of India, linked with an increasing intake of sugar. So if we can somehow stress that the importance of carbohydrates and the importance of sugar in our diet, because I think a lot of disservice has been done over the last 50 years, focusing on low fat as opposed to low carb. And I think that may have caused a lot of our problems. Next slide, please. So if, as you can see, there's been a lot of evolution. The pyramids keep changing, the plate keeps changing, the concepts keep changing as far as nutrition. So when we go through the clinical scenarios now, we'll take the help of Kavita and Rucha and on how things have changed and what should be our focus now when it comes to nutrition. So we can go straight to the first clinical scenario. And Rucha, if you can read it out, then I think Kavita is going to handle the clinical scenario 1 and 2, and then we both will also chime in.
Sure. Great. So we have a 42-year-old man working as an accountant, and he undergoes his annual master health checkup because his wife insisted. His BMI is 28. His elder brother has diabetes and his grandfather has diabetes, and his mother died early due to lupus at the age of 38. So certainly he has high risk factors. As we know, BMI 28 qualifies him to be in the obese category, almost class 1, very close to that for the Asian classification. His fasting glucose, as you can see, is 112. So it's in the pre-diabetic range. And his HbA1c is 6.1. So again, he's in the pre-diabetic range. Total cholesterol we have is at 235. His HDL is low at 35. His triglycerides are 200. And his LDL cholesterol is 160. So raises a lot of questions. Number one, does he have diabetes, or what would you classify him as, Kavita? Maybe you can lead us, and how would we counsel him? Is it enough just to have a weight reduction diet? Do we need to get more information? And then we'll come to the last question. Why don't we first start off with Kavita? How would you approach this case? What would you, how would you sort of counsel him? Because he was in denial, not even wanting to do the annual health checkup till his wife insisted.
Right, right. So thank you very much. I would like to thank the entire team of RSSDI Delhi chapter, Dr. Shalini Jaggi, Dr. Sharma sir, Dr. Meena Chabra madam for having me over here. And thank you, Usha Sriram madam, for being here. It is a great pleasure, to having you here. So yes, first, I think is like, how should we counsel him? Yes, he is the right candidate for nutritional counseling. So we need to, as he is in a pre-diabetic state, and this is the phase where we can think about reversal. And there are number of trials, say maybe DPP trials, DACWING trials, and there are many trials which has shown the role of lifestyle modification in helping them to prevent into helping them to move to a reversal of diabetes. So first I would like to specify that we would counsel them for MNT. So we all know that MNT is important for such a case. So there we will be actually restricting his amount of carbohydrates. We all know that the ADA does not have a specific numbers for the macronutrients, but yes, RSSDI guidelines and the ICMR guidelines have a specific, say, around 50 to 60% of carbs should be taken. So on, like, for a diabetic especially, I would focus more on complex carbohydrates, where and reduce the simple carbs, where we would be asking them to change his dietary pattern. Of course, first I would need his 24-hour dietary recall, understand what is his dietary pattern, see his food frequency, and then we would focus more on complex carbs like coarse grains, and adding more of proteins, what we were talking about, adding more of fiber in his diet. That would be more important, adding more of sprouts and salads in his diet. So will his weight reduction diet will be enough? Not only weight reduction, we need to also focus on other aspects, like because he is dyslipidemia, he is so we need to have his lipid levels also on control. And secondly, I already told that we need more information on his also on cultural food habits. You know, what type of food is he taking, so that we are able to mold him. We've also always counsel the patient with their spouse. You know, so it's more easy to understand, and we get better compliance from the patient. You know. And what is the role of meal replacements? Yes, and again, there are number of trials, the look ahead trial. Then we also have a pilot study of Dr. V. Mohan, which has shown the role of meal replacements, which has helped to reduce not only the HbA1c, but also the lipid levels. So yes, we can incorporate meal replacements, replace one of his meal with any meal replacements, which will help them to give to reduce the amount of energy, and at the same time give them appropriate nutrients. And I think we can also think about, I would also like to understand the meal, like, you know, to understand what is the composition of the meal is, so that if I can, you know, help him out to change the composition of this particular meal.
Thank you,
Thank you,
Kavita. Dr. Usha, I would like to ask you that, would you sort of tell him calorie reduction versus macronutrient manipulation? And if we do ask him to lose weight, as Kavita pointed out, how much weight should he lose to prevent this progression from pre-diabetes to type 2 diabetes? The two questions, please.
So I think first, Usha, I want to say thank you for using the word progression to type 2 diabetes, because, you know, I also think that what Kavita said about reversal to back to normal is really important to tell the patient that this is the only time that they can go from being pre-diabetes back to no diabetes. Because once you have become diabetic, you're always a diabetic. As they say, you cannot put the toothpaste back into the tube, but you can be very, very well controlled and in great shape like a normal person. So the most important thing is not to progress. If you're normal, you don't progress to pre-diabetes. If you have pre-diabetes, you don't progress to diabetes. If you have diabetes, you don't progress to complications. And if you have complications, you don't progress to death. So no progress is good progress in this one particular situation. And I think we need to stress that very importantly, that we have caught them early. And I also tell the patient there is no special diet for pre-diabetes. Pretend you have diabetes. And so the diet is primarily a diet that we would prescribe to people with diabetes. And the good thing is most often, majority of the times, they are not on any medications. So there is no major adjustment to the activity of the of the medication. So a balanced diet, I would focus definitely on the weight. Even a weight reduction, it's been shown in DPP and Look Ahead and everything, a 7% weight loss is enough to make major metabolic changes. So we don't want to tell them, I want to see a BMI of below 23, but we want to say that keep on losing very gradually. So even if they lost half a kilo a month, it's 6 kilos in 1 year. So that kind of very gentle, doable, sustainable weight reduction program is what we should prescribe to our patients. And as Kavita nicely pointed out, focusing on the amount of carbs. And when the question that I put in there, do we need more information, is primarily a complete, history about what kind of work does this man do, what is his eating habits, likes, dislikes, food fads, allergies. Only if we take all that into account, and what can he afford? Only when we take all that into account, we can tailor a proper diet for this person. But I think we are losing a great opportunity in people with pre-diabetes. If we can catch those people, we can cut down the amount of diabetes in our country going forward.
Great. Thank you so much, Dr. Usha. So great. Now we have this young gentleman with what we call the metabolic syndrome or the insulin resistance syndrome, and we are really going to try and educate him, understand his cultural background, financial background, using a dietary recall or even a 3-day dietary recall, and counsel him to lose anywhere from 7 to 10% weight so he does not progress to overt dyslipidemia or overt type 2 diabetes. Let's see what happens further. I'm just trying to, let's see. The slide. So the gentleman we met earlier, we are 3 years into the game. He's 45 years old. His BMI is 27. So he did listen to Dr. Usha. He tried a slow and sustainable weight loss. But however, his fasting blood sugar has progressed to 165. So he's overtly diabetic. His HbA1c is 8.8. Lipids, as you can see, total cholesterol 265. Still a low HDL. Triglycerides are higher at 310. His blood pressure is not at ideal level for a now diabetic patient, 146/96. And unfortunately, his lifestyle, as we said, he travels a lot due to clients all over India, poor sleep habits. So what will you do now? Should we change or give him a little bit more aggressive diet? How do you counsel him to eat smartly when he travels? So even though we said there's no proper proportion for carbs, can you give him something simple? His wife wants him to try a keto diet, and he really is now interested. Finally, now that he has diabetes, the toothpaste is out, but he wants to put it back in. So how do we reverse his diabetes?
For that matter, so many of our diabetic patients who just turned diabetic come back and they want keto diet or intermittent fasting. So I would like all the 3 panelists to kindly comment on that.
Okay.
I would just start with it, like how we would be treating now. Actually, again, we would be what I feel that this patient is non-compliant. In spite of all the diet and everything what we have given, this patient is not compliant, and his HbA1c has increased, even his lipids have increased, and now he has metabolic syndrome. So that is where we need to focus. We need to give a holistic approach where we can incorporate maybe a physician or endocrinologist or dietitian along with a diabetes educator, and we need to ask him to be very compliant first with his diet. We need to plan for him a complete lifestyle modification. I think that would help him for attaining his good glycemic control. And as he is traveling a lot, I would suggest that I think a wife should play a major role where she can make some homemade stuff like khakras or chuda or nuts, probably, which can be given and which can be easily taken by him. In fact, this is the time where he can use this meal replacers, and it is especially like where we usually give to the patients who are traveling a lot. Meal replacers help them to have a proper nutrition, especially at the time of traveling. And I think his wife wants to be on a keto diet, and let me just add on a word on keto diet. Keto diet is a diet where the fat content of the diet is very high. It's around 60 to 70% of the meal is fat. Around 20% is the proteins, and only 10 to 15% is the carbs. And especially for such a case where he's traveling a lot, it is very difficult for him to find a food with keto diet, because usually if we see a menu of a keto diet, it's mostly it has a lot of non-vegetarian items and everything of fat. So if he's traveling, it's very difficult for him to balance, to keep himself into keto diet. And even if it has he is at home, still it becomes very difficult. The compliance part, what we actually face with our patients, that the compliance is not we do not get compliance from our patients, especially on the keto diets. And I think most of the dietitians do believe on intermittent fasting rather than keto diet, for especially for diabetics. And about diabetes reversal, yes, there are number of trials like the direct trial and the number of trials which
Kavita, let me interrupt you and put that question to Dr. Usha so that we can get her input. We don't have much time left. So.
No, very quickly, I'm not a fan of keto because I think we don't have long-term effect on, too much protein and too much fat, especially in a person with diabetes, on their kidneys or their heart. In the short term, you will see dramatic fall in numbers, and it will all look really good, and their medications will go away. Everybody is happy all the way around. But we don't know 5 years down the road, 10 years down the road, what is it going to do to their heart or their kidneys or brain or anything. So I think in keeping with that kind of proactive approach and sensible approach, definitely cut down the carbs a lot instead of doing people doing 60-70% carbs. If we can do 30%, like a 30-30-30 or a 40-30-30, it would be still a very, very sensible, still a very low carb diet for our Indian patients, and it's doable. So that's what I am prescribing to my patients. As far as intermittent fasting, for overweight patients, it seems to work well. But for diabetes, there's more and more evidence coming out that it may not be particularly, helpful. And, very difficult to match the medication, because you eat only twice a day, and it's probably around 11 in the morning and 5 or 6 in the evening. And when you take medications that have longer activity, there may be a greater tendency for hypos, and we don't know, or a tendency to rebound and eat more in the morning when you're breaking the fast. And lastly, about reversal, I think, Rucha, you probably have much more experience with that. So you want to comment? I think we may be running out of time.
Yeah, so I'll just briefly say Shalini asked me to put in a word about the fat diets. So we know that recently this week we had the death of a young actress, which was blamed on the ketogenic diet. So just a word is, I really don't think diets kill you. If you are going to do something extreme along with the diet is what might kill you. A diet that was designed primarily for children with epilepsy and was followed for years on end for these children should not be the one to kill you if it's done under supervision. So certainly this is a great case, and I think even if we run out of time, here's a prototype type 2 diabetic patient with dyslipidemia, high blood pressure, and can we truly use lifestyle to reverse all these conditions? So my take is that in the short term, as Dr. Usha also mentioned, to lose weight, you may have to use macronutrient manipulation, caloric restriction, as was shown in the direct trial. The direct trial, which was conducted in UK for diabetes reversal, used a very low calorie diet of about 800 calories for about 12 weeks. And they focused on the fact that patients who lost 15 kilograms of weight, they were able to reverse their diabetes in almost 97 to 100% of the patients who lost 15 kilograms and not percentage. So this is a good number, but this is a UK-based, of course, a UK-based study. A similar Indian diabetes prevention program done by Dr. A. Ramachandran's group in the South showed that using metformin 500 milligrams versus just a simple education about skipping carbohydrates at one meal worked just as well. And these were just farm workers and they were asked to walk home. Nothing, they were not going to the gym, but just asked to increase the amount of activity by walking. And even in them, metformin was the same as lifestyle change. So certainly this is the patient I would target in the short term. Get him to lose that weight early. If you get him to lose the weight in 3 to 6 months, you will mobilize fat out of the pancreas and the liver. So whether you're using a short-term ketogenic diet, and I have a study with a ketogenic diet going on, so I will not say I'm not following the ketogenic diet, understanding it, using it appropriately. And then in the long term, what works best is, as Kavita pointed out, what is sustainable, what is culturally be suitable, and your patients can take their medicines, enjoy the taste of food, and continue that in the long term. But certainly in the short term, we do try and teach them carbohydrate counting, especially for our type 1s and even the insulin requiring type 2. Reducing the amount of carbs has been shown by the ADA as well as all the guidelines to be the most sustainable in the long run for diabetes management and also reduction in medicines. So diabetes reversal is now a reality, and the most important caveat for this has been weight loss. So most of our patients, the obese diabetics, we want to target this 10 to 15 kilograms of weight loss. Of course, we need to understand that Indians are smaller build, so we have to understand the muscle fat ratio and do it safely and sustainably for them and work with them. So I don't know, do we have time, Dr. Shalini, or can we quickly look at one young girl over here?
Yes,
I'll go on till yes, Dr. Sharma, do we have
yes,
time?
we can. We have the time.
5 minutes? Okay. So I'm just moving to case 3. A 14-year-old girl has been diagnosed with type 1 diabetes and she's hospitalized for DKA. She attains menarche 2 years ago. She has severe dysmenorrhea and has vomiting and abdominal pain for 3 to 4 days. She can only tolerate liquids. As you can see now, her BMI is 19 and she's a vegetarian. So is the nutritional advice different over here for different types of diabetes? And Dr. Usha, I'll start with you this time. How do we provide nutritional counseling for children? Did we lose Dr. Usha by any chance?
Dr. Usha, please
It's not really
unmute
that
yourself.
different
Yeah,
for
please.
different types of diabetes, except of course gestational diabetes. But when it comes to young people with type 1 diabetes, children, we really we have to balance many things. We have to provide the right kind of calories and nutrients for them to grow. We also have to get the glucose in control, and we also have to make sure that they don't feel, deprived and different from their peers. So the psychological aspects. And the fourth thing is, how do they cope with these things in school? See, we cannot make them eat something completely different, when their peers are eating something else. So balancing all of this becomes very important. And of course, making sure that they don't, get into DKA or hypo when they don't have supervision, for example, at school or when they're playing. So that's the challenge with type 1 diabetes. And since they have to be on insulin, the food, the way they eat has to match the way their medications work or when their insulins peak. So that's also something to keep in mind. So that's the only difference between in terms of type 1 versus type 2.
Great. Dr. Kavita, do you have any words to add?
No, actually, just about the carb counting, it may sound a little difficult at the initial stages, but when we do a little hand holding, fine tuning with the carbohydrate, make them learn the food exchanges, and then the patients become little, they get acquainted to the amount of the carbs, and they easily calculate the amount of the carbs in the food what they are eating, especially the type.
Absolutely.
Okay. So we do have one more case, but in the interest of time, I'll just see if there are any questions from the other panel members. We have a 53-year-old lady with ASCVD, but I will stop over here. And I see one question in the chat box asking the thermic effect of processed foods versus whole intake food. If anyone can kindly comment, and intermittent fasting, various types, which is better to be followed. So do you want to answer the thermogenic effect of food, Kavita, by any chance? Processed food versus whole foods.
Yes, I think not much aware about that, but yes, I think the processed foods, we all know that we always say that it has to be taken in less it has to be
And
better
so
or
I can give a word. So we have done studies looking at thermogenic effect of whole foods versus protein versus processed food. So when you say whole foods, I'm assuming the Dr. Rahul who has put the question is asking about complex carbohydrates versus protein versus fat versus processed food. So thermic effect of protein in the form of meats and all is highest. You take what it means basically is the energy expenditure spent on processing of food. So the thermic effect of food is highest for a protein. So you will take longer to eat the protein and digest it. Thereby, you may lose more fat in the process. So it has a little bit more in terms of energy expenditure. Processed foods, while your body kind of just sort of pumps it out or may not use it. And therefore, we always, that is one of the other reasons besides the saturated fat and trans fats, why eating complex carbs or protein is better than simply using processed food. So that is just a simple question for an answer for Dr. Rahul. For the second question, Dr. Usha, intermittent fasting, she already spoke about it. Well, a lot of discussion was made about intermittent fasting, and there are various types of intermittent fasting. Time restricted versus patterns of restriction. So I think we can kind of avoid that. Dr. Shalini or Dr. Sharma, do you have any questions for
There's
us?
one, Rucha, there's another question which we'll take in a minute and we'll finish off because we're out of time. This is from Dr. Shilpa Batla, who wants to know how to manage sugar cravings and headaches while a patient is on weight reduction diet.
It's a very, very common problem. When you go on a diet, your body fights with you. Ghrelin comes out, but then you feel more hungry, or when the slight lowering of sugar, you get a headache. So the important thing is to make sure that you have low-calorie snacks in between and keeping yourself well hydrated. It's the starvation that makes people go into all of these things. So small, healthy, low-cal snacks will keep the sugar level slightly on, slightly okay, and people usually don't get into these problems.
So thank you so much, all my
I think
esteemed
Salini, can I just ask one question?
Yes,
It doesn't
sure,
matter.
sir.
So it's to both Usha, Rucha, and Kavita. Between diet and exercise for a type 2 diabetes, keeping in mind the CMB, DC, and the DBD, which one you will recommend will be more beneficial? Of course, the both are to be taken together. Rucha is an exponent of both, so which one will you think is more beneficial, and why?
So for glycemic control as well as diabetes reversal or anything, we all know that diet plays a bigger role. 80% I would say is a contribution of diet. And whatever you want to maintain all the benefits that you've got and also contribute to your cardiovascular fitness, you cannot achieve that with diet alone or with weight loss alone. So for that, you definitely need the exercise part of it. Now, what we have started doing, we actually have a protocol going on wherein we are training our patients, especially the kind of high-risk CV patients post-MI, in the heart rate zone. So we only keep them in 60% of their maximal heart rate zones, which really helps with fat burning and preventing, the cardiac remodeling should not.
Thank
So
you,
we are
Rucha.
really working
Thank you.
on that.
Thank you for the time, place. Why did that young actress died? Why Mukherjee died?
So that is a good question. We always think there must be something else to the story.
Renal failure.
So there are also these keto salts you can take, the beta hydroxybutyrate salts.
This is my
If
fault.
you take those inadvertently, you can go. Yeah, because nutritional ketosis, we always maintain them in trace ketosis. We measure their beta hydroxybutyrate level and we do urinary keto sticks. Whereas in people who are trying, in an actress, she must be under pressure to lose weight aggressively. If you do something like that and go on a very low calorie diet along with that, like less than 500 calories per day, that could precipitate, bad things to happen. So they said
Thank you.
acute kidney
There are a lot of
injury.
things to ask, but we should go ahead. I think my talk is the next, so I will have
Yes,
full
sir.
30
Yes,
minutes.
so we don't want to cut into your talk.
Yeah.
So
Thank you
many
again,
thanks.
everybody.
Usha, my regards to you. Thank you.
Thank you,
Many
Dr.
thanks,
Usha.
Kavita, bye bye.
And Dr. Kavita. Thank you so much for that.
Thanks, Shalini. Thank you, everybody. Dr. Sharma and
Thank you.
RSSDI.
I hand over to Dr. JK.
I'll stop screen sharing once.
Yeah, please. Thank you.
Thank you, Dr. Shalini. And thank you all the 4 young professionals for enlightening on this very important topic of diet. So now we have another 3 very important talks left. And people are much interested in listening to Dr. A.K. Das sir.
Oh.
So to introduce Dr. A.K. Das, I invite our chairpersons, Dr. N.K. Singh. Dr. N.K. Singh is bubbling with knowledge and bubbling with energy, Director of Diabetes and Heart Research Center at Dhanbad, Chairman RSSDI Jharkhand and CCDSI BJ, ex-governing body member of National API, ex-chairman of API Jharkhand, edited Millennium Book of Medicine, over 30 publications. And he is the admin and founder CME India WhatsApp group. And now the website editor www.cmeindia.in, and he has the academic solution of any question related to medicine. I welcome Dr. N.K. Singh, and to join Dr. N.K. Singh is our another important governing council member of RSSDI Delhi chapter, a senior physician, senior consultant, diabetologist at Mulchand Hospital, Dr. S.K. Bakshi. He is actively involved in academic activities and teaching of DNB students, executive council member of RSSDI Delhi chapter, EC member of API Delhi state chapter, former executive member of South Delhi IMA. And I request both of them to invite Dr. A.K. Das sir, to introduce Dr. A.K. Das and then to invite Dr. A.K. Das. Dr. N.K. Singh, please.
Yeah, good afternoon. First of all, I am really thankful to Dr. J.K. Sharma and Dr. Meena for giving me this unique moment when my mentor, my guru, whatever I should tell, Dr. A.K. Das, it is rather a great pride to chair a person like him. जब जिंदगी में दो दोराहे हो जाएं और पता नहीं चले कि राइट जाना है या लेफ्ट जाना है, in that time I think no other guide I think in my mind today except Dr. A.K. Das, and his topic today is also like that. In diabetes, when there is a glucocentric path and also there is a vasculocentric path, and the whole concept in diabetes has changed today, and we are really wondering which side we should go to do that excellent and very unique job. I have great pleasure to invite Professor Dr. Ashok Kumar Das, consultant physician and endocrinologist, PIMS, patron RSSDI, co-chair ICMR India Diabetes Study. He is also chair diabetes in the young registry. If I go reading details about him, it will take at least, I think, 10 minutes. So without wasting time, sir, great pleasure to inviting you for your talk. Thank you, sir.
Thank you, Dr. N.K. Singh, for a very, very generous introduction. Thank you, Meena. Thank you, JK, for inviting me for this exciting event. And I'll directly go to the topic because I have little more slides, but I'll finish it in time. Dear friends, the topic that we're in today, I call it most important contemporary topic. Whether we need a vascular glucocentric approach or we need a glucocentric approach for the management of diabetes. Dear friends, I will just say that I have a very, very big agenda, but I will be very brief to say, I'll just say that diabetes is a metabolic cum vascular disease. Somebody said in Hindi, it is metabolic cum and vascular jada. I mean, we'll examine it. So evidences for the glucocentric, evidences for the vascular glucocentric we'll examine. That is the knowledge that we have to discuss in this meeting, and I'll give my opinion at the end. But I must allude to the new concept that has come in today, the atheroma-based chronic disease, dysglycemia-based chronic disease, and cardiometabolic-based chronic disease. When Jeffrey
Your slides are not visible. Your slides not visible, sir.
Not visible.
No.
One minute. Orosri? Slides not visible. Orosri, slides not visible. 1 minute. I'm sorry about that. I'll just rectify it.
I think you will have to reshare your screen.
I think reshare the screen.
Yes, sir.
Is it visible now?
No, yes, sir.
Yeah. So these three terms, ABCD, and the dysglycemia-based chronic disease and the chronic metabolic disease-based chronic disease are the new concepts. And this concept has wonderfully revolutionized our concept of the entire control from the pre-diabetes, diabetes complications, and also the complications that are set in as the cardiometabolic complications of diabetes mellitus. To make a long story short, dear friends, MI has a 8-fold excess occurrence in diabetes, stroke 7-fold, amputation 9-fold, and ESR the 20-fold. This is, to make a long story short, the impact of the disease. And if you look to the necessity intervention and the ADIC observation, you will find the most important thing is the early good control. And it has been shown by the famous lecture that the bad karma and the good karma, the metabolic karma, and you see that if you have a bad karma, you still suffer from the outcome 20 years later. If you have good karma, early aggressive, be it glucocentric, be it vascular glucocentric, early aggressive control is the one we can still reduce 32% even 20 plus years later. And this is again shown here with the STENO2 trial, the necessity ADIC. It said it's up to 21 years, standard versus intensive. You can have a great benefit because of the good karma, because of the early aggressive. Of course, I'll qualify multifactorial control. Now, the diseases in the cardio-renal metabolic system share the same risk factor, such as the microalbuminuria. They have macroalbuminuria. They have atherosclerosis, and they pass on to the various types of the disease that we're discussing today: atherosclerosis, CAD, MI and stroke, LV remodeling, heart failure, cardiovascular death, and what we have risk factors for them. We have the risk factors: diabetes, obesity, hypertension, and dyslipidemia. So only glucose control will examine how it is insufficient, but here is the answer to the fact that why it should be vascular glucocentric. Dear friends, CV disease can occur even before the diabetes occurs. And today we know that we have the CV disease occurring even -15, -10 years, and the atherosclerotic disease at least 10 years, and this factor present for up to 15 years. And the microvascular disease occurs, say, about same time or little earlier, maybe in the diabetes mellitus. Dear friends, the risk factors for the vascular disease in type 2 diabetes are physical inactivity. Thank you, Rucha. Thank you, Usha and Kavita. High blood pressure, poor diet, we addressed today, smoking, obesity, dyslipidemia, and metabolic syndrome. The effect of the hyperglycemia on the vascular disease and diabetes is through arterial stiffness, endothelial dysfunction, oxidative stress, platelet activation, of course, inflammation, and the metabolic dysfunction. Therefore, dear friends, that you have cardiovascular disease as a continuum in type 2 diabetes mellitus. We have the risk factors, which I alluded to. We have the subclinical effects of the various things I alluded to. You have got clinical damage in the MI, and then ultimately we have the myocardial infarction. And the coronary disease is caused by atherosclerotic changes in the vessel wall, and it leads to the, combined with hypertension, it leads to MI and leads to the various types of the echo defects. Now, I must tell you that diabetes from the Steve Harpner study and many other studies before and after have shown that time to fast MI is much less in diabetes, accelerates to the first time to the event of CV disease diabetes is faster, and to fast hospitalized because of heart failure is also faster. Therefore, our objective today in 2020 must be glucose-centric plus centric on some drugs which can take care of the fast MI, take care of the fast heart failure. Dear friends, I am not referring to the SGLT2 alone. I am referring to the entire gamut of the diseases that occur, the interventions that can give rise to the vascular control. Dear friends, life expectancy reduced at least by 12 years, those who have vascular disease, and therefore it is very important to have vascular control. Now, despite the improved prognosis with advancing standards of glucose control, type 2 diabetes mellitus, the CV mortality is very high over the years, and you see the life expectancy is mostly low with the patients diabetes with the heart disease. Now, also life expectancy is at least 12 years with the MI, and you see this is the hazard ratio of 6.9, 3.5, see 31% to up to a very huge percentage of the mortality is increased. Now we have two types of risk factors in diabetes. Diabetes specific risk factors, the NOx inhibitors, epsilon, S-RAGE antagonist, AGEs, MGOs, S100 inhibitors, IL-1 beta inhibitors. The last one is by the inflammation. The three here is because of the glycation, and the first one is the ROS. But dear friends, we have the risk factors because of the lipids, BP and glucose. And we know that we have wonderful drugs today to take care of the lipids, statins and the PCSK9 inhibitors. We have for the blood pressure, the ACIs and ARBs and the mineralocorticoid receptor antagonist. And for the glucose, I'll come back in a minute. Next few slides, I'll be repeating the same thing. So I'll just go very fast. So reducing severe risk in type 2 diabetes, we have to have a multifactorial approach. Dear friends, for the entire audience, I will reiterate, you already know it. Today, diabetes control is the control of the LDL, is the control of the antihypertensive therapy, antiplatelet therapy, glycemic control, weight loss, and lifestyle intervention. And all the studies that the intensive glycemic control has a very modest benefit. And glucose lowering studies confirm that the benefits are on the microvascular, but on the macrovascular, the benefits are very minimal. But you see the severe risk reduction with the other factors, 4 millimeter lowering of the systolic blood pressure, see the benefit in the reduction of the CV events. 1 millimole of LDL lowering, see the benefits. And today, the statin therapy is held as one of the most important modifier of the CV risk. And you see HbA1c for 1% reduction, see the amount of CV risk factor reduction. Steno 2 showed this, that intensive multifactorial therapy reduces CV risk in patients with type 2 diabetes and the albuminuria. See the number of months extra life it gave. It gave 8 years of extra life, and also showed the CV risk reduction in long term. I met Peter Gede recently, and he said that he's planning for a new study, but it's very difficult to get it again. Now, if you have a multifactorial approach, you have to take care of vascular approach, raised blood pressure, abnormal blood lipids, of course, smoking cessation, hyperglycemia cessation, control, and the severe risk by the aspirin, by the antiplatelet drug, others, etc., etc. Therefore, if you look to the transition in the focus of care over time, this is a beautiful slide which shows from the UK PDS. This is the classic trial, the Ramayana and Mahabharata of the diabetes control. You cannot deny it. But come to the new trials, the Chetan Bhagat's half-girlfriend trials, 212 to 218. It is dominated by the trials of the newer drugs. Not only, I'm not referring to SGLT2 alone. I'm referring to the gliptins. I'm referring to the GLP-1 arrays. I'm referring to the drugs which will come a little later. So all this trial today, to make a long story short, that today beyond 2012 or from 2012, the emphasis has been on the vasculocentric approach up to the 2008 publication of the Accord, Advance, and the Steno. Dear friends, there's a concept called reverse translation given by the Matthew, who published in 2020 this year. He says that the cardiac benefit, vascular benefits, renal benefits, and now he's looking at the respiratory, metabolic, musculoskeletal, neurological benefits. Not yet found, but it will be built in the various trials. I'll show you now that is the reverse translation of these effects, which gives rise to SGLT2 inhibitors in the renal, heart failure, CV death, MACE, and also GLP-1 array for the MACE, CV death, and heart failure, renal, questionable, but some semaglutide showed some benefit. So it is those trials which is said here. I will not go to the large CVOT trials. Suffice it to mention that you name any gliptins, mention any SGLT2, they have potential clinical benefits to the vasculoglycemic approach. It is glucose lowering, lowering of the microvascular morbidity, decreases glucotoxicity, low risk of hypo, insulin independent mechanism, osmotic diuresis, and of course, a nutritional offloader by excess loss of the calories in the urine. Therefore, the dawn of the CV risk reduction in type 2 diabetes It's for the last 5 years. To make a long story short, it's from the 2016 onwards, and we have got a lot of data today. I've given the names, I will not describe it, but it says that there's a great deal of benefit of vascular benefit by these new drugs, and also old drugs like statins, like metformin, like a good glycemic legacy, like the aspirin, like clopidogrel. I mean, no, one has to be cautious about the new drugs. Glucocentric approach may be more important for the retinopathy, neuropathy, and the peripheral arterial disease, on which the SGLT2 may not have much effect or may have a deleterious effect in the CANVAS trial. But the vascular centric approach is most in function of the AMI and heart failure, and some benefit in the stroke, and definite benefit in the diabetic kidney disease. Before 2008, we did not consider other drugs except BETF, SU, glitazones, and insulin. Today, we have to take into the other drug that are available in our armamentarium today. Dear friends, mortality is substantially higher in the type 2 diabetics with a chronic kidney disease, and it is said that a chronic kidney disease provides the fertile soil on which the heart disease occurs. Therefore, a drug which reduces chronic kidney disease is very important, because that will ultimately, the chronic kidney disease CKD increases the risk of MI at all stages, micro, macro, and if you see the reduced kidney function, it will increase the risk of severe events, and it is shown in the various trials that how it increases the kidney disease, the cardiac risk, and it is association with the albuminuria and the various cardiovascular effect you see with the microalbuminuria, macroalbuminuria is definitely higher. So therefore, there are two blockbusters of the new drug. One is anti-atherogenic effect, increase in the NO release, decrease inflammation, stabilize plaque, reduce fat spillover. We know these drugs. And we have the hemodynamic effect of the GLP-1RA, where we have reduced preload, reduced afterload, reduced epicardial fat, and decreasing inflammation. Therefore, if you have the drugs used today, like the GLP-1RA, I've given the benefits here, the drugs here, like the Elixir, Lira, Sema, and Exenatide, you see the major CV events, how it controls its effect on the heart failure hospitalization. And you have the DPP-4s, you see how it benefits. And we have the SGLT2, EMPA, and CANA. We see the various types of effects that they have. The key outcomes in the CANVAS trial, in the EMPA-REC trial, has been the effect on the CV death, on the non-fatal stroke, non-fatal MI. It brought it down, see the benefit, like the points are on the left. Hospitals for the heart failure, effect on the CV death, all-cause mortality, and of course progression to renal composite, including everything, eGFR, progress to microalbumin, etc. So therefore, majority of the things today that we look for in diabetes control favors at least SGLT2 at a great extent. I'm not saying that we will change over to SGLT tomorrow morning, but it has shown by the various DAPA-HF, Emperor reduced, with the Credence trial, it has shown that there is a rigorous practice-changing paradigm shift of these drugs. Large trials, they're multicentric trials, multi-country trials, they are persuasive p-value. You know, the number of 17 patients to get the benefit, 21 patients to get the benefit, 45 patients to get OSA benefit. So persuasive p-value, internally consistent across the class, large effect size, mortal reduction, improvement the quality of life, and excellent background therapy has to be there. Dear friends, I'll make it very clear that when ESC said that start with the SGLT2, we pointed out that these benefits were there when it was added, SGLT2 added on the background of the basic background therapy of metformin or whatever it is, of DPP-4 or the diet, exercise, etc., etc. So on the background of that, this drug is very beneficial. Now I just end by saying that SGLT2 inhibitors and GLP-1 receptors are cardio safe. They have reduced MACE. They have produced great benefit. The only possibility, that only question asked, is it affordable? Now, people who advocate for these drugs, they have shown the hazard ratio and the various elements of the cardiac malady, like hospital heart failure. See the hazard ratio here. See the hazard ratio in GLP-1 receptor agonist. So they definitely benefit. How do we make it affordable? How do you make it available? How do you make it accessible? How do you make it appropriate is partly our job and partly of the job that I take care from the DCGI or we take care from the government of India. So that is one of the aspects. But some people have said, why we spend 3 lakhs per stent? Why not invest some money in the beginning? And the drugs are becoming inexpensive. You know the whole story. I won't go to the extent of it, but I must make it clear here that you combine metformin 1000 milligram with the 5 DAPA or 10 CANA or whatever 10 EMPA, and the benefits are even huger than what one find. And again, I must mention here, the kidney outcome data is also very, very hard. Today, we know that the CVOT and cardiorenal trials in patients with type 2 diabetes mellitus across the board, like the DAPA kidney, Credence, EMPA kidney, and all the trials have shown that it's a very kidney-friendly drug and very important. Therefore, the guidelines from the 2015 onwards have started including this class of drugs in the armamentarium of diabetes care. So we had the various trials, and we had 2 more trials to come next year, next year. The delivery will come this year. We have scored SOTA trial, EMPA kidney trial in 2020, and in 24 we'll have the FLOW trial. Now, when all these trials are available, we'll have 2 types of treatment. Treat to benefit trial, which will reduce the severe risk, GLP-1 array and SGLT2I for the people of high severe risk, and the HbA1c reducing trial of all the drugs, sulfonylurea, metformin, insulin, glitazones. So therefore, dear friends, I say it's a complete treatment, but vasculo-glucocentric approach will probably take the lead in coming years. Dear friends, we cannot forget the retinopathy, neuropathy, and the peripheral artery disease. I must tell you that trials to say that sustained have some on the retinopathy. It was not so friendly. Neuropathy, ELIX had some effect on the neuropathy. PAD was not benefited by any of these trials. Credence trials showed amputation. So, dear friends, we cannot forget the majority of the adverse effects and must be alive to it, dear friends. Therefore, on a new onset diabetes, the drug, to my mind, to the majority of mind, I saw Rajiv is here and he's going to speak now or a little later. Now we said the GLP-1 and SGLT2I, but we also said about metformin as the treat to benefit trial. You must have metformin, GLP-1 and or SGLT2 inhibitors, which can take care of the stroke, AMI, heart failure, and of course diabetic kidney disease. So vasculocentric approach is very important. But if H1C is not yet on target, and if H1C from the beginning, if not on the target, we have to also add metformin, DPP4, ACUs, insulin, because we have drugs treat to target, we have drugs treat to benefit. So today's approach is vascular, treat to benefit, and treat to target, the metabolic control approach, the glucose control approach, which can take care of retinopathy, neuropathy, PAD, and of course on the DKD. Dear friends, the multifactorial approach has been well brought out in this 1002 trial. There is no study better than this today. I know details of it. And also the summary of various CV, heart failure, kidney outcomes, which have been used in various drugs like SGLT2, GLP-1. But don't forget, when we say vascular drugs, ACEI, it was just discussed before I came in, and ARBs and statins, huge benefits. We cannot afford to forget them in a diabetic patient. Last 3 slides, diabetes associated with 2 to 3-fold increase in the CV disease. A figure which increases markedly in young onset, long duration diabetic, and presence of the comorbidities like PVD, CKD, I told that, and risk factor clustering. Whatever treatment modality is employed, drug therapy, or you give advanced CIBG, PCI, diabetes patients have generally worse outcome than the non-diabetic patient. A difference referred to as the residual risk. And to dig at the residual risk, what we need is early, aggressive vascular glucose control. In vascular glucocentric approach, in individuals who present with CV events, and the fasting blood glucose H1C should be more than what we expect. And there we have to give drugs which are appropriate. In diabetes, intensive management of severe risk factors like glycemic control, BP control, lipid control, antiplatelet agents should be perused as an appropriate for the individual patient. A new severe risk stratification is coming. We must respect that. And new guidelines also include a very aggressive management of the statins. Dear friends, I cannot but overemphasize that we do not do the aggressive lipid control, which is the thought of the day, action of the day, and that must be taken. And high and very high risk patients may be considered by taking simple aspirin therapy. People forget about it. On low dose rivaroxaban, we are using plenty today in the COVID situation. And the new glucose lowering agents, SGLT2I and GLP-1RA, come at the end as recommended the first line therapy type diabetes mellitus, but with the background therapy of all that I've already said. So the vascular conundrum in diabetes, it is similar in both type 1 and type 2. Lowering blood pressure improves vascular complication driven by glycemia. Statins increase the risk of diabetes, but nevertheless, it may not be beneficial in the PBD and ESRD, but is hailed has brought down 1/3 of the heart attacks. Triglyceride predict vascular disease. The treatment, we do not know how much beneficial. Now, dear friends, I must end by saying we need today holistic approach to type 2 diabetes care, cardiorenal and metabolic aspect of the disease. And I have given some evidences, you know the evidences. I've tried to give some evidences to justify why I'm saying that. We need appropriate glycemic control. We need exercise and diet. We know we cannot forget the metabolic flexibility and how much exercise helps for that. BP control, often with multiple agents. Statins, which are grossly underutilized. We do not achieve the target. Fenofibrate, which are probably again underutilized. PCSK9 inhibitor, we have problem here because of the cost. Two new concepts today, that the cardiometabolic based chronic disease and dysglycemia based chronic disease, that has to be respected. For what? We have to see patient as a whole. In order, diabetes in the patient is it's a chain of events, cardiometabolic events. It's a chain of events from the very origin. We can say from the fetal origin, whatever origin, and it passes through the pre-diabetes, diabetes, vascular complications. So therefore, recent CVOTs, patients were treated, both treat to benefit and treat to target. And SGLT2 inhibitor, GLP-1 confer both renal and CV protection. A glucovasculocentric approach, vasculo-glucocentric approach to put it more rightly, is important, and we cannot forget it today. Probably a combination of both glucocentric, that is treat to benefit, treat to target, and a vasculo-glucocentric, that is treat to benefit, are important and must be instituted at the early phase of the disease. Sir William Osler said, to end my talk, more important to know what sort of patient has a disease, what the patient before us, obese, what family history, what risk factor for atherosclerosis, than knowing that what sort of disease a patient has. Thank you very much for a present hearing. Again, thankful to RSSDI Delhi chapter for giving me this great opportunity, which I treasure with love and regards. And thank you, Professor N.K. Singh, for the wonderful introduction and for being in my talk.
Thank you, sir. Actually, a great lecture. So I will request Dr. S.K. Bakshi, our co-chair, to comment on the talk and any questions.
Dr. Bakshi, my regards.
Yeah.
Yes.
Thank you, Dr. Das, giving an excellent overview of the vasculocentric approach to the control of diabetes and having both treat to benefit and treat to target approach. I think this was such an excellent lecture. There may not be any questions, but still we'll see.
We have got 5.4 minutes, sir. I have the stopwatch here, so I finished in 24.6.
Yes, sir. You are actually on the time.
Yeah. So, sir, we can have 2 or 3 questions. I like
sir. Sir, yes, I don't think any questions.
Yes, sir.
In the chat box. So, sir, just give us a message. Well, you have already given a very good approach that how to combine the vasculo-glucocentric approach. But what is happening in the practice of a diabetologist or a physician, if we start with the sulfonylurea, metformin, basically from the very beginning in a newly onset of diabetes.
Yes,
But knowing that these things in long run, basically they will turn towards the cardiovascular complications. So do you think that this is the time when we should combine SGLT2 inhibitors, metformin, and if not controlled, then we should proceed for the adding sulfonylurea and other group of drugs? So do you think that the time has come now that from the very beginning, this vasculocentric approach should be the priority in our practice?
I think Dr. Singh, as the head of the CME of the country, I call you the teacher of the teachers for the whole country.
No,
I
sir,
will
no,
tell
sir.
you have hit the bullseye. Let me photograph you. Now, I'll tell you what exactly in my mind. I can see Meena, I can see Rajiv Chawla, and all of you. My regards to all of you. I must tell you one thing, that metformin is a basically vascular drug. I always, NK Singh sir, as per your teaching, the metformin is a vascular drug. It has so much of vascular benefits that that we cannot do it. Therefore, sir, in my kitty today, metformin still remains the #1 drug. And I do add the other vascular drugs which are beneficial. So first I will add a statin, a ARB, a ACI as the required, or multiple combination of the treatment. I will give in the appropriate, not for the primary prevention. When I see the case for other issues, I will be adding a aspirin and also the clopidogrel. So I have got multiple things to add for the vasculocentric, and of course I will today add the SGLT2 inhibitors, maybe along with the metformin when the cost has become a bit affordable, to provide that benefit. That's my take, very short take on the great question you asked, Dr. NK. Yes, Ajib.
Thank you, Professor Das, for a wonderful elaboration of a vasculocentric versus a glucocentric approach. As always, you have done a wonderful job. But I wished towards the end, when you were talking about guidelines, you should have not missed RSSDI ASI, for which you are a mentor and where we have very appropriately. I think this time we have fixed a hierarchy for drugs. It moves in a clockwise pattern, and
Rajiv, I'm sorry.
it's a true patient-centric approach.
My letter to the editor, dear friends, day for yesterday, the KDIGO published.
KDIGO, yeah. I was just coming to that only. Yeah.
Dr. NK and my chairperson, Dr. Joshi, I must add that in that they have taken recourse to our Dharma Chakra without taking our name. So Nikhil was Indian member. I asked Nikhil, well, he said, sir, it was automatic, spontaneous. They have read our guideline. They said Dharma Chakra must be there. So, sir, it is, I did not show it, my apologies, but I must tell you, globally today, the Dharma Chakra is accepted.
I think we are,
KDIGO trial.
Maybe we may invite one of you to write a commentary on KDIGO versus our therapeutic wheel.
Exactly.
I think it's a wonderful
very incomplete wheel. We know that, but I was telling that in what high esteem I hold this chakra, from my my desk.
So you are a patron and you are a mentor for everyone across RSSDI or ESI. So it is your own wheel and your own guidelines, sir.
So nice of
you.
Thank you. My regards to Pratap and to Girish, of course, my dear friend Dr. Shalini, and to Jingan. Ashok Jingan is here, whom I know from long time, from the Madam's Health Minister's treatment, Sushma's treatment time. Dr. Ashok was the primary physician. We are all secondary. Thank you very, very much, sir.
Thank you very much, sir. Dr.
JK, thank you, JK. You only called me. Thank you very much. You gave me the first. Meena before that sounded me, but you called me. Thank you, JK.
Thank you very much, sir. Thank you, sir. And I thank both my chairpersons, Dr. NK Singh and Dr. S. for taking time out.
Thank you.
Yeah. Now we have another 2 very important sessions left, and I request Dr. AK Das sir to please stay.
I will be staying, sir. I'll be staying.
Please stay. And to conduct these 2 sessions, I invite my friend Dr. S.N. Gupta. Dr. S.N. Gupta, please.
Thank you, Dr. Sharma. So we come down to the penultimate 2 lectures of the afternoon. Both are by outstation speakers. The first talk would be by Dr. Renu Joshi, talking about technologies in diabetes. And for that, may I invite the two chairpersons, Dr. A.K. Jhingan sir and Dr. Pratap Jetwani from Gujarat, to introduce and carry forward the CME. So may I introduce Dr. A.K. Jhingan. He has a total, dedicated 45 years of service to the profession, and his core areas of specialization are diabetes care and education. He is also the chairman of the Delhi Diabetes Research Center and founder president of the Diabetes Education and Research Foundations, founder president of the Juvenile Diabetes Association of India, and is a founder member of the Delhi Diabetic Forum, member of the RSSDI and Diabetes Association of India, ADA, and the API, and has presented papers in various national and international conferences and created 3 Guinness World Records on the World Diabetes Day on 6 November in 2016. Dr. Jhingan sir. And the second chairperson is Dr. Pratap Jetwani, an executive member, All India RSSDI from 2020, an honorary secretary, Gujarat State Chapter of the RSSDI, organizing secretary of the RSSDI 2018 at Ahmedabad, past tutor, Leicester University, UK, the section editor of Sadiko's International Textbook of Diabetes, past president of the Association of Physicians of Rajkot, and he's a consultant diabetes specialist at the Jetwani Hospital and a visiting diabetes specialist at the Rotary Midtown Diabetes Clinic, Rajkot. Dr. Jetwani. Please carry the session forward.
Dr. Sen Gupta for kind introduction. I welcome my co-chair, Dr. Jhingan sir. Thank you, Dr. J.K. Sharma, Dr. Meena Chhabra, and the entire Delhi team for inviting me to chair this session, which is related to, I think, the technology because of which we all are here, the virtual technology because of which we are able to run this conference in this new normals established because of the pandemic, COVID-19 pandemic. So I will request my co-chair, Dr. Ashok Jhingan, to introduce the speaker, and then we will carry on with the proceedings. Over to you, sir.
You're muted.
Dr. Jhingan sir.
You're muted.
Dr. Jhingan, please unmute yourself.
So thank you very much, Dr. J.K. Sharma, Dr. Chhabra. And till now, I think this is a wonderful session, wonderful arrangement, and a wonderful conference which I have seen. So 3 cheers to both of you and the whole team which has made it wonderful conference. Coming to this, that after the Dr. Das, very important topic, that vascular-glucocentric approach, but the things come that how to achieve that. And for that, we should have a modern technology which can enable us to make these patients so that they can have a better glycemic control. And today, new technologies have really revolutionized the outcome of the treatment of a diabetes. And for this, to know more about this, today we have a person who has been doing a lot of work from the last couple of years, and she's Dr. Renu Joshi. She's a chief of endocrinology and a chronic disease management, population health, UPMSC Pinnacle. She's a co-chair diabetes clinical initiative since 2001, which has led to the improved inpatient and outpatient glycemic control across 7 hospitals in a large complex hospital system of UPMSC Pinnacle. And I think she has all because of her efforts that the centers has been Center of Excellence for Diabetes certification from the Joint Commission. And the another good thing is she completed MBBS from the KGMU in 1984. So over to you, Dr. Renu Joshi.
Thank you. I'm just going to share my screen first, so we can see my slides. Great. Okay.
Make it screen. Yes.
Okay. Great. Thank you, Dr. Meena, Dr. Sharma, and the whole RSDI chapter for inviting me for this wonderful program. I'm very, very excited. I've heard the program, at least the last several presentations, and they have been excellent. So my job is pretty difficult and practical, but I'm going to spend the next 20 minutes talking about technologies in diabetes, and then a little bit of research, and then practical questions which come every single day. So the 3 technology updates we are going to do is about continuous glucose monitoring, also known as CGM, insulin pumps, and smart pens. So the continuous glucose monitoring is a sensor-based technology which is applied on abdomen for continuous glucose monitoring or glucose in the interstitial fluid. So the important thing is that it is different than your capillary glucose. The blood glucose with continuous glucose monitoring is recorded 24/7, and the data is then downloaded in a graph form for all of us to see. There are 3 devices available for use, Guardian RT from Medtronic, a Dexcom, and a Freestyle Libre. The Freestyle Libre, all 3 can be inserted by the patient. Eversense is another very nice device available now, which can be inserted below the skin by provider and is actually changed every 3 months. So we have a great tool of technology of CGM available today. The data on the continuous glucose monitoring technologies have been available for more than 10 years, and I'm going to be sharing some of that data with you. They're mostly utilized with pump, but standalone CGM has become very, very popular now. Okay, the CGM in patients with type 1 diabetes. So the data again goes back from research from 2010, when initial papers were presented with 153 children and adults with pump patients and an A1C of 7.5 to 9.5, when they were randomized to the sensor on and sensor off arm for 6 months with a 4-month washout period. In just a mere 6 months, there was a difference of A1C of 0.43%, but more important, less time spent in hypoglycemia due to frequent pump adjustments. Another study published around the same time showed similar results in 120 adults with less time spent in hypoglycemia, and the time in range, which you already have heard the full talk about how important the time in range is now to improve metabolic complications. It increased from 16 hours to 17.6 hours in 1 day, and the A1C drop of 0.27% again in a mere 6 months. And a JAMA paper recently showed in an open label crossover trial in a 161 type 1 diabetic patient indicated a 0.42% improvement in A1C and improvement in severe hypoglycemia. So what is the evidence we have for continuous glucose monitoring utilization in type 2 diabetes? Again, many papers starting back in 2010 showed there were 100 type 2 diabetic patients only on basal insulin and medications. They showed almost 1% improvement in hemoglobin A1C with off and on CGM just for 3 months. The sustained benefit for these techniques were seen at 1 year with decrease of A1C in 0.8%. Another paper published more recently showed 224 type 2 patients on Freestyle Libre machine showed absolutely no major difference in A1C except in patients who were less than 65 years of age, but a significant improvement in time spent in hypoglycemia. So as you all know that hypoglycemia has now become one of the major predictor for at least development of macrovascular disease. The lesser the hypoglycemia, the better we are. Okay, so if I just want to point out, there's no dearth of CGM studies available. So these are different types of studies which have been done since 2010 to 2020. And there are 3 types of study I have mentioned here. One is continuous glucose monitoring with MD and continuous glucose insulin pump therapy, which is the empty circles. So MDI is multi-dose injections, which is your basal bolus insulin and the pump. Then there's SAP therapy, which is shaded one with vertical bars. And that shows sensor augmented pump therapy, which means the continuous glucose monitoring was utilized along with the pump to improve glycemic control. And the third one is the most exciting, and which are the more latest studies, which is SAP with LGS, which means the sensor augmented pump therapy was also utilized with low glucose suspend. What that means is that the pump will artificially, or importantly by itself with the AI, stop giving insulin when you have a glucose which is in the range of 80 to 110. So if you look at all of these studies, and these are all very powerful studies, the A1C is depicted on the left side, which shows a reduction, and the X bar is hypoglycemia, which shows reduction. So you can see in almost every single study, there was not only reduction of hypoglycemia, but there was also reduction of A1C. And if they did not show an A1C reduction, they showed significant reduction in hypoglycemia, which is one of the most important things we have learned with the CGM moving forward. So what is the data on CGM and pregnancy? Again, two very elegant papers published recently. The first paper showed 210 pregnant type 1 diabetic women on CGM versus normal blood glucose measurement spent more time in target. Again, less time hyperglycemic. Even though the statistically significant change was not seen in hypoglycemia, with just a change in target and hyperglycemia, there was a significant improvement in neonatal outcomes. There were lower incidence of large for gestational babies, neonatal hypoglycemia, and neonatal admissions. And then finally, a meta-analysis was recently published in 2019 of 29 studies which had only 3 randomized controlled trials, but the rest were open label or observational studies, showed conflicting results on macrosomia and C-section, but there was definitely increased detection of dysglycemia and glycemic variability with CGM. Again, we need more large randomized controlled trial to really confirm whether pregnancy CGM is going to be helpful, but in the smaller studies, it has clearly shown benefit. So when we talk about continuous glucose monitoring, one of the big things we talk, and not new to this group, is MARD, or also known as mean absolute relative difference. So any continuous glucose monitoring to be powerful or accurate, you have to have a MARD of less than 10%. And as you can see in 2020, whether you look at Dexcom G5, Freestyle Libre, Guardian 3, which is your Medtronic device, G6, which is the latest from Dexcom, and Eversense, which is the one inserted inside the skin for 3 months, show a MARD between 8.5 to 9.7%. So telling you all of them are very, very accurate. And one of the important thing I want to point out again for the non-endocrinologists, that this is an interstitial fluid, and capillary blood glucose is always going to be different than interstitial fluid. So you cannot expect a 0% MARD with any of these devices. Okay, so more practical aspects of it. So there are 2 of them available, which we use commonly most of the time. The first one is called Freestyle Libre, and now the Freestyle Libre Pro 2 has just been approved. So they're very easy to use. As you can see, this is a quarter shaped, just a quarter size coin type tongue, which comes on your arm and you actually insert it in your arm. The new one also gives you alarms for hypoglycemia and hyperglycemia. It is fairly cheap in US. The sensor lasts for at least 14 days and there's no calibration required, which means you really do not need to calibrate blood glucose unless you are suffering serious hypo or hyperglycemia. They're waterproof devices, so you can even take them in the shower or a quick swing. Dexcom, on the other hand, again, very easy to use. The size, again, is a little bit different than Freestyle, but not very big. It's a little more expensive. It has much more sophisticated alarms for hypoglycemia and hyperglycemia, but the sensor only lasts for 6 to 10 days. So you do have to change a week to maximum of 10 days. Again, no calibration required, and they're both waterproof. So excellent devices available to us for our use on a day-to-day purpose. So one of the most critical aspects which Dr. Meena wanted me to discuss is to discuss how to interpret a report of CGM. So when you put CGM on anybody and you bring them into your offices, they can actually download the device on their cell phone, and you can download the device in your EMR, and the data will appear like this. So there are 3 aspects of the main report, which I'm going to go over in length. So the first report is called the AGP report. This is the top column, which you will see on every patient. And the concept, which I want to bring again and again, is the target range or the time in range, which is most critical. The target range, or the green bar, is defined as what is the normal target, which is 70 to 180, which means avoiding hypoglycemia and avoiding hyperglycemia. And I'll discuss the target range for different population in a second. Then the high, or the yellow bar, is your glucose is between 180 to 250 milligram per deciliter, and the very high is glucose is more than 250 milligrams. Then you have a low threshold or low red bar, which is less than 70, which is also defined as mild hypoglycemia. And then you have a very low bar, which is less than 40, or defining as severe hypoglycemia. So on the right side, you will see that this person only has 47% of her glucose in the target range, 23% high, and 20% very high. So we have a lot of room to work on this patient. Another thing is this person has significant hypoglycemia, which I'll define what the current guidelines are. And then it gives you an average glucose management indicator, which is your A1C, based on these numbers. And how much is the glucose variability, which again, as you go into the time in range concept, is very, very important, especially for macrovascular disease and mortality. So these are the target of glycemic ranges defined by the in diabetes care in 2019. And on the left side, if you see for all type 1 and type 2 diabetic patients who are young, your target range of 70 to 180 should be at least more than 70%. The hyperglycemia, 180 to 250, less than 25%, and more than 250, less than 5%. Again, at any given level, the severe hypoglycemia has to be less than 1%, which is our main target. And less than 4%, 70, mild hypoglycemia is acceptable. But if you go beyond that, then you're really not doing a good job with CGM. Then if you look at our very high risk, which are older population and have a lot more comorbid condition, you can see that the target ranges are different. And we are actually taking a lot more hyperglycemia for that population, as Dr. Das very nicely alluded to, that there are other factors we work on to improve the comorbid conditions, and glycemic control may not be your most important factor. Once again, in very older population, as we defined above 75 years of age, your hypoglycemia target should be less than 1%, which is very, very, very critical. If you look at pregnancy with type 1 diabetes, the target range is different. The target range is not 70 to 180, but it's rather 53 to 143. And again, that target has to be more than 70% with a similar hypoglycemia risk. But when you talk about gestational diabetes in pregnancy and type 2 diabetes, my gosh, you look at the target range of 63 to 140, it has to be close to 90% in the range, and hypoglycemia, again, less than 4%. So hopefully you'll find these graphs very, very helpful when you're interpreting your patient CGM on a day-to-day basis. And this is the third piece of the second or third piece of the graph, which you will see. So the blue line provides you a median, which is where your numbers are all the time, starting from midnight until next midnight. So you can actually see it provides you a record of glucose literally every minute. Then your dark blue shadows are your glucose ranges between 25 to 75%, and the 10 to 90% are defined by the light blue. So just by looking at it at one glance, I can clearly say this patient has very good control in the range overnight till 12 o'clock. And as soon as he starts feeding his food, all hell breaks loose. So you can see that the problem here with this person is food and dietary habits, and we need to work on diet and his bolus insulin. But he might actually be benefited by a decrease in basal insulin because he's touching 70 many times in the middle of the night, which may cause hypoglycemia. So that's how this graph is very, very helpful to me, and actually more helpful to the patients than me, because when they look at this and I tell them, I don't know what you eat at lunch, but your glucose is going up to 350, it makes a huge difference. And then the last piece of the graph you will see, it gives you a daily variation. So you can see the yellow is defined by hyperglycemia because the averages don't tell you much. So you look at daily graphs and the red part are defined by hypoglycemia. So you can clearly see that the hypoglycemia is more overnight, and hypoglycemia also happens when the person covers for hyperglycemia, then he's over covering himself and is causing hypoglycemia. But clearly, he has meal-related hyperglycemia, more prominent with lunch and dinner. So I show these graphs to the patients on whenever we see them. And again, that makes changes in their dietary habits and bolus techniques. Okay, the patient can get all these reports on their sensor or on their cell phone. It gives you a visual alert and the trend arrows. And these arrows are very beneficial. If the arrow is going straight up, that means the glucose is rising very, very quickly and they need to take control now. If the arrow is going down at a 90-degree, that means they're going to be hypoglycemic in the next 20 minutes and they need to take something now. A sideways arrow of a 45-degree is not, it's just showing that your glucose is increasing. Then it gives you daily pattern graph, which we talked about, time in target, average glucose graph, and low glucose graph. So these are very helpful technique to your patients on a daily basis, even if you are not seeing them in your offices. And the similar report comes with Dexcom. So Dexcom gives you a report on the iCloud called as Clarity. And the Clarity report looks exactly like a Freestyle Libre. And same thing, you get a median of the graph, then you get everyday values. So you can show the variability of the glucose, and then you get an average. And this also gives you the glucose median and average based on like an Excel form. So you can actually give the patient numbers. So again, all of this data is available to your patient on a daily basis on their phones. So our data on CGM, we have more than 500 patients on CGM and pumps currently among 8 endocrinologists we have. We have seen exactly similar results as the published data. Our time in range have significantly increased. And during COVID-19, we are now utilizing CGM in our inpatient services in ICU. We have 25 patients on inpatient CGM, and it has already shown, now this has already been utilized for compassionate use, so there's no research behind it. It has shown great results in maintaining glucose in range, improving hypoglycemia in your COVID-19 patients, and saving PPE. And I don't want to spend more time on COVID-19 because that could be another hour, but it does save PPE and it has improved hypoglycemia. We are currently involved in a randomized control trial research study on coronary artery bypass patient and utilizing CGM in that population to see, and hopefully we'll have some data in 6 to 8 months. So very, very exciting news on CGM. So let's shift gears and talk a little bit about pumps. Now, the pumps are more sophisticated way of providing basal, bolus, and sliding scale insulin than your regular basal and bolus injections. And I'm not going to spend the time in research because the data I showed you with continuous glucose monitoring, a lot of those studies were done in pump patients. And pump has now been regularly approved for many diabetics, which I'm going to talk about. So the 3 critical things you need to know about pumps is your basal rate, bolus, and correction insulin. So who are the candidates for pump? Any type 1 diabetic patient who you can utilize pump, you should utilize pump because it'll improve their time in range and glucose variability. Patients with pregnancy, there's a lot of data on patients in pregnancy with pump. Type 2 diabetic patients uncontrolled with multiple injections of insulin where you cannot control their glucoses. Patients with gastroparesis, brittle diabetes, they're great candidates for pump, and I'll show you in a second why. So what is basal insulin? Basal insulin is your continuous delivery of insulin to mimic the normal working of the pancreas. That can be programmed to change basal delivery many times of the day. So when we use pumps, we're using less than normal basal between 12 to 3 a.m. because as all of these groups know that cortisol and glucagon are at their lowest up at that time. And we use higher than normal basal rates between 3 to 6 a.m. because cortisol and growth hormone peak at that time. And if you just utilize the basal insulin, it will prevent decay in a type 1 diabetic patient. The bolus is some insulin which is used to cover meals. It is given typically before meals, and we call it insulin carb ratio or IC ratio in the pump. This number tells you that 1 unit of insulin is going to cover that many grams of carb. So 1 to 5 ratio means 1 unit of insulin is going to cover 5 grams of carb. And the third thing we use in the pumps is insulin sensitivity factor or ISF. It's like a sliding scale, but it's a much more sophisticated version of sliding scale. And it's utilized to correct the high blood glucose. It's based on insulin resistance, based on patient's weight, and the total daily dose of insulin. So what is the correction factor represents? It represents the amount of blood glucose drop with 1 unit of insulin. For example, the ISF or insulin sensitivity factor of 30 means 1 unit of insulin will decrease your blood glucose by 30 points. And then finally, the concept of insulin on board, which we can never really solve in basal bolus insulin. So let's see if you have a patient who has given a bolus, has a basal rate of 0.75 units an hour, has given a bolus of 7 units. 2 hours later, the glucose is still elevated. The patient may give himself 6 units of insulin if he was on a basal bolus concept. But the patient still has the insulin left over from the last one, and you had given 7 units or 6 units more. This is called a stacking effect, and the net result is hypoglycemia. And as you have seen now, the hypoglycemia is actually equally dangerous for a type 1 and type 2 diabetes population, especially when it comes to macrovascular disease. So this stacking effect can easily be avoided by the pump because pump will actually let them know at 2 hours, this is how much insulin is on board, so you cannot really give this much insulin. So the stacking effect can be prevented by pump. So how do you do calculations? You take the total insulin dose in 24 hours, decrease to 80% for the pump use, divide total daily dose into 50% basal, 50% bolus. The basal dose is then divided by 24 hours, and that rate it utilized every hour on the pump. So, and as I said, we change the midnight rate. So let's say if you have a total dose of 100 units, 80% dose will be 80, 40 units will be basal, 40 divided by 24 is 1.6 units per hour for the whole day. You will give 1.2 units for the midnight to 3 and 2 units from 3 to 7. So that will be your starting rate of the pump, and then you will manage accordingly. For the calculations, you do the two formulas. These are well-researched formulas, which I cannot get into detail due to shortage of time, but insulin carb ratio is calculated as 500 divided by total daily dose, and ISF is 1800 divided by total daily dose. For this patient who is 100 units of insulin, IC ratio is 500 divided by 100, 1 to 5, and ISF is 18. So that's how we'll put those numbers in the pump, and then you follow these patients on a weekly, every 2 weekly basis to adjust. Okay, the pump can provide 3 different types of boluses, which is the most advanced thing happened, which we cannot do with other patients on a bolus insulin. One is a normal bolus, square and extended bolus, and a dual wave and combo bolus. So normal bolus is like any other bolus, which you use for meals and you also use for correction. But the square and extended bolus is really important. This amount delivers evenly over the period of time you set. So you can utilize the square wave bolus over 2 to 3 hours. And this is great for patients with gastroparesis, so they can use a square wave bolus and not have to worry about immediate hypoglycemia after eating meals. It can also use when you especially eat Chinese and pizza, when you have a lot more fat, you can actually use the square wave bolus so it can continue to correct your glucoses up to 3 hours. But then you can also do a dual and extended bolus. The dual bolus means you can use half the dose as a normal bolus and the other half can be utilized as extended bolus or after the meals. This is extremely important again in meals who have both high fat and high carbs and which delay the digestion, Mexican pizza, Chinese food. But you can also use it in pregnancy. So let's say if you gave 4 units and the patient could not eat the meal completely and threw up, you can stop this next bolus so the patient will prevent hypoglycemia. Again, important concept of basal and bolus insulin in a pump. And then finally, just to give you some idea, how do you see the numbers? So this is glucose. Basal insulin is being given and the patient is in target range. This is the first time he ate their meal, probably gave 5 units of bolus, but he forgot to give the pre-meal bolus. So they gave the insulin a little later, which was not appropriate. The glucose was really elevated and that glucose came down to 110. It is still within target. So if you have an acceptable range within 30 points of the target, you don't need to change anything. If this value would be dropping below 80 or 70, then you will have to change the insulin carb ratio or the bolus ratio. And then you can also change the sensitivity factor accordingly. Okay, the temp basal is the last thing I'm going to talk about the pump. So pump can also utilize something called as temp basal. This is needed for short duration, like for exercise, short time NPO, temporary stressful situation. In every pump, there's a temp basal setting. You can either increase or decrease that by 10 to 20%. It typically lasts for 24 hours, and then you can change that back. So how many pumps do we have available? I know Medtronic is available in India. So we have MiniMed, which is Medtronic 630G and 670G. Then we have the Tandem Control IQ, which works with Dexcom. Medtronic works with their own sensor. And then we have Omnipod, which is the first wireless pump available, which works with Dexcom as well. So the beauty of this, and this is where I'm going to lead into a second talk, which is going to happen with artificial intelligence and artificial pancreas. I have never thought in my career path when I did my fellowship back in 1990 that we're going to see this for our diabetes management. And I'm very proud to see that this has happened. The technology has come a long way to show the data on artificial pancreas, which is called the sensor augmented pump, which means a low glucose suspend pump, which means based on the sensor, continuous glucose monitoring, the pump is automatically changing your basal insulin all the time, on a every minute interval. So when you see these graphs, this is how it looks. So you can see that the median black line is the patient median, which is the target range. And you can see the time in range. That patient has been in range most of the time, very little ups and downs. Then this is the numbers, the orange bar shows you the numbers between 25 to 75% of the time. So you can see that overnight from 12 midnight till 12 noon or 2 p.m., the patient remains in target very nicely, except some hypoglycemia. And then of course the number changes slightly, but the pump is actually managing this patient themselves. And when you see these artificial pancreas graphs, this is how they look like. Lot to see, lot to digest, but I'll show you just next graph to show just the details. So when you're looking at these graphs, these are very, very important to see that the basal insulin is very well controlling the glucose. The patient has first meal, breakfast, or lunch time. They forgot to, the number 2, which is, these are your calibration circles. In Medtronic, you have to do calibrations. And then this number 2 is your calibrated back circle. When the patient glucose went high, they asked him to calibrate. But the patient forgot to take the bolus and then covered himself with a high dose of insulin. And then the net result is hypoglycemia. What I wanted to show you was to see below that the pump automatically suspended. So there was no basal insulin provided, which is called the low hypoglycemia suspend, that really helped them go a long way to prevent further hypoglycemia. The last slide is on InPen, which is the pen combined with smartphone app. So people who cannot go on pump, this will be a great thing for type 2 diabetics, especially in India. It gives you a pen which has a smartphone app for calculating dosages of insulin, provide the pump type calculations without the pump, gives you insulin on board. So this is how much insulin is still on board. This is how much insulin you gave before, and this is how much you want to give again. This is the glucose. So it tells you all, and a patient can remember what insulin they had given before. So a very smart technology, which is now available for our population. So in summary, it's an empowering device available to improve glycemic control, which improves A1C, improves hypoglycemia, improves time in range, and improves quality of life. And we have come a long way in the last 20 years. So I'm going to stop here and just really thank KGMU, which was my place to graduate. And I can never, think about this enough, and love being a part of KGMU society at this point. And I'm going to stop here and take some questions.
Thank you, madam, for an excellent overview of technologies in diabetes. One question I would like to ask you. In India, the patients are paying from their pockets. So for a type 1 diabetic, what will you invest your money first, in CGMS or in insulin pump? What should come first? Because they have to pay from their pockets.
Absolutely. The first thing I would invest is in CGM. If you do a continuous glucose monitoring, and I don't know if India you can do that. I know there's a lot of diabetes educators available now. So there's something called as professional CGM, which your diabetes educator can actually place the machine just for 7 days. So you don't have to buy a home CGM. The educator department or the diabetes departments can buy those machines, and you just place it on the patient for 7 days and give them the data. If the data does not show that there's a variability in glucose, their time in range is 70%, this person will probably not be benefited by the pump. But if you have a time in range only at 30 to 40%, they have severe hypoglycemia, they have brittle diabetes, they have gastroparesis, yes, this person will be more appropriate candidate for the pump.
Can I have a small comment, Dr. Jatwani? I have time? 1 minute. Can I?
Yes.
Yeah. I think, Dr. Renu, thank you very much for a very, very important talk, which we wanted to listen from you. We had less experience, definitely, but we published our data with Jyotidev was our leader. You must have heard of him, met him in the ATTD and ADA. We wrote about our use in type 2 diabetes is much higher because the numbers are 95%. So we analyzed the various indications. I'd like to have your comments. Are you in the correct? We said that we give for the high H1C by multiple, good MDI, glucose doesn't come down. Insulin resistance, does not respond. Brittle diabetes, so-called quote-unquote brittle diabetes. Patients with asymptomatic or symptomatic serious hypoglycemia who get recurrently, and the patients seeking improved quality of life with insulin pumps. And last one, we gave chronic kidney disease and for the pregnant mothers. And so far, Dr. Renu, we have been quite happy. Of course, type 1 diabetes also we give. That is Bansi, our president's area. So I would like to know your comments that are we on the correct track?
Oh, absolutely.
Setu also here, my dear friends, who have joined. So,
No. Thank you.
Yes,
Thank you, Dr. Bass, for that excellent question. Yes, we actually do both for type 1 and type 2 diabetes. And the data is equally beneficial in type 2 diabetes as well. There's absolutely no doubt about it because 95% of the population is type 2 diabetes.
Therefore,
and as you said, the glucose variability has become a big deal in improving mortality. So I think if we can improve glucose variability, our long-term data will be very, very helpful.
Dr. Renu, I have a question. In adolescent girls, they have a lot of
I think we can.
menstrual cycle. So during
we are running short of the time. We can.
Even when they attain menarche. So is that an indication for pumps and type 1 diabetics? And plus Romagai phenomena, because with basal bolus, sometimes you can pick up that 60, 70 or 80 in the middle of the night, but they get up with a very high sugar in spite of correcting the hypoglycemia. I think
the pump will be a great thing for them because you can almost lower the basal rate during the nighttime and increase the basal during the daytime. And the Minarche time, you can actually put a temporary basal for 3 days, and they need higher or lower dose, you can adjust that. Pump is a great thing for type 1 teenager patients with Minarche time. Absolutely.
Ashok, just 1 minute.
Thank you, Doctor.
Ashok, the national pride for us, that India is the first country in the world to approve LibraPro in the 2015. That's a national pride for us. We first in the world approved LibraPro for 14-day use in our country. Thank you. Sorry, Ashok, I took time.
No. I think Dr. Renu Joshi, you have done a wonderful job and full explanation of it today. What are the newer technologies? Because of the short of the time, otherwise we would have loved to listen more from you. But because the short of time, thank you very much on behalf of the all RSSDI team. Thank you very much.
Thank you. Thank
Dr.
you, madam.
J.K. Sharma.
Thank you. Thank you. Yeah. Over to Dr. J.K.
Yes, Dr. Sengupta.
Yeah.
Please proceed further.
Thank you, sir, for a very wonderful lecture. We come to the last lecture of the day, which would be by Dr. K. Sethu Reddy, who will be dwelling on artificial intelligence in diabetes management, for which I may invite the two chairpersons, both stalwarts of the Delhi RSSDI chapter, Dr. Rajiv Chawla, who's a DNB teacher and guide for the last 20 years, more than 70 papers on micro and macrovascular complications, awarded the AAC travel grant twice for masterclass paper, 10 orations awarded, past chairman of the RSSDI Delhi chapter, past secretary of the RSSDI national body and organizing secretary annual conference RSSDI 2006 and 13, scientific chair RSSDI 2018 and scientific chair 10th World Congress of Diabetes and Diabetes India 2017, executive editor, International Journal of Diabetes in Developing Countries, President DIPSI 2019 and immediate past president of the RSSD National Chapter 2018 and 19. Second chairperson is Dr. Rajesh Maria, who is a teaching faculty for a certificate course in evidence-based management, diabetes management, and certificate course in gestational diabetes, advanced certificate course in prevention and management of diabetes and cardiovascular disease, and a national diabetes educator program. Has been awarded the Dr. D.K. Pal Memorial Oration at the 28th Annual Convention 2008 of the IMS South Delhi branch, Chairman's Oration at the 13th RSSDI Delhi Chapter Annual Conference 2017, and Speaker and Chairperson in several national and international conferences. Paper published in national and international journals, chapter written in the RSSDI Update 2018 and Emergencies in Diabetes and Endocrine Disease and a Handbook of Geriatric Care 2019. Actively participated in investigated in several studies and certification of received various certifications like Introduction to Diabetes Care from the University of Newcastle, Australia, Practical Diabetology from the Steno Diabetes Center, Denmark, from research to clinical practice from the Justin Diabetes Center, Boston, and a certified program in clinical diabetology from the Harvard Medical School. I ask the chairpersons to carry the session forward, please.
Thank you, Dr. Sen Gupta, for those kind words. Thanks, Dr. JK, Dr. Meena, and the entire organizing team of RSSD Delhi chapter for this opportunity. With that, we come to the penultimate, the last, but possibly one of the most important topic, which could have been, I think it is because of the time zone that we have having Dr. Siddhi Reddy towards the end. Otherwise, it could have been one of the first topics, which is very, very relevant today. We all know type 2 diabetes being a chronic metabolic disorder. Not only it ends up with the neuropathy, but retinopathy and PVD and many more complications, which could put a lot of burden on the overall medical fraternity and many times could be fatal also. And there cannot be a better scenario of usage of AI, artificial intelligence or technology, what Dr. Renu just talked about in diabetes than the current scenario of diabetes and COVID, which we are unfortunately on, where the relevance of sensors, AIs, mobile apps, overall that mobile computing has become very, very important in clinical practice for all of us, starting from maybe virtual clinic, then maybe talking about those fundal cameras, mobile apps where you can actually screen for diabetic retinopathy, and many more things to not only avoid morbidity, mortality, but also to get good glycemic control. And I'm sure Professor Setu Reddy, who is one of the most learned, one of the most celebrated endocrinologists from this country settled in US, he's a personal friend to Dr. J.K. Sharma, has been a co-faculty in number of conferences which we have attended. I think he remembers once we were together at Jocelyn meeting in Dubai last year. And he's a professor and chair of discipline of medicine, Central Michigan University College of Medicine. He's currently vice president of ACE. It sits on the advisory board and the uh, faculty board for AAC board. His prior positions have been chief of adult diabetes at Joslin Diabetes Center, Harvard, has been vice president USA for medical affairs at Mark Sharp and Dome, chairman of endo, diabetes and metabolism at Cleveland Clinic also. And he is, of course, 9080 batch MD from Canada, 9085 FRCP in endocrinology and metabolism, and 95 to 98 research fellowship, which he did in cellular and molecular physiology at Harvard Medical School. It is just the least we can say about Professor Setu Reddy. I think he hardly requires any introduction to a national or to a international audience. Professor Setu Reddy, this is for you for another 30 minutes.
Thank you, Dr. Chawla. Hope you can hear me and see my slides.
Yeah.
And pleasure again. And I'd like to thank Dr. Sharma and the organizing committee for this kind invitation. It's always with trepidation I accept the opportunity to talk to an Indian audience, because it's one of the few places in the world where the audience knows more than the speaker. So it's always a challenge. And today, I'm not going to talk about so much about past, but looking forward. To paraphrase Robert F. Kennedy, he said, some of us dream or see things as they are and ask why. And some of us dream as things could be and ask why not. So this really will be more of a futuristic landscape of how we will eventually practice diabetes throughout the world. I'm also pleased that many of the faculty have quoted Sir William Osler, who was obviously perhaps the most influential physician of the last century from Canada, professor at McGill as well as at Johns Hopkins. So let's get started on artificial intelligence. We just published a chapter on artificial intelligence and digital tools in diabetes care in an issue of Clinics in Geriatric Medicine just this past summer with my colleague, Dr. Ram Sriram, who's an artificial intelligence expert formerly of MIT. Objectives are in the next 20 minutes is to explain the evolution of artificial intelligence, understand diabetes mellitus and the variety of the vast amount of associated data generated by our patients, and recognize some recent examples of how AI could play a role in evaluation and management of diabetes. Now, before we talk about medicine, we should go back, and I'm sure many of you have visited the Walt Disney, Disneyland, Disney World. And Walt Disney dreamed back in 1966 of Epcot, and you probably visited the Epcot, but sometimes we forget that Epcot stood for Experimental Prototype Community of Tomorrow. And Walt Disney dreamed of a community where every house was a hospital. Every bed was like a hospital bed. The society members would be connected to a medical system, and really futuristic looking. Now, only recently, our friends in Japan have actually brought it to almost full reality. So they have a city near the foot of Mount Fujiyama, which is essentially a smart city. The homes are smart, the cars are smart, all the data that's collected is integrated, etc. So this is coming around the corner very quickly. Now for diabetes, the challenge is that the number of people with diabetes is exploding as we speak, and you're all aware of that. And at the same time, we don't have as many physicians. So now with the number of people with diabetes, each individual with diabetes here in the US is thought to generate vast amounts of data. Over 1 million gigabytes of health-related data in their lifetime, which is equal to 300 million books as we know them today. And currently the problem is that 80% of the health data is unstructured. It's very disparate, stored in various places, not accessible easily to the healthcare provider. And much of the individual's health outcomes may be related to genomic data or environmental data, which again, we don't have access to. Speaking of the physician workforce, in 2011, already there was a need for 1,000 additional endocrinologists. And we know that telemedicine is well accepted by type 1 patients. And the question of, do we as diabetologists or endocrinologists, how can we possibly look after millions and millions of people practicing medicine the old-fashioned way, face-to-face, and clinical appointments in our office? So this is where artificial intelligence comes in. What is AI? I think we all know what intelligence means, but artificial intelligence has been defined by Bowden years ago as the ability to make computers do things that would require intelligence if done by humans. It's a very simple definition, but it does get more complicated. Artificial intelligence also implies deep neural learning. And neural learning is not designed by humans. In other words, this is unsupervised learning. Very much like IBM Watson could learn all the past chess games, watch how the other player plays, and learn the techniques of defeating the opponent from that experience. And Watson essentially learned how to do that on its own. And a key component, of course, of driverless autonomous car technology, as you've seen in Tesla and so on, is artificial intelligence. Now, many of you are probably using artificial intelligence, but not realizing that you're using it in your daily lives. So if you're using Google Nest or Amazon Alexa to turn on your car, turn on the lights in your house, etc., speech recognition, you're using artificial intelligence. Some of the terms in artificial intelligence, especially related to diabetes, rule-based learning. So we as diabetologists often say, well, if the glucose is low, then we must do something. Or if the glucose is high, then we must do some action. Or fuzzy logic. How can we make sure that the computer does the most appropriate thing and not necessarily be so rigid? So for example, if our patient has a blood sugar of, if less than 10.1 is good and greater than 10.0 is bad, what is 10.1? So the computer then has to make a judgment call as to what's an appropriate intervention. Many of the professors that have spoken today have talked about essentially how they practice and how they approach clinical care. And we all operate by these rules of thumb, heuristic approaches that we learn from our professors and our professors' professors. How can we train computer systems to learn those rules of thumb that really comes after 20, 30, 40 years of experience? And machine learning, we've talked about decision tree, very important for classification problems such as, for example, which type of diabetes a patient might have. So a sample neural network, here you see the input layer, and each blue circle would depict a neuron. And that neuron is then connected to every other neuron in the second layer. And the convoluted neural networks that I will talk about, there are at least maybe 7 to 8 layers of these hidden layers of neurons that are all interconnected. So the input layer, the data, comes in, and each neuron then analyzes the input from all the other neurons, and then processes it and eventually gives output. So for example, if you have a fundoscopic image on the left, after all this computation, the computer may tell us whether the patient has no diabetic retinopathy or whatever the grade of retinopathy might be. So here is a fundoscopic image, and again through the cartoon here, how it's each neuron might look at a different zone of the retina. And collectively, all this is processed, and again, the grading is made. This is so-called convolutional neural network. It is used for many imaging type of analysis. Fundoscopy would be one, but dermatology, looking at moles, malignancy, mammogram or mammography data, and of course, reading radiographic images such as chest x-rays and so on as well. Now, here's an example of AI thinking. This is a paper from the United Kingdom, and I must just give an editorial comment here that there is the Indian diaspora of scientists and physicians from India working throughout the world. And when you do look at review the literature, you'll see that many of the authors are from India originally. So here's a paper from London, and explaining, I think, how AI could be important. So if you look at panel A, you see that this is a graph of hemoglobin A1C levels, age, and the chances of admission to a hospital. So the prediction model of whether that patient will be admitted to the hospital. The pink area is considered high risk, and the lighter area is considered low risk. And that's what we would, as human beings, would come up with. The higher the A1C, and maybe some other factors, they were more likely to be admitted. But artificial intelligence, looking at the same data and analyzing it for hidden relationships, not things that we would normally think about in our daily practice or from our foundation of knowledge. Artificial intelligence suggests that there are people here, and you can see in the lower part of panel B, those with the low A1C that are also at high risk of admission. So this really gives us a much more granular and nuanced interpretation of the data, and may be very useful for us to actually more accurate prediction of what's going to happen to our patients. Now, the relationship to retinal imaging and analysis, et cetera, here's an example. So you have a picture of a sunflower and essentially a bevy of sunflowers throughout somebody's garden. Now, artificial intelligence can take a look at just one zone, not even the flower, but a zone, and analyze it. And based on the colors, the pigments, etc., will make the prediction that this is a sunflower bed. And again, much more than what we would be able to tell from looking at a small point of the, or a small pixel of the image. So the application remains for AI. Hello? Could be automated retinal screening, clinical decision support for all of us, population health, as we all, as endocrinologists and diabetologists, move into not individual management, but population management, predictive population risk stratification, and patient self-management tools. Recent advances, Dr. Joshi did a great job of looking at reviewing the new technology, and that is helping the individual patient. But the next step is, how do we compile not just the glucose data, but their socio-demographic data, their eating habits, their physical activity data, et cetera. Put that all into a system and make a prediction of what's best to do for the patient. So a bolus calculator algorithm has been developed using AI in London. Closed loop systems are based on fuzzy logic, and then guidelines. So guidelines are good and bad in that sometimes they're seen as very rigid, that if you don't follow the guideline, you're not doing a proper job. But individuals are individuals, and they don't necessarily fit neatly into any discrete bucket. So there has been a study where how can a computer or AI interpret the guidelines as relevant to the patient situation, and retinopathy detection we talked about. So some of the methods in AI include, I'll just highlight them on the left here, the method, how it works, strengths, limitations, etc. And multi-layer perception, so I mentioned those, convolutional neural network, random forest, and this is a kind of a pun, so to speak, because you have these number of decision trees based on each bit of data. And then how do you look at the forest for the trees, so to speak? Fuzzy logic, support vector machine, logistic regression, which we are all quite familiar with, natural language processing. This is the next phase of electronic medical records. So that instead of filling out discrete fields in EMRs, and as you know, the current EMRs are very cumbersome, natural language processing, so that you can imagine that as you speak to the patient, the computer will understand what's going on and what to order, etc. And they'll understand the way we speak and write rather than discrete kind of computer language. So these are some of the methodologies that AI is incorporating to, as you see on the right in bold, obviously retinal screening, decision support, and prediction models is going to be a very important tool when we are talking about artificial pancreas, as well as other aspects of diabetes, holistic diabetes management. So here's an example of retinal imaging and AI. The top panel A on the right, you can see a normal fundus photograph on the left, someone with diabetic retinopathy on the right. On panel B, you see the various grades of diabetic retinopathy. As you know, most clinical trials look at what are the two-step progression in diabetic retinopathy as a clinical outcome. And again, AI has been used to really not only grade, but predict what's going to happen with the retinopathy. And the convolutional neural network, CNN, you see on panel C, where the data from the retina are processed through these various layers of neuronal networks, virtual neural networks, and then you end up with the final result. And here's an example of prediction of diabetic retinopathy in several patients based on the initial baseline fundus photograph 6 months earlier. Now, what's exciting to me is when I read this particular paper in biomedical engineering from Nature. So artificial intelligence can look at a fundus photograph, and because of this deep learning, can actually predict the patient's blood pressure and potentially the risk for that patient to develop cardiovascular disease. So indeed, the eye, in fact, may be the window not only to our soul, but to what's happening in all of our body. So again, we as clinicians can look at a fundus and we're looking for hemorrhages, aneurysms, et cetera. And whereas the AI is looking at the imaging data beyond what we have learned as clinicians, and thus be able to see relationships that were never thought of before. Dr. Joshi presented CGM data quite extensively. I won't belabor the point here, but the amount of data coming to us is just phenomenal. And we're still at the very early stages of understanding the data and the excursions in glucose metabolism. We're still not able to completely integrate dietary habits, exact types of food, activity, moods, psychological situations, et cetera, into the variability of glucose excursions. Here's an example of a threshold-based insulin pump interruption for reduction of hypoglycemia. And this, you can see that during the time that the pump was able to suspend insulin, they're able to prevent hypoglycemia very nicely, and certainly has become incorporated into some of the pump technology now as we speak. Now, this will be done in graded steps. I think the technology is there to go essentially a closed loop system today. But I think the developers are quite anxious that they want to do this very gradually and go through the regulatory process, the FDA and the governments, so that it'll be safe. What you do not want to see happen is one individual develop a major hypoglycemic accident, and that can put the whole program behind by many years. So what's happening with diabetes as we move forward? We've talked about CGM glucose technology. We've talked about Fitbits, people monitoring their with their smartwatches, pulse, blood pressure, amount of sleep they're getting. There's also talk of blood pressure monitors as well. We know that. Smart contact lenses that can also measure glucose on a continuous basis. We have the artificial pancreas we talked about, socks and shoes that are smart, that have embedded computer chips that will actually tell the truth about how active we are. So when our patients tell us that they walk 3 miles a day, well, the shoes will tell us maybe otherwise. Unless, of course, they give the shoes to their son or daughter and they use them during their exercise body weight. Beyond this, I think we'll also see data from their whereabouts. Where are they spending their time? Are they spending time in restaurants or in fitness centers? Are they spending time with family and friends, or are they isolated socially, etc.? So this amount of data then gives us this defining a health persona. So I think one of the faculty members earlier quoted Sir William Osler saying, "We must know the patient." Well, here's an opportunity that we can know the whole patient and not just the glucose levels, cholesterol levels, and the blood pressure levels. So all this data then will come to us. And of course, we are not going to have the capability of understanding all of that data, nor the time. And this is where we're going to have to rely on artificial intelligence to help us, to be a tool. So there's always a fear amongst physicians that AI will replace us. And I don't think that will happen. AI is going to be a tool that we will incorporate into our practice. So a patient comes, collects data, we analyze the data, we review the data, hopefully with the help of computer systems and artificial intelligence, and then we, as clinicians, individualize the care and make the proper clinical recommendations. So again, I want to thank the RSSDI from DC for this kind invitation. Hopefully in a short time, we've covered, I think I'm on time, we've covered AI and the potential role it could play in our future management of diabetes. And look forward to any questions or comments that our friends may have. Thank you.
I think thank you, Dr. Reddy, for explaining a very, very complex topic in a simplified manner for us novices, because we as doctors are not very much in tune with these kind of technical things. But yes, definitely, you're right. Artificial intelligence is coming in a big way in various fields, and now in diabetes also, as you very nicely explained about the ophthalmoscopy, the continuous glucose monitoring, and the stopping of insulin injection, and all those things. And mind you, 2-3 days back, in our country, our Prime Minister declared that the India is going to be an artificial intelligence hub. He's giving a great push for that, and hopefully we should be doing better than that. Thank you very much once again for very nicely explaining everything. If there are any questions,
good morning, Dr. Setu.
In the chat box? Not really. Okay.
Morning, Dr. Setu.
I have one comment to ask. Can I? Sorry, I think Rajiv, you are speaking after.
Yeah. No, please, sir.
I think
I was just checking whether there is any question in chat box.
Dr. Chawla, can I have a question?
Yeah. After Dr. Das. Yeah.
Beautiful lecture, because you made matter very simple. Dr. Maria, as you rightly said, what is one of the things that caught many people's attention here? We want to diagnose the pre. We know the pre-diabetes. If we know pre-diabetes can prevent diabetes. If we know the pre-retinopathy, in the whatever microaneurysm stage or microalbuminuria stage or whatever stage or capillary leak stage of the retinopathy, we can give better. Am I clear, Professor Reddy?
Yes. Yeah.
So I think that's the greatest benefit from the AI, Dr. Maria, that we can say that what is going to happen to the heart, capillaries in the heart. You rightly showed that intake, the window to the heart or to the kidney or to brain, whatever it is, the window to the tissue damage of diabetes. This will be great benefit. And India being the forefront of computing, maybe it will be one of our greatest assets. Thank you very much for giving us such a great.
Very exciting what he said, that eye could be used as a window of opportunity to look into the overall vascular health. We never knew that from eye you can pick up an early diagnosis of cardiovascular risk, or maybe long-term cardiovascular mortality could be predicted. And another CNN model which he suggested that with AI you can predict that this patient will have an outcome like that. So based on that you can advise hospitalization. You can step up care for that particular patient, and based on collection of data, analysis of data, you can go back and then do sort of precision medicine based on the information from that.
I think it was always wondering Setu, that there are few diabetics, in spite of everything, they go scot-free. Some diabetes get into complications. So I think what Rajiv said into that only, that if we can identify where we can focus. Fantastic, good comment. Thank you.
Dr. Setu, good morning.
Please,
good morning. Good to see you after a long time. So, important thing is we are getting a lot of now tools also based on AI which are helpful for diabetes patients. US particularly being an advanced country and a lot of people becoming very friendly with different AI based tools. How good is the uptake of these tools for managing diabetes at patient care level in US? India, it is very poor. People are not using many apps or using feeding data into the apps and connecting with the physicians through the apps. But how is the situation in US?
Thank you, Dr. Makar. You said the US is an advanced country, but I beg to differ. We're not advanced in many other regards. We're not advanced. But with respect to apps, I reviewed this recently, and there are apps arriving every week. And many of them are not validated by diabetologists or endocrinologists, and they're not properly tested. So the patient doesn't know which one is reliable, which one is not. Our industry partners have a lot of apps as well, and some of them are very useful, but they're very product centric. So I think it's still in its infancy stages. I think the apps are going to have to be, they're very select. Some are very good for adherence, like a reminder system to take your medication. Some are, they have other functions. I have people that have an app that does what the pump does. Basically enter their activity and blood sugar, and it will calculate the bolus, etc., so mimicking what the pump would be doing. So I think it's right now it's worse than looking for a car. There are so many models, so many particular attributes. I think you have to individualize. I would suggest that as physicians, we should get familiar with maybe 10 or 15 apps that you're happy with, and I would recommend those to our patients. And I would, ourselves, we should probably use the apps so that we have some comfort level, or have your educators use them. And it's always good to recommend from experience than from reading an article or reading some.
No, I totally agree with you, but important thing is, once you are friendly with the apps, you advise these apps to the patients. My question is, how good is the uptake by the patients?
The persistence is very important. So just like pumps, when insulin pumps were first developed and introduced, it was very much like in America, we have this tradition of Christmas gifts. So you use the gift for 2 weeks, 3 weeks after Christmas, and then afterwards you put it away, you forget about it. So there's a big uptake in technology, first 6 months to a year, And afterwards, people get tired and they're looking for something else, novel or something different. So I think it's very important, just like medication adherence, that how can the app keep the patient engaged? And that's a very important attribute.
I think of late the acceptance of app is increasing. Most of us have been part of various studies. We endorsed actually that Wealthy app by RSSDI after validation on certain datas and all that. And we have had, I think, close to 10 publication over last 3-4 years in ATTD, ADA, and ACE also. That not only outcomes in terms of glycemic reduction, the compliance improves, the time in range also improves, and you get, as you rightly said, in lifetime you have something close to 300 million books written by on overall data points of a diabetic. So I think you collect huge information in terms of data points which you can then incorporate into the management of the patient, and in long run that could be possibly the way forward for at least for those patients who are type 1, those who are on pumps. Like Dr. Renu very rightly said, 20 years ago no one knew that there will be artificial pancreas model also getting through in our lifetime. So everything has almost become a reality. We are almost close to a closed loop system being practical for the patient use, not only in theory or not only in research trials. With retina images, I think that is almost a norm these days. India also, we have close to 40-50 centers working through mobile apps or through those distant fundal cameras, and then transporting or transferring those images through iCloud, and then getting back the information, avoiding those unnecessary visits to retina specialists and all that. So I think, and you very rightly said that physical check on your feet through those apps, whether you are actually walking or no. And I'm sure down the line, 10 years, you never know, you have a app sensing your brain or your mind or your heart also, whether you're going to stay or no. Physically, you're already keeping a check through those apps. So I think apps are going to stay and going to be a reality.
You know, like any weapon, there's always a double-edged sword. So
Very true.
there are very huge problems about privacy, sharing, etc. And I think in the future, the patient will have to give permission anytime their data is shared with anybody. And one can't.
That is true. That is the basic ethics and norms. Yeah.
I think this
Yeah.
acceptance is coming. We have 2 questions in the chat box for Dr. Reddy.
Yeah.
One is from Dr. Shilpa Bhatia. Sir, can we please have suggested reading slide again? Dr. Reddy, please show the slide with suggested reading material. What if one is maneuvered wrong initially? Whole AI structure falls.
Yeah, I will send.
You can open the chat box. You have got 2 questions.
Yeah.
One is by Dr. Shilpa Bhatia, another is by Dr. Renu Joshi.
Oh, sorry.
Click on the chat box.
Dr. Maria, I will send a PDF of the slides to Dr. Sharma, and he'll be able to share them with anybody who requests. And let me go to the chat box. And what do you see here?
It's already open. Someone asking, can you
Dr.
suggest?
Renu, you can unmute and ask yourself. Dr. Renu Joshi, your question. You can unmute and ask.
No, I was just saying, Dr. Reddy, for the faculty benefit, it'll be nice to provide the 10 to 15 good apps you were suggesting. So all of us can be on the same page.
I'll get a list to Dr. Sharma, and we can.
I'll share with all the faculty. I'll share.
Great.
So if you don't have any more question, I think we can close this session and hand it over to Dr. J.K. Sharma for further processing. And thanks a lot, Dr. Setu Reddy. Wonderful being with you on this session. Really very, very enlightening session. Thank you very much.
Thank you, Dr. Reddy. Thank you, Dr. Chawla, and Dr. JK and the whole team, Dr. Meena Chhabra. That was a wonderful conference, and we enjoyed it from the comfort of our own rooms. That was the best part.
Yeah.
And we could relax when we wanted to also. Wonderful.
Girish, you were found sleeping.
Thank
Yeah.
you, Dr. Chawla,
JK,
Dr. Maria.
I enjoyed the talk of Dr. Reddy. It was really wonderful.
Yeah.
And,
So, as Dr. Maria said, you can relax while listening.
Yeah.
so,
Yeah, JK. Yeah.
anyway, thank you, Dr. Chawla. Thank you, Dr. Maria, for chairing this important session. And my special thanks to Dr. Setu Reddy and Dr. Renu Joshi for accepting our invitation and delivering their excellent talk at this early hour from Sat Samudra Par.
Yeah. Must be just 4-5 a.m. in the morning only to both of you, Dr. Joshi and Dr. Setu. Yeah.
So I'm extremely thankful, and I'm extremely thankful to Dr. A.K. Das sir.
Thank you, sir.
And
Thank you.
all other speakers and chairpersons, and my special thanks to our friend Dr. Vijay Arora, which I could see only just now.
Good.
So now we will be having our valedictory function. So to conduct the valedictory function, may I request Dr. Meena Chavda to be alert, Dr. Sen Gupta, he is the treasurer, and myself. So Dr. Meena, please extend your thanks to all you want to.
No, not. I want to thank each and every speaker from the bottom of my heart, particularly our speakers who've tuned in from the United States, because it was the crack of dawn that you both got up. And we're extremely sorry the session was running late by almost 40 minutes. So please accept my apologies, and awesome talks, both of you. And we would like to invite you even in the future to be connected with RSSDI. And I'm sure we can have international members also. So you could become members of the Research Society for the Study of
Dr. Setu is already a member, I think.
I
Dr.
think
Setu is the
Renu
RSSDI member. Yeah.
So Dr. Renu just expressed a desire to be a member of the RSSDI. Thank you so much, both of you. And I thank all the speakers, all excellent deliberations by all of them. And I also thank Dr. J.K. Sharma, my secretary, Dr. Shalini Jaggi, I can't see her, the joint secretary, Dr. Sen Gupta, all the other EC members, and of course our patrons and our gurus. Dr. Makkar is right here, Dr. Chawla. Thank you so much. And a very big thank you to Professor Das. You always are guru. Thank you so much.
I must tell you,
you are our guiding light. Shalini
Das sir is Guru's Guru. Sabke Guru.
Dr. Meena and Dr. JK and all the people.
So Girish, thank you so much. Vipul is not here, all the EC members. And I hope to meet all of you again, because now that we are virtually connected, so we can actually share scientific knowledge at the click of a button, which is awesome. And thank you, Dr. Setu Reddy and Dr. Renu, for sharing your data with us. Thank you so much.
Thank you very much.
On behalf of the faculty, not as the patronate, not as faculty, I must tell you that it has been a veritably great, delightful experience. I heard about 5 talks from the last, and I must tell you that they were really, really good. Take a nutrition talk, Setu. I mean, it was so good. Every talk, the talk by Renu, talk by Setu, and it has been marvelous. You had less number of topics, not crowded. You have time for discussion. That is one of the best things, JK and Meena, that you have done. And number 3, I must tell you that you have chosen the practical things, starting with Anup's COVID to Setu's AI. So it is a very practical topic, which will be day-to-day very useful. And I'm extremely happy to be here on behalf of all the faculty, Indian faculty, and we are all faculty together, Renu and Setu and all of us. We convey our very sincere thanks, gratitude for having invited us. And we really, really enjoyed the meeting, the conference, and more such things to come. And grateful to you.
Thank you very much.
Thank you.
And we thank to our industry partners, AstraZeneca, Lilly, Sun, Boehringer, MST, and USP, without whose support it would not have been possible. So thank you, everyone. And now I request all the RSSDI members to please stay for the general body meeting which we have. Can we start the general body meeting in 5 minutes time?
Yes, 10 minutes.
10 minutes.
Thank you. Bye-bye.
Bye-bye.
Thank you.
Very much, Dr.
Good
Setu.
seeing
Thank
you,
very
Dr.
much.
Setu.
Thank you. Bye-bye.
Rajesh?
Why do you need to wait for 10 minutes? I mean,
I know we can finish. We can.
Let's start, yeah.
But I think virtual we can have JK, but virtually we can have this this liberty of starting immediately.
All right, sir. Rajesh, can you unmute the other people?
डॉक्टर चावला आप खाना खाए हो, हम नहीं गए ना चाय पी।
10 मिनट और नहीं खाओगे, थोड़ा इंटरमिटेंट फास्टिंग हो जाएगी।
नहीं, I don't need it. Sir, I've lost weight during the lockdown. I'm becoming sarcopenic.
एक और खाना।
Sarcopenic obesity.